like to and dear participants, we welcome you to day 2 of the day 2 of the International Conference on Innovations in Health Information Technology in LMICs, being held here at Policy Perspective and Global Health Learning. Today, we continue this journey with a day full of insightful sessions and transformational ideas with international expertise. We thank all our partners, sponsors, academic collaborators, healthcare institutions whose support has made this conference possible.
Before we begin our technical session, we are honored to invite our distinguished national public health leader whose contribution continue to shape India's surveillance and outbreak response system. We welcome Dr. Himanshu Chauhan, Additional Director, National Center for Disease Control, Ministry of Health and Family Welfare, who will be joining us online. Dr. Chauhan's work focuses on strengthening India's integrated digital disease surveillance program, leading outbreak investigation and rapid response, scaling digital platforms such as IHIP across states, and advancing data-driven approaches for public health preparedness. His leadership has been pivotal in enhancing the country's surveillance architecture and digital integration for real-time decision-making. Sir, may we privileged to have you with us virtually. We kindly request you to address the audience. Sir, are we audible? Sir? Hello, sir. Hello, sir. Are we audible?
Good morning.
Good morning, sir.
Yes, you are audible now.
Okay. So, sir, we request you to, are we audible from the starting, or you missed the starting part?
I'm still not able to get the audio very clearly. So
Okay. Sir, now are we audible?
Yes, it's much better now. Much better.
Sure. So we request you to kindly request you to address the audience.
All right. Thank you very much. So I'd like to thank the organizers for giving me this opportunity to share my views on the use of digital technology in disease surveillance. And I also apologize that I could not be there in person to join this event, which is so very closely related to what we are doing in disease surveillance at the Government of India right now. But and there are priorities and there are reasons why I could not make it in person, especially the Parliament being in session. So I'd like to briefly talk about the use of technology in disease surveillance as to how we have evolved over the last 4 or 5 years, and probably the way in which we are proceeding. So we know that India, being a huge country, both in terms of the the size of the country, the population, and the diversity that we have, the different systems across the country, federal being a federal structure. So the states and the country, they have, and health particularly being a state subject, it is driven by different systems and different priorities. However, we are aligned when it comes to certain deliverables like disease surveillance and our preparedness for epidemics, our preparedness for outbreak-prone diseases. So that's the mandate that the Integrated Disease Surveillance Program has been given, to be able to detect early warning signals of impending outbreaks before they become outbreaks, and to be able to respond to them timely, so that loss of lives and mortality and morbidity, as we say, are both prevented. So this was a system which was in place. The Integrated Disease Surveillance Program was launched in 2004. So it's a 21-year-old program now, and it has a rich history of responding to major challenges that the country has faced in the past. To name a few, obviously COVID-19, everybody is well aware of how the country dealt with COVID-19. It was an example for the globe. And the other diseases that we usually deal with, some of them have been, I would recall the threat of pandemic influenza when it came in, and bird flu outbreaks that we have repeatedly seen, the threat of ever looming threat of a new influenza pandemic sweeping, being prepared for it, the threat of diseases like Nipah, threat like SARS, when it developed, we were fully prepared to deal with it. So how does such a system work, and what are the mechanisms that have been put in place? So we look at a system which collects data from multiple points. Speaking roughly, the number would be some 250,000 plus units across the country, as we refer to them as surveillance reporting units. So the data from these units being collected, compiled, and then reported onto a platform. That was the system that we had before 2021. In 2021, we migrated to a system which is electronic, real-time, case-based, and which has all the advantages that a digital platform brings in, namely auto-analyzed reports, dashboards, analysis that can help monitor the trends on a real-time basis, and to pick up the warning signals early. To add on to that, we also were supported by the AI team of the Ministry of Health and Family Welfare. AI Wadhwani was one important partner in developing that. So using the tools of AI to detect events which could be the earliest signals of an impending outbreak anywhere in the country. So this system that we refer to as the Integrated Health Information Platform. So that platform was launched in 2021, and to be able to migrate the entire country, it was a huge task. I would like to put on record my appreciation and gratitude for all the states and the districts and the 250,000 plus reporting units which supported this migration in letter and spirit. And we could bring on a system which is now offered to the globe as an example of a digital public good. And India has been, in its diplomatic endeavors, open to offer this technology, this platform, to other countries which are desirous of setting up this system in their own jurisdictions. The beauty of the system is that there is no need for an intermediary level to enter the data. So the data is captured, the data related to early warning signals is captured at the point where it is generated. So there's an ANM who goes out into the field, and she comes across a few cases in a village, which may be the earliest signal of an outbreak which is brewing somewhere. She captures the data there itself in the handheld devices, tablets that have been provided to her. And she enters the data from there itself. So that's the point, that the data is captured, and since it's real time, it is immediately transmitted to the national servers. And the dashboard, the system is so organized that if it's really something unusual, there's an immediate alert which is generated, which alerts the district surveillance units and the state surveillance units that such an event is happening somewhere in even a remote part of the country. So add on to that, this is the syndromic surveillance that I am referring to, wherein the actual health system reaches out to the population. If we look at our health facilities and laboratories, so they all deal with infectious diseases cases on a daily basis. And when they capture and report this data on the same day on the electronic platform, the HIP, we get to know what are the positivities which are coming. Let's say, for instance, if we talk about influenza right now. So we are entering into the influenza season, and we look at all the cases which have been tested for influenza and the ones which have come positive. So we immediately get a profile of, on a day-to-day basis, we can monitor at the district level, at the block level, and even at a PSC level as to what is the trend of influenza-like illness, what is the trend of severe acute respiratory illness, how many cases are being tested positive for influenza and other respiratory pathogens. So we get a clue. When I say we, I refer to the state systems as well as the national level systems, which are mandated with monitoring these trends. And we are immediately alerted if there is any change in the trend. So a slightest upward tick would be caught by the system, and alerts would be auto-generated the moment it crosses a certain pre-decided threshold that we are now entering into a phase where probably we may see a continued transmission, and therefore all the measures that need to be put in place are activated immediately. So this system has changed the way that we look at surveillance and our response mechanisms, and therefore our preparedness for epidemics and pandemics in the future. To add on to this, we also have recently launched the community reporting tool. The community reporting tool is also an attempt to capitalize on the digital penetration, the use of mobile phone technology, smartphones especially, into the remotest corners of the country, wherein the citizens themselves, they become eyes and ears of the surveillance system. And they have a very simple way of picking up whatever is happening around them, which could be an early warning signal of an outbreak. If there's water accumulation, it could lead to mosquito breeding and the outbreak of vector-borne diseases. If there's breach in safe water supply, then we could see diarrheal diseases, we could see food poisoning incidents happening. So all this, because the community is the first level at which these effects, these signals are usually perceived and felt, they can be immediately picked up by the community itself and reported onto the platform. The moment it is reported by a handheld device like a smartphone, a simple QR code that is scanned, and a check that it's actually a person who is reporting in the form of authentication through an OTP, we immediately get the signal is transmitted in the form of an event alert to both the district surveillance units and also visible at the national level. So that way, the true spirit of engaging with the community and amplifying our sensitivity multifold by making community as the partner, we have now entered into that domain where the chances of missing any early warning signal across the country, they are minimal. So we have undertaken a massive dissemination drive so that the community is aware that there is such a platform that exists. And all these are in sync with each other. So the data that is flowing in from the hundreds and thousands of reporting units, the AI tool which is crawling the media reports which have been picked up, and the community itself reporting. So by these mechanisms, these three systems working independently of each other, yet ultimately leading to a common platform where all this information is collated and it's analyzed. And therefore, the larger picture of are we ready? Are we looking at any potential sign of an early outbreak? This is very well captured, and it's increasingly being utilized, being used by policymakers, decision makers, administrators across the country to be able to monitor the trends of diseases, especially outbreak-prone diseases, and to divert resources where they are most required. That's the ultimate essence of this system, that resources always being limited, we need to be able to judiciously use them and to divert those resources to a place where they are maximally in need. So this kind of a system, it has taken some time, around 3-4 years, and Bihar in particular, where the event is happening, I remember when it was launched, it was perceived as a challenge that how do we implement this digital revolution, if I could say, in states like Bihar, where population and other factors, historically it has been viewed that the surveillance systems and the public health infrastructure over there might pose challenges. But Bihar has taken a lead in this, and I congratulate the state surveillance unit and all the district surveillance units and the myriad of workforce, public health workforce, which is connected to the system. And Bihar has consistently featured in the top performing states. So I congratulate the leadership over there for this feat, which is no minor feat in any ways. So the technology exists. Where do we take it? What additionalities can we add on to that? With this kind of data flowing in, if I look at the records, millions of records are generated on a weekly basis. And being a case-based system, the data is verifiable. It is clean data, as we say in epidemiological terms. So that data, over a period of time, if it can be utilized for predicting the outbreaks before they happen, that's the future direction that we are looking at. So with that kind of data that we have in our system, this can be utilized by groups which are engaged into mathematical modeling, predictive analysis, using the technology that we have right now. AI, use of AI tools is a very good example. So looking at all those variables that are captured with that data, if those variables could be plotted, if they could be used, and we could have predictive models. So imagine a situation where we are able to pick up the early warning signals even before they emerge, going by the emergence of these signals across the geography. And we are able to say that now is the time when possibly a dengue outbreak might happen. Even before the first case of dengue comes in, we would be able to say that the conditions exist where a dengue outbreak is a possibility. So that's one example. We can look at multiple diseases, we can look at multiple partnerships, and we are exploring partnerships with institutes and agencies who have expertise in this area, and who can be partners with the government to make that change, to make that dent in the outbreak situation in the country. So those are few thoughts that I felt are appropriate to share with this forum. And we have a long way to go. We have just made a beginning in this arena, but the beginning itself has been very impressive. It has been well appreciated by all, including the leadership in the ministry and the partners. Globally, we have had visitors from various parts of the world, and the system has been well appreciated by anybody who's seen it. So I rest my thoughts here, and I wish the organizers all the very best. I hope there would be partnerships emerging from this discussion, and we look forward to interested partners and parties who could join hands with us in this endeavor. So thank you very much, and all the very best.
Thank you so much, Dr. Chauhan, for an insightful session. Before we move forward, I'd like to thank our project partners, that is State Health Society Bihar and Gates Foundation. We would also like to extend our heartfelt gratitude to our sponsors SBI, RODIC, IIHMR Delhi, Axis Bank. We would also like to thank our healthcare partners, Medanta and Sen Diagnostics, and academic partner, that is AIMS Patna. We would also like to thank our publication partner Springer and our knowledge partners UNICEF, PCI India, Pune University, IGIMS, Piramal Foundation, Digital Bharat, IIPH, Gandhinagar, TISS Mumbai, and Yodh. So now we move forward to technical session 1. For that, I'd like to invite Dr. Abhay Kudale sir, please come to the dais sir, and Shri Ajay Kumar Singh sir to chair the session. I would also like to invite Dr. Ayanava Basu, Mr. Brijesh KG Rao, and Dr. Indraneel Sen. Please come to the dais, sir. To follow up with the introduction of our co-chairs, Dr. Abhay Kudale is the head of the Department of Health Sciences at Savitribai Phule University. Dr. Kudale leads the Department of Health Sciences at Pune University and brings more than 26 years of experience in epidemiology, community-based research, and public health system strengthening. Shri Ajay Kumar Singh, he is a senior journalist and former press secretary to the President of India. Shri Singh is a senior journalist and former press secretary. He brings deep experience in media, public communication, and the interface between governance, citizens, and national institutions. To talk about our presenters, firstly, Dr. Ayanava Basu. He is alumni of TISS Mumbai. He is also a focal person for Applied Epidemiology Program at the WHO. His work includes outbreak investigation, surveillance strengthening, and building applied epidemiology capacity through FEDP platforms. Dr. Brijesh K.G. Rao is an associate director at PCI India. He leads work on public health and nutrition, gender equity, and behavior intervention at PCI. He heads the behavior outcome and decision heuristics, that is both vertical, and focuses on behavioral science, human-centered design, and social and digital innovations. Last but not the least, Dr. Indranil Sen is a managing director at Sen Diagnostic. Dr. Sen is the pathologist by training. He has been involved in developing quality assurance diagnostic services in Bihar and has contributed to expansion of private laboratory networks supporting the clinical care and public health programs. So now, as we move forward to begin the today's proceedings, I would like to invite Dr. Ayanava Basu to share his views and give us the insights. Please give a big round of applause, please. Thank you so much.
Am I audible? Okay. Thank you so much. Thank you for inviting me in this wonderful platform. Before we start, let's delve into something that we heard yesterday. There were certain questions which intrigued us. I pick up 3 questions which were discussed, and maybe my presentation will try to answer some of them. So first is, how do we make innovation in health informatics equitable? Second, how do we ensure that the innovation is responding to the right question or right issues? And third, how do we make it sustainable so that beyond the donor cycle, the innovation goes on supporting the issue it was supposed to be? Okay. So now can you please, the first, okay. So let's go to the first thing, that is, we all saw what COVID did to us. More than 7 million confirmed deaths, trillions of dollars in GDP loss. Next slide, please. Which one? This one? Okay. Globally, COVID also showed gaps in surveillance, data flow, and real-time decision making. Further, in the lower middle income countries, there were different fragmented information system, weak workforce capacity, detection were delayed, though there were certain digital tools, they were not properly functioning. Lab disconnect was there, that is, lab was not really connected to the real situation of field or the decision makers. And finally, the governance gaps. Everything said and done, do we think that COVID-19 is the only pandemic that we are going to experience in our lifetime? I do not want to proclaim doom or something, but rest assured, COVID was just a dress rehearsal. Why do I say that the next pandemic is inevitable? That's because what we are seeing that across the globe, the newer emerging infections, they are zoonotic. Often when people, livestock, and the animal world, wildlife, they meet in a situation of ecological stress. This risky contact, that is again furthermore exaggerated when there is deforestation, there is expanding agriculture, uncontrolled markets, and climatic change, of course. Now, these pathogens, once they regain or gain the efficient human-to-human transmission capability, given the urbanized centers and this regular air travel, a local spillover turning into a global catastrophe is just a matter of days. So, pandemic is inevitable, but catastrophe is not. Because taking lesson from this pandemic, WHO and other organizations across the globe has already prepared something called the WHO Pandemic Agreement. What is it? The objective of this pandemic agreement is guided by equity, and the principles further set forth within to protect, to prevent, prepare, and respond. So how does it preventing, preparing, and responding the pandemics? Prevention is from dangerous pathogens, from spilling over and spreading. Preparation is by early detection and containment, and response is by ensuring fast, equitable, and sustainably financed response. So, digital informatics actually accelerates the second and the third part, that is detection and response. By real-time surveillance, integrated One Health systems, advanced analytics and AI, genomic informations, and interoperability and standards, so that rapid cross-border information can be shared and action taken. Let's talk about a process through which this can be supported. It is called, the acronym GEEKS is actually Growing E-Health Expertise, Knowledge and Skills. It is an applied informatics training where digital health capacity building is done among public health data people through experiential project-based learning. There are 4 objectives. First is to build interdisciplinary foundational knowledge and skills for public health informatics. This is specifically important. That is, it is not just preparing something. It is preparing the manpower who have the foundational knowledge to use it, to foster relationship between the teams, mentors, and the leadership to build a community of practice, to provide participations and the participants with tools and skills so that they're able to do what is needed for them. And finally, to provide additional targeted training that is required and needed for the local needs or for the country. So GEEKS works by mainly 4 processes. That is, first is the identification of the problem. What is the problem that is actually bugging that particular locality? It can be a country, it can be a district, it can be a state, it can be any place. It can be a process as well. So that particular problem has to be thought of as something to address to. And that has to be fit into the overall objective of matters. Second, there has to be a system design. So how this problem is part of a larger system, that and the project management cycle behind that, the geeks participants need to understand that and respond in that way. It is an iterative improvement where the implementation is also done by them. So in iterative improvement, the mentors are assigned, they guide the team to upskill, to get upskilled, and thus those team take it forward, prepare the solution, use the solution, and at the same time be ready to mentor the next set of practitioners. Now, pandemic preparedness generally depends heavily on how quickly and accurately we can detect and respond to health threats. So, in 4 ways generally this is done. One, that is the real-time integration. Second, so that the solving bottlenecks. Third, analytics. And fourth, sustainable internal expertise, that is reducing the dependence on donor cycle. Now, geeks supports in all these 4 processes. Real-time data is integrated by interoperable systems, linking surveillance, lab, clinics, and supply chain data to early detection, solve informatics bottlenecks through addressing the data quality issue, then reporting delay, fragmented systems, all that, stronger analytics, supporting the decision making, and finally, preparing the sustainable local expertise that can sustain the program much beyond the donor funding has dried up. So, in the impact of pandemic preparedness, it works on 6 levels, that is by faster detection, better decision, streamlining integration, local capacity building, data quality enhancement, and finally, sustainability. Coming to the real world GIGS innovations, till now what I was talking about is the theoretical framework of what can be done and what was the idea behind the GIGS process. In real world, GIGS has delivered the GIGS program has delivered the following things. One is integrating dashboards, surveillance automation, lab tracking tools, and genomic integration. So, let me just run you through few examples where the actual dashboards are prepared by this GIGS team. We all know that the VPD surveillance system, which is ongoing throughout the country, that needs some information management. So that is something the GIGS team has already done. High-risk areas are the areas where there's need of specific intervention, identifying, geolocating, and visualizing those high-risk areas for any specific targeted activity. That is also done by this program. Real-time graphics from monitoring data of routine immunization and different small, large immunization campaigns. And this is something of neglected tropical disease. The lymphatic filariasis program, how this program is actually trying to eliminate the disease, that is also being captured in a dashboard. So, what in a nutshell we can say is the preparedness is basically a function of people, processes, and platforms. This program, like GIGS, that ensure that countries possess all of these 3. So, taking it forward, preparedness, that is a choice. Whether we really want to be or not, that depends on us. Digital informatics, that supports it. It helps in that preparedness. And Geeks is a program that can build those people who makes this process real. Thank you.
Yes. Thank you, Dr. Basu, for introducing the forum, this GIGS kind of developments which are happening and the utilization. I think all the questions we will take towards the end.
Sure.
Sure. And then, yeah, I think it is time now for the next speaker. Yeah, Dr. Dr. Bridges? Yes, I think, yes. Dr. Bridges. Yes.
Good morning. Thank you very much to Adri team for inviting us to be part of this very good discussion and lot of learning. So, can I have the presentation? Thank you. So I'm going to talk about the community engagement and how we are leveraging the digital ecosystem which has developed in last, say, 5-10 years and made like everybody's life easy in terms of collecting data, getting the information, reaching to the community and all. So next slide, please. I have to use this? Oh, okay. Yeah. So just a snapshot about PCI India. Maybe many of you are not aware about the organization. So PCI India is an NGO. We are working in 17 states. We have around 46 projects and we have reached about 20 million people in these states. We have made 5 domains of work: health and nutrition, women economic empowerment, gender and social norms, and climate action and emergency response. So these are the 5 areas, but today we are focusing more on the health and nutrition and also PCI journey in Bihar, when we have engaged with community, especially on the RMNCH issue and nutrition issues. So we started our work in Bihar around 2012 when we got a grant from the Gates Foundation about the community mobilization part as part of the Ananya program, which was there, the MOU with the government of Bihar and Gates Foundation. And we had this approach and we designed, we thought like, why can't we use this SHG as a platform to work on the health and nutrition issues? So largely it was known like the SHGs are for the livelihoods. They are not for health and nutrition. And everybody was asking like, the question was why these self-help groups who are majorly there for the income enhancement will work on health and nutrition. So it was a kind of a thought. And we started doing the efficacy testing in Bihar in 8 districts with support Gates Foundation. And because at that point in time in those districts, the Jivika groups were not available, so we actually formed our SHGs on the same guidelines and the patterns of the Jivika. So we formed around 18,000 SHGs, we started working with them, and we got the external evaluation done by the Population Council. And in the evaluation, it was like seen, there is a traction in the SHGs where the health interventions have been done versus the SHGs where there was no intervention on health. They are better in terms of the health indicators after the intervention. And that gave some confidence to the entire stakeholders circuit. And then they ask, okay, because the SHGs are yours, you have done all the programming and all, whether this approach will work in the government system or not. Because in a project mode, when an NGO is working, it's very easy to do all the changes and all. But when you have to go with scale, with too many organizations, with too many processes, system, procurement, this, that, all those things, whether it will be successful or not. And then we got to complete the MOU with Jivika. I think everybody in the room is aware of Jivika. They have 1.2 million SHGs now in the state, and they have a great reach. And we are very proud, we are partnering them from 2012, and we are trusted partners to them. So they provided us their platform, all the support which was required, and then you can see from 2014 and up to 2016, we started with around 18,000 SAGs. Then we worked with 80,000. Then again when evaluation was done, and then it was scaled up in 349 blocks. As well as when we started sharing our stories from Bihar, the other states SRLMs got interested, and we first got the invitation from the Tripura. So whatever you are doing in Bihar, that's we want to do it in Tripura as well. And then the model was adopted by the NRLM, and we became the technical assistant partner at the national level, and we started providing TA to other states as well. So it's a kind of a proven model where SAGs can work on health and nutrition issues. So I will just talk about our social and behavior change and community service access approach which we designed. It was basically informed by many SBC theories like socio-ecological model, fog behavioral model, and other whatever available in the research work related to behavioral insights and all. So we have come up with kind of our understanding and our approach. So you can see there are multiple layers. So these layers are individual, then interpersonal, then the institutional, and the system and policy level. And Jivika and that kind of SRLM platform, it provides you all these levels. So at each level, if you are putting some effort, you will definitely get that the entire system working. On the other hand, you can see the structures of Jivika, that is self-help group, then they have the village organization, then the cluster level organizations, and accordingly they have different people who are working for that. So that's the kind of a thing, and we combined all these with our understanding of the social behavior change kind of a thing. So we started working, designing based on the individual cognitive biases, which actually affects what we do, how we do, and those things. Then there are other motivations, people why they are not doing so what we are trying to do. Then there are social norms and gender-based things. And when we have to scale something, if we want to do it at once at the, say, state level in entire 38 districts and all, we have a very large team. So the capacity building becomes the most important thing in delivering all those things at the ground level. So we need staff at the ground and also the managerial level, very energetic, effective, efficient, and all those kind of a thing. And then the convergence between the departments. And lastly, yesterday I was hearing Dr. Tanmay about the MIS and all, how we can use the data for the decision-making kind of a thing. And we used all those things along with our designing process, which is based on the human-centered design, and also following the term which we call 3M. So if you want to change some behavior, the message should be correct, the medium should be very effective, also the messenger should be very trusted and credible. So how in these years, these medium and messenger has actually changed with the development of the digital tools, digital environment, mobile phones reach and everything. That's the story which I am going to tell now. So earlier it was all the paper-based kind of a thing. But when we got this opportunity of the digital ecosystem developed, all the mobile phones, internet connectivity, cheap data and all, we started utilizing, leveraging the digital ecosystem. And I'm talking about three large buckets. One bucket is how we reach to connect community directly. So we created edutainment drama. Edutainment is education plus entertainment in the same video or something. Awareness videos, then mobile games, how we created video boards, and how we created integrated application which has the dissemination component as well as the MIS and the data collection component. And we use through YouTube, WhatsApp, Facebook, all those things. The second part is mainly about the capacity building, which I said is very essential for any large scale program. So we started certain community-based learning management systems and also for the managers. And lastly, we utilized all that data for the monitoring and the tools for the monitoring, like the integrated apps, dashboard, analytics, and all those things for our program quality as well as for the monitoring. So let me show you a glimpse of one of the very short video. Can you play that, please? Sound is not there. Huh?
Can you please change the speaker from Realtek to Protect? Up. Not there. Come out of that. So the top one is Realtek, that you have to take out. Yes. Come out of that.
If it's troubling, we can continue with the presentation, then come back to video. Yeah, you just please check, put on the presentation back. Okay, so maybe when the sound is ready, we can go back to the video. But I was just trying to show you like how an edutainment drama series, which we created in 18 episodes, covering all those health and nutrition related aspects. And also, because the video is very strong medium when you try to bring in order the entire family or the norms and all those things. When you are in the print kind of a thing, when we have to print some poster and all, showing that, okay, the gender sensitivity is there, male engagement is there, that sensitivity, entire ecosystem is there, it's very difficult to depict in a paper-based thing. But when it comes to video or audio, it's easy. So bringing all those things in the design aspect, we created this drama series. And also we developed this drama series in many formats and also lengths. So there are 20 minutes episodes which can go on air on Doordarshan and kind of channels. We have also 30 to 60 seconds teasers which can go in the WhatsApp and Instagram kind of a thing. And also there are 2 to 3 minutes episodes. So we call it mobisodes, which can easily transfer through the WhatsApp and all. And the scripting, all those videos have been done accordingly. So that's like the thinking of leveraging every platform which we had while we were working on this series. So it has like character-based narrative. It's very engaging. It has the all behavioral nudges which will influence the behaviors. It has the fun part. And also we utilize the influencers things in our work. So there are influencers in Magad region. They are called Mangdi boys. They are very popular in local. So they acted in this series. So that all things we try to do in this kind of edutainment series. But this entire thing was the package. So based on the characters which we created in the drama series, we followed up with the kind of bots and the FAQs and the recipe games. So if two characters, the central character, the couple is there, they are also depicted in a way for the recipe game. They are also part of the video FAQ in the game, and they also are the part of the video board. So once the community is exposed with the episodes and the things, they have a mobile game in their phone. They can play on their own pace and when they want to use it. So it was a complete package where we utilized the main video drama series as the main tool, and then subsequently we started using the FAQs, bots, and the recipe-based games and for the community. And in the series we covered actually the entire continuum of care from the conception of the pregnancy up to the child is 2 years of age. So these are some screenshots of the video-based FAQs. So it's not the FAQs like in the text format or so. So it's a very engaging. It's a kind of a game-based video bots and FAQs where if you are giving right answer, then you are getting points, and there is a marketplace where you can find some toys or something for the kid. So that information is actually shared with the community through these mediums in a very engaging way. Similarly, if you see the recipe-based game. So if we want to promote, say, ragi-based recipe or say something, if we convert that into a form of a game where you have to find the ingredients, you have to cook the recipe with the right process, and unless you are using the right ingredients, you will not able to go for the next step. And also that's a timer base. That's the 20-second time when you have to find the correct recipe. So if for preparing khichdi for the kid, if you want to identify those ingredients, you are putting it together, you are following the process which is actually recipe based, then only you will win this game. So it's like putting those challenges in front of the user, and then they are learning. And they compare it with someone going and telling them how to prepare khichdi and playing this game and try to understand like what is the process. So that's a large difference which we faced in doing all those things. Then comes the mobile application. As I said, this is a Badhai Ho application. It's available on Play Store even today. And this is a kind of a teaching aid, because many a times what happens, like when the community cadre goes to the household and talking with the beneficiary, they may miss some important information. They don't have that, like maybe everybody is not that motivated. But this kind of application, standard message is there. There are like fun-based engaging things in that. Then you can also, the right interpretation would be there because the message is very clear and tested and sound. If I can play this from here. No. So can you, I don't need audio for this. On the slide, if you click, yeah. So this will just show the, just play the video on that, yeah. If it's not running, then leave it, no issue. So inside the this game, when once enter their profile and all, they have different sections. If the pregnant lady is using that algorithm is there. If how many months she is pregnant, choosing that, and the right kind of information will be there. There are sections on myth and misconceptions, and that is game based. So you have to play the right and wrong kind of true and false kind of a game, and then you will earn point and all. And with this kind of application, the biggest success for us is also you are getting the data. Like when we are showing the media, audio, video through WhatsApp and all, we are not getting any data like how many people have seen this, what is the impact and all, how they are doing. But when we are coming with this kind of an integrated game, you have the user profile, you know their profile, you know their demographic data and all. Also, whenever they are interacting, they are logging into the game, they are playing a certain game, they are providing the answer. So, for example, myth and misconceptions, there are 10 questions. If they choose 3 as wrong, we know most of the people are what myth they are having for the particular case. And then we are using that analytics in developing the other tools and going for the next level of messaging and all. So this kind of an integrated app is really helpful in doing all these things. So this is the kind of a complete package which we have used for our community engagement and direct reach. The second part which I was talking about is about the how we can make the learning and the capacity building part easy for the large scale implementation programs like Jivika and others, where you can't do the 3 days, 2 days training on a very regular basis, but that regular training and reinforcement is very much required. So we created this Digisala, which is for the ground level workers, and it's a very low tech kind of, we use the ONA and Keto platform. We created very Excel based kind of coding system which is required for the ONA and all. And then we created the dashboard with the Power BI. So that was very helpful. And now with a mobile link, a web link which is shared through the WhatsApp and the other mediums, all the community cadres were used at their own discretion, like when they want to learn that. For the senior managers, we actually created a larger level LMS in partnership with AIMS Patna and XLRI Jamshedpur. So we chose for the managerial capacities, management training and all. XLRI is the partner and the AIMS Patna is partner for the health and nutrition thing. So this is just like Udemy and all those LMS platforms which actually creates your personalized learning and all those things, which actually helps in doing all those things. So I am not going in detail on how the e-learning web mobiles or based platform learning platforms are successful and doing things. This is some data on the LMS. So for out of 350 managers who were actually part of the MICN and nutrition modules, around 80% of them have been used it regularly. Similarly, 88% for the management training. And the lower bar is about the field level workers. So you can see like out of 6,000, 102, 95, 88, 75%. So that's the reach which is we are having through our Digisala and LMS platforms. Lastly, the quality assessment part. So using the ONA ODK toolkit and later now we created our own application, we created some form of doing the quality assessment on a very regular basis. And I think Tanmay is here and Indrajit is our country director who actually, they thought about something which is called concurrent measurement and learning. While we are implementing program, when we do the quality assessment and outcome monitoring at the same pace concurrently, then we can have a very good increase in the expected outcomes. So this system is just, what started doing, like we do the regular based kind of a sampling and then collection of the data, but data is not only about the outcome, that data is also for the process. So the next slide and this graph, this is just one I have taken from the snapshot of the dashboard. The indicator is the SHG meeting where members able to recall key messages of the last session. So for us, the platform is SHG meeting when we are actually imparting the knowledge. So maybe in the last meeting, it was the breastfeeding. So when our people will go to field, they will ask like, what was the last meeting, what you learned from that, and if they are able to tell the right key message which was intended to disseminate in that meeting, if it's there, then only they will put this yes. So if the red zones like 30%, 36%, so we can understand if we delivered something in the meeting, and after 1 week or say 10 days, somebody is going and asking, what did you learn in that meeting? And people are not able to recall. Expecting outcome from that process is something which we should not do. So that's what we are doing with this kind of a system, utilizing the application, dashboards, and all those things. We haven't used AI in this work in Bihar, but recently we have used that in our other work, which we have created one LMS for the skilling. That's in Maharashtra. And with the partnership IIT Patna, we were able to create a module for the communication skills enhancement of the students through that. So when they speak in that LMS, they have to record there is a passage, you have to record the passage in your own tone, and then the AI will tell like how was your tonality, or how was your pronunciation, what was your speed, and that will analyze and give you a score of your communication skills. And then second time whether it has improved or not. So it's very personalized and all. We can build all those things for the community as well, but we are still not there because although all the advantages are there, I'm not going in detail, but still like in the age of social media, the information overload is already there. So making a space for us in that crowded situation is really difficult. Secondly, the entertainment and edutainment part. So edutainment is good, but entertainment has still the age on the edutainment kind of a thing. Lastly, I will say the most women still do not have their own phones. So we are working with women. So as per data which I have is around only 20.6% of women in Bihar have ever used internet. That's per NFHS 2020. That's the challenge. But with the population we have in Bihar, that 20% is still very good enough to start with. So that's how we perceive this. Thank you very much. You can play the video? Yeah, thank you.
आपके लिए मुंह दिखाई सुनी जी।
हाय गुरुजी, इसका क्या जरूरत थी? ये तो बहुत ही महंगा होगा ना?
तो क्या हुआ? आपकी खुशी जरूरी है, महंगा सस्ता ना ही। देखिए ना सुमी जी, हम आपका निवेदन मनवा लिए। अब आप पढ़ भी पाएंगी और जब आपको माँ बाबू जी की याद आएगी तो आप उससे बात भी कर पाएंगी।
आप हमें पहले फोन दीजिएगा, हम इसमें वीडियो देखकर निक्की और प्रभा दीदी के लिए स्वस्थ रहने वाले फल और सब्जियों का लिस्ट बनाते हैं। उसके बाद मेहमान जी को भी समझाएंगे। और अब चिंता काहे करते हैं, हम हैं ना। हम इसमें वीडियो देखकर फटाफट लिस्ट बनाते हैं, आप बाजार से लेकर आइएगा। गर्भवती महिलाओं को का खाना चाहिए?
फोन का ये इस्तेमाल, ये तो कभी सोचा ही नहीं था। सुमी जी, आप जब हंसती है ना तो बिल्कुल आलिया भट्ट लगती है।
हटिएगा जरा, बनाइएगा मत, हमें हाँ बता दे रहे हैं हम। इतना फुर्सत वाला समय है नहीं अभी हमारे पास।
बनाए तो आपको ऊपर वाला है, बिल्कुल फुर्सत में।
ये कौन सा फिल्म चल रहा है?
दादी कुछ नहीं, वो प्रभा दीदी और निक्की के लिए पौष्टिक आहार वाली लिस्ट बना रहे थे।
इसमें देख के
जी दादी देखिए,
हमारे शरीर में कई प्रकार के इसका नाम तो ज्ञानवंती रखना चाहिए था।
ज्ञानवंती, वाह दादी। चादर के पीछे क्या कर रहे हैं जीजा जी?
कुछ खास सोच रहे हैं क्या जीजा जी?
सोच भी।
थैंक यू।
We will go to the next presentation of Dr. Indranil Sen.
Good morning to one and all present here. So it is a great honor for me to be present here, and I thank the organizers for inviting me. So I'll be talking about digitization in healthcare and a private laboratory's journey in Bihar, the challenges, opportunities, and the road ahead. So this is an outline of my talk. So the initial part of my talk will be more like a story, which will be the journey of Sen Diagnostics from its inception to today. And the latter part of the talk is about how we are utilizing technology and AI in our current scenario and what challenges we face. So the legacy and origins of Sen Diagnostics. So Sen Diagnostics was started from an 8x8 room, and now it is a network of diagnostics facilities throughout Bihar. We have over 6 decades of quality service, and we brought global technology to Bihar. And we take pride in delivering accurate, reliable, and compassionate diagnostic services. Sen Diagnostics was founded by my late grandfather, Dr. Dilip Sen, in 1965. And that was a time when medical diagnostics was in its infancy. And Dr. Sen demonstrated to the state that laboratory science could transform clinical care. It's also a matter of pride for us that this year is also the 100th birth anniversary of late Dr. Dilip Sen. And the reason being that digital revolution of Sen Diagnostics is deeply rooted in the scientific curiosity, fearlessness, and love for innovation that he embodied. Dr. Dilip Sen was always a gadgets guy. So if there was any new camera or any new interesting gadget, he always had to have it. And similar was the case for any new instrument or new medical equipment. He was fascinated by electronics and medical instruments. And he, in fact, after his training in London, he brought back a few equipment which really helped in, speeding the process of modernization in laboratory medicine. He instilled 2 values that still define Sen Diagnostics. Quality cannot be compromised under any circumstance, and new technology must be adopted early, not when it becomes fashionable, but when it becomes useful. After Dr. Dilip Sen, my father, Dr. Sandeep Sen, took over the mantle, and it was during his time that we expanded in terms of the number of collection centers. Like Dr. Dilip Sen, he was also interested in electronics, and as a hobby, he liked coding software. So we grew in terms of number of collection centers, and under his leadership, we also had a tie-up with the state government where we opened about 250 collection centers, and we had labs in district hospitals of 19 districts of Bihar. And throughout his period, we were always upgrading our equipment to the latest technology. Now, impact of digitization and how our journey was from the 1980s till 2022 under Dr. Sandeep Sen. So in the mid-1980s, Dr. Sandeep Sen programmed a homegrown Unix-based laboratory information management system from scratch. At that time, it was unheard of, where even in large metropolis, lab reports were being sent out and they were handwritten. The goal for him was not glamour, it was workflow precision and optimization of workflow. What advantages did this software offer? Well, it improved laboratory operations drastically. It digitized patient indexing. It automated report typing, reduced transcription errors, and overall it was faster. Now, there were pros and cons of this server-based architecture. So the pros were that we had complete control over our operations from billing to report dispatch. It was highly secure because it was not connected to the internet, so there was a very low risk of cyber attacks, and it offered unmatched customization. So I have an anecdote here. So since this software was built for local people and semi-skilled workers, so if there was any error in billing, so the comment would read, "Hisab mein ghapla," which is understood by the local people here. So it was that customized. For decades, it supported computerized reporting and data management with great reliability. But then there were cons also associated with this because it required a lot of hardware, and hardware is costly. We had to have multiple backups for that. It had cooling requirements for which we had to keep an air conditioner on 24/7. It was highly dependent on IT, and there was risk of downtime due to physical failures. And this was also problematic in terms of expansion into districts, and scalability was an issue. Then in 2023, we transitioned into a fully cloud-based software. So the advantage was there were no servers. And just like we log into Facebook, this provided us a similar platform where we could log in through any mobile device, the only requirement being a stable internet connection. So this provided us with great flexibility because we could use the same software across all our network of collection centers and labs. Another advantage with digitization in healthcare is sample tracking. So with barcoded samples, we have right from the collection of sample from our collection center to report dispatch. All the steps, the sample can be tracked at each and every step, and it gives us an idea where the sample is. So from the user end, patients have access to a mobile app where they can track their exact location of their sample as well. So this ensures safety, transparency, and reliability. So right from sample collection to interfacing with the machine, and then the report is accessible to the patient on his mobile device. So all our analyzers are integrated into our software, so nobody is manually typing in results. It is automated through the analyzers. Smart reporting. So what this software also offers is flexibility in terms of it analyzes trends of patients. So patient data is maintained through a unique ID, which is linked through his or her mobile number. So if a patient comes, if it's a repeat patient, so the software will analyze his previous history also, and then give a trend analysis with graphical representation. If there are critical values, it alerts the pathologist, and it also, if the results are a bit wavered, it will indicate whether reflex testing suggestions are required. It flags abnormal results so that the technicians and the pathologists can be alerted early, and the patient can be informed, or the doctor can be informed immediately. The software also offers an insight into turnaround time, so where samples are tracked and daily performances are logged. So at a regular interval, we can monitor how our lab is performing in terms of turnaround time. So our standard TAT is 8 hours, and we try to maintain all our samples and dispatch samples before that time. So there's a live dashboard which keeps us updated about our TAT, and it maps bottlenecks, helps us identify which is the problematic area, either the pre-analytical, analytical, or post-analytical stage. And there are AI-enabled insights also which are generated. So, sorry. Okay, that will come in the next slide. So what overall has happened is the end user is the patient, and the patient has benefited a lot from this digital transformation because the reports are available on his mobile device. So the patient does not even have to visit the lab. His sample can be collected from home. He can book the test online, and his report will be available on his device. We also use social media a lot. So we have been using social media to create awareness about diseases, and we also keep updating our profile about any camps that we are conducting, or if there are any new procedures or tests that we are starting. So social media is also being utilized to a great extent. And AI we use in our daily operations and in our finance and in our TAT analysis. So what it does is it analyzes the workload trends, it identifies seasonality, and helps us identify which tests are coming in which season. It helps us in our inventory management also, because it helps us identify reagent consumption and which season requires more of reagents, certain reagents. Different collection center, how they are performing, that is also analyzed through AI. And apart from that, it tracks revenue, profits, seasonal patterns, predictive insights. So overall what has happened is there is a shift in decision making from intuition to data, helping the organization grow sustainably and allocate resources efficiently. So this is the dashboard which I was talking about TAT analysis. So for the month of November, it has compared with previous months. Our overall TAT, which is 8 hours, so we have maintained about 5 hours, 57 minutes per sample. Pre-analytical stage, there was a decrease since previous months, which is good. Analytical TAT, there was an increase of 9.8%, which we need to work on. And post-analytical TAT, there was a decrease. So all of this is present on our dashboard, and it helps us keep a track of how we are performing on a day-to-day basis.
Please summarize.
Okay.
Please summarize.
So right now, I'll be a bit about the challenges which we are facing in implementing and digitization. So there are technical challenges which has to do with the technology which is already being used, that needs to be upgraded. Financial challenges, especially in the case of LMICs, where budget is important. Human resource challenge, which includes training of personnel. There is a resistance to and human resistance to training. So training programs have to be consistent and not just a one-time program. And there are regulatory challenges, especially with the use of AI, where ethical and legal considerations also have to be taken into account. And organizational challenges. There are a lot of stakeholders in healthcare. All of them have to be on the same page, which includes insurance companies, hospitals, policymakers, labs, both government and private. So the recommendations are that foster interoperability, which means that different stakeholders, they should have access to the same platform. Next is staff training, which should be continuous. And then phased rollout. Whenever there is new technology, it should not be abrupt. It should be in a phased manner, so that if there are any issues, it can be detected early, and even there's time for training. And finally, regulatory and financial challenges. So one last thing I wanted to tell was about ethical and legal evolution. So with the use of AI, ICMR has laid down guidelines which dictate how AI should be used and how to protect data privacy, especially while using AI. So that's it. Thank you so much.
Thank you. Thank you. Thank you, Dr. Sen. Yes. Can go on? Yeah. Yes. So 3 speakers and 3 diverse presentations, the kind of issues what they touched upon, starting from pandemic preparedness and the GIGS advantage, what we are having. The second presentation was on edutainment, okay, the kind of initiatives PCI has done in health and nutrition in Bihar. And the third presentation coming from Saint Diagnostics, kind of experience in AI. Any questions to this particular group?
Thank you for this very, very interesting session. I would like to congratulate all three speakers for bringing out very interesting topics. So I have a question each. I mean, I have many other questions, but I would just restrict to one for now for each of you. First to Arunava. This Greeks program that you were presenting seems very interesting. So, but then are we thinking of like an additional module or additional workforce for the which is different from the already existing workforce that is there, which is part of the government? If so, then how do we make this sustainable and affordable? Because that was what was your, that is what you started out with. If you're thinking that we would train the government, existing government people in this module and make them adopt it, then why don't we make it as a part of their regular training curriculum than having it as a separate module, sort of? So that was my question from the interest, because recently we have also started working in this area of training of public health workers. So from that perspective, it would be very interesting to know what would be the level of workers that you are targeting. Can that be integrated into the regular programs and so on? With Brijesh, very, very interesting concept. So in ADRI also we have been into literacy work for the last 25 years, and there were these edutainment methods that are used for community penetration. So my question was that, so I know that these are one of the upcoming methods and very, very tried out in different parts of the world. But what, so compared to the traditional methods, is there any study that you have done or evaluation that in Bihar, how effective are these mobile-based methods versus the traditional methods? And if there could be a combination of the two, because the traditional methods are much more cost intensive.
One more thing I wanted to ask you was that there are ways you can ensure that people are downloading your platform, but how do you track that out of the entire population, how many have actually downloaded it? And after once they have downloaded it, you obviously have a way of monitoring. So how do you make out the first part?
And to Indranil, again, very, very interesting. So we have known Sen Diagnostics since, it has always been there, but it was very interesting to know about this digital transition that you have made. So my question for you is, when you moved to this cloud-based system, how difficult was it to, adjust to your local needs? Were you able to, was there any scope for feedback that was not working? And in terms of this system that you have adopted, how standardized is it, and how can it be integrated with other data collection, reporting surveillance tools that the government is using? So thank you.
Can I answer? Yeah, okay. So coming to the first question, that is, what is the cadre like, these geeks? Actually, India is the 6th country in the world which has started with this process. It is part of pandemic preparedness and field epidemiology training programs branch out. So currently the 2 cohorts that has already been trained, they were actually district level or state level data assistants. So if we are thinking of taking it forward, maybe we can look at a district level, district data entry operators, or even block data entry operators. So we do not want to create another new cadre, because it is already about the people who are in the system, who knows the system and are well aware of the difficulties they are facing, either in their daily work or in the program itself, so that organically that solution comes out from them only. This program is about training them, equipping them, and mentoring them in a way so that they can identify, think in a systems process and project cycle, at the same time have the support of mentors who teach them how to go about upskilling them in health informatics, and finally they prepare that solution, whatever it might be, and use that for their work. So they become the guardian of whatever they have prepared. And at the same time, this GIGS program, like the field epidemiology training program as it is done globally, it depends on a network of mentors. So if one group is trained in this year, it's a 1 year long program. So then for the next year, this groups become the mentor and trainers. So maybe some external trainer, 2, 3, 4, they can come for a while, but end of the day, it is the in-house trainers who take it forward. So the sustainability matter is taken care of. The thing is, GIGS is in its very initial phase. Only 2 batch, that is around 40 personnel has been trained in the country. And we are really open to take it to larger audience, larger participants, and dialogue with different state governments are on. So we would be really interested in taking it to Bihar if it accepts it. Thank you.
Dr. Basu,
yes,
you started with an alarmist view, I believe, and that is a realist view as well.
Yeah.
Because I've heard Bill Gates also repeating the same thing, that what you saw is just a what you call dress rehearsal.
Yes.
So, but once in a century, pandemic is enough, because we have all seen it and we have gone through that, and it is really a painful experience.
Absolutely.
So, thanks to ब्रजेश जी, इन्होंने एक चित्कार क्या था, चटकारे जिंदगी के, तो that came as some optimistic view.
Yeah.
but what I wanted to know is that I mean, apart from all training and everything, this what you said was very important, that balance between the nature or ecological balance.
Yes.
That has to be maintained in order to save the earth.
Absolutely.
So, unless you raise the consciousness level, what kind of informatics would do any good to the nature, would do any good to society, unless the consciousness level of the society, the governmental agencies and everybody, if that could be raised, and we should be trained to protect the climate.
Absolutely.
So how should we go about that?
So the thing is, this climate change is a reality, and the way the world is actually progressing, sorry to be not that optimistic, I don't see the rate of climate change that is happening that is going to slow down in very near future. Because the decisions that different government and intergovernmental bodies are taking, those are in a way stalling the process in a very, and not in the spirit which I feel in which it should be. So, from that context, that is definitely the best thing to do if we really increase our awareness and start doing things which is going to, if not stop, at least stall this environmental changes, this ecological stress, which we call it. Given the situation that environment is changing, there is enough evidence that newer pathogens are coming out. They're emerging. And this pandemic preparedness accord is to be realistically ready for that. For COVID, nobody was ready. It hit us very hard because absolutely nobody has any clue what is going to happen. Nobody of our generation has seen any pandemic. But COVID showed it in a very harsh way that pandemic is a reality of today. Maybe 20 years, maybe 15 years, maybe 5 years, we don't know. But in our lifetime, we are going to encounter pandemic. Are we prepared for that? Pandemic might come, but are we really prepared to actually prevent it? So this is all about that preparation. So a sustainable model, something which is already always ready to identify and act. So this pandemic preparedness is all about that. It is not something doing once and slipping. No. It is something which we have to do again and again, same repetitive, boring tasks. But that's the way it is. We all, while coming out of our house, lock the door. It's not that yesterday I locked, today ठीक है नहीं मतलब दरवाजा बंद ना करने से भी चलेगा. It's not like that. It's a mundane job. You just put the lock on your door, but you do it again and again. It's something like that. Thank you.
Thank you. Thank you. Over to
Thank you. Thank you. So on the question of any effectiveness data or such study for us.
Recording in progress.
So unfortunately, working with government brings one challenge, which is you have to do everything at a scale, and we have to do it on a scale. Finding the counterfactual, right counterfactual to conduct any kind of study is very hard. That was the case for us in Bihar. So while we have the testing data, while we are doing our SCD research, qualitative assessment, and we are doing the proper SCD, that data we have, and that's encouraging. That's why we actually created all these things. But when you ask like whether that is a very scientific data which we can put in some kind of a publication, that's unfortunately not available for Bihar. But at the same time, we also have a way of doing this, like whether it is effective or not. That is doing the analysis based on the exposure of the these kind of things. So that's also encouraging. But that's why I didn't put in this kind of a forum where we have some internal data or this kind of a data. So that's the reason. Otherwise, while we are using, we have seen that differences. So if the respondent is exposed to any of these methods in addition to the other methods, that there is a difference. But that attribution establishment, while this is the main region or this is a very good cause to, like causal effect is there to establish that thing, that is something which is not here. So that's the limitation with this. To answer your question about the how this population, so I will link this with your remark on the use of both the traditional method as well as the modern digital thing. That's what we have taken, and we know this for us it's physical, it's not digital. So you have to do something physical. Similarly, like you have to do certain diagnostic there, and then you use the software. So it's a physical model. So for us, luckily, Jivika has more than 80,000 cadres in field. So for 12 lakh SHGs, for 10 to 12 SHGs, there is one cadre. They are called CM. and there are additional cadres for different kinds. Like there is CNRP, which is Community Resource Nutrition Person, at the panchayat level. So if 20-30 per 1,000 people are there at the ground, they know about this app. So this is being installed, facilitated during the meetings, so they can use it in a longer term. We are hopeful like people will be able to use directly, they can go and find it and do. For that we use flyers with QR codes and all those things we are doing. But largely it is facilitator based. So you inform them like this app is available and you can do in that way. So.
Your question.
Okay, answering my question. We had a lot of staff since the 1980s whose first exposure to computers was the application created by my father. So it was Unix based and completely on the keyboard. There was no use of mouse. So that required transition into a new software which utilized a browser. So people had to be trained about how to use a mouse. So from that scale, it was difficult, but we ensured that the training was appropriate. So we did it over a period of months where we requested. So the software which we use is a Pune-based company, and it has customers throughout the globe. So more than 3,000 customers, even in the US, in the Middle East. So it is something which is plug and play. And there's tough competition in this space also. So there are a lot of players who are providing this laboratory information management systems. So it is something which is absolutely doable, and ABDM is going towards that direction. And hopefully in future we'll have a platform which is integrative and it takes into account all the stakeholders. So that is what the way forward is, and that is one way of maintaining data integrity. And you'll be able to have all the data in one place. And UHID is one. It has a long way to go, as I was discussing with Dr. Basu, but that is one way of doing it. And as far as the end user is concerned, initially in the evenings during the reporting time, there used to be a huge crowd where people used to physically come to collect reports. Now it looks like a deserted lab because all of them have received the report on their phones already. Thank you.
Thank you for your responses. Yes, one question from Dr.
Thanks, Dr. Basu. I would like to know more about that training program. I will keep in touch with you. It was an interesting part. My questions to Mr. Brijesh, that these kind of the multi-educatement materials in terms of LMS, also in terms of videos and games, that requires kind of investment in the initial phase. We had developed 3 applications for the WCD department, and in COVID time, 2018 to 2022, we have received the funds. But after that, it was difficult to sustain when we had catering almost 40,000 of Anganwadi workers simultaneously, because we have invested in hosting part and the server part. But now if we want to continue those applications, even though it's open source codes that we use H5P content, it was not sustainable. The second thing, during those areas also, we had UNICEF earlier had made a MENA kind of a video series that almost guiding the beneficiary about child growth, nutrition, preparedness also. And during that part also, we had exposed about certain ANC, SBA training apps in terms of education. So how this needs to be structured for the sustainable and scalable level? That's the first question, sir. Second question, I completely agree, because these kind of resources, when we implement, it's difficult to assess. We use Kirkpatrick model. There are 4 levels. We try to assess these kind of interventions that making any change in the behavior. The users SSG group or the healthcare worker, we could see those changes. But when we do the causal association, just like ma'am asked, that is it possible or not, then we had so many of confounding factors that needs to filter, and it was difficult. So to anyone, if someone knows how to evaluate these kind of training resources, I would be happy to understand how to go forward. So first question to you, then we can have the second answer.
So maybe the comment on the second first. You have to find an investor to do that RCT for us when we are designing this kind of a thing, because that investment for this kind of a evaluation is a question which is nowadays very rare to us. So that's the difficult part. Maybe Tanmay will add on that. On the first thing, because this was a technical support program, day one we wanted to transition all these things to Jivika. So I'm happy to say you will find a LMS of Jivika on their own server where we have transitioned all those videos of AIMS Patna on that. So till the time we had funding from Gates Foundation, we were running it. Before that, we ensured that those videos and everything is now available on Jivika's own LMS platform. So that's the one way of doing this. Second thing is like, again, when we were developing something application based for some government department, that understanding like this is going to be done. Then while we are designing the software or the application, we are assessing their own internal server capacity, server type and all those, because we face this. So दूध कहते हैं ना, दूध का जला छाछ भी फूंक के पीता है. So हम लोगों ने बनाया और जब लेके गए तो उन्होंने बोला नहीं जी ये तो हम गवर्नमेंट ऑफ इंडिया का जो है ना वो वाला सर्वर यूज करते हैं, इस पर ट्रांजिशन नहीं हो पाएगा. सो जब हमने एजेंसी हायर करी, उसके साथ पहली मीटिंग व्हेन वी डिड, we also asked कि let's sit with the IT team of that particular department, understand what kind of a hardware configurations, everything is there available, and have a written agreement with the top leadership of that key. Once we will design and develop this will be taken and transitioned to your system. Unless until that is done, we don't start any work in that way.
We were unfortunate in that because we had given everything. After 3 years, they are not able to manage it.
So शुरू के 5 साल हमने भी वही झेला था सर, बाद में सीखा.
Thank you sir, thank you.
Just before organizers asked me to shut up, being a common partner in crime, knowing Dr. Bridges' data on Jivika, the whole health and nutrition layering here, working with WHO for different aspects and Dr. Indranil also. I just want to mention one point regarding the evaluation of the behavior change, especially for training, a very recent update. So just like as Dr. Rashmita mentioned, that in Bihar, there are several efforts to ultimately ensure that the managers and the providers' behavior is taken care of. So it's a journey of Bihar Technical Support Program with a multi-partner consortium, as you know, starting from technical support to techno-managerial support to behavior change, and right now optimizing Bihar state transformation. So in this one, we just finished assessment of the most accepted, expected, and never pursued component in healthcare service, that is compassion. Compassion कौन सा medical college में पढ़ाया जाता है, at least I don't know, but it is taken care of that all of you are compassionate, empathetic, having influence without authority, having active listening, having non-judgmental approach, and all leadership competencies. Everything we just mentioned. Assessment of that in a multi-state tool validated through confirmatory factor analysis, structural equation modeling, and principal component analysis. Just finished, and the paper just got accepted yesterday, International Journal of Epidemiology. So we will be very soon sharing them, and I guess based on that, it will be a tool for all of us to further the efforts that we are actually trying. एंड जैसे डॉक्टर वीएम काटोच बोलते थे, कोई क्वेश्चन है? पब्लिश्ड सर. थैंक यू.
Hello. Yes, thank you. With this note, I think it is time to conclude this session. Thank you. Thank you to all the speakers.
I'd like to thank all the speakers on the panel for an engaging and insightful session. This session was an amalgamation of all the three pillars on which public health stands, that is, preventive, promotive, and curative. So moving forward, now for the felicitations, I would like to request Sri Ajay Kumar Singh sir to present memento and certificate to Dr. Ayanava Basu. Now, I would like to request Dr. Abhay Kudale, the co-chair of the session, to present memento and certificate to Mr. Brijesh K.J. Rao. I would like to request Dr. Abhay again to present memento and certificate to Dr. Indraneel Sen. I would like to thank you all the speakers and the chairs. Thank you, sir.
Now I'd like to call upon Dr. Harsh Shah to chair our next session. Dr. Harsh is an assistant professor at the Indian Institute of Public Health, Gandhinagar. Dr. Shah is nationally recognized for his contribution to digital health innovations, particularly Niksha Setu, MERM, AI-based chest X-ray platforms, and a large-scale health system strengthening initiatives across surveillance, TB, RNMCH plus A domains. Please join us, sir. So the theme for this session would be digital health innovations and data-driven governance. I would like to invite Mr. Sudhakar Reddy, WASH officer, on the stage, Mrs. Rekha Raj, health officer, UNICEF, and Dr. Mausami Gupta, senior research lead at ADRI, to join us at the dais. We also have a speaker from Taiwan, Dr. Chung Ying Lin from National Cheng Kung University, who will be joining us through an online mode.
Hello. So, this is the interesting topic, digital innovation and data-driven governance for health system strengthening. It touches upon many areas, and we do have interesting topics today. I welcome all the speakers. Thank you for having us. Here, the first session is from Dr. Cheng Ying Lin. He's going to talk about internet addiction on health and studies from country comparisons. So, have they joined?
Maybe do I need to share my screen first?
Yes.
Hello, everyone. Let's see. Can you my screen?
Can you check the screen?
Is my screen there?
Yes. It's visible. Over to you, Dr. Lin. Dr. Lin? We are not able to hear you. Please wait.
Okay. So can you hear me?
Yes, now we can.
Okay. So do you see my screen?
Yes, we can start.
Okay, good. Okay, thank you for inviting me to participate in this conference, and it is my honor to be here. I'm sorry that because of the busy schedule in the semester, so I am not able to participate in the conference in person. So I present this topic, Internet Addiction and Health, and about some of my studies from different countries to introduce about when we use the technology, not only think about the positive sides, but we may also think about it could have the negative sides. Okay, and this is Choyin Lim, and my background is occupational therapy, and I'm in the Institute of Allied Health Sciences in the National Cheng Kung University, Taiwan. Okay, so we know that this is a technology era, so everybody has a smartphone. Based on the World Bank statistic data, basically everybody has 1 point something smartphone, especially in Asia countries. We have searched the literature and found that actually the Asians have more smartphones than the Europeans. Okay, and so what do we use the smartphone to do? Basically, smartphone can bring us a lot of enjoyment. Like we have the Line, we have the WhatsApp, we have Google, and we have the TikTok. And even if we want to do online shopping, if we want to do, social networking, or we want to watch any videos. And some people even can use the technology, the smartphone, to, earn their living, right? There are some kind of YouTubers, so they can use the YouTubers to their YouTube channel to obtain some donations and then earn a living, something like that. So basically nowadays, everything is about technology. Everything is about the smartphone. And because of the Wi-Fi, so it is very convenient to use the smartphone. So we know that there are many benefits of surfing internet. We can get information quickly, immediately, as long as we can have the smartphone and we have the internet, and we can know the information we want to know, and we can use it to do a lot of daily activities. So indeed, there do have some kind of positive effects of using the smartphone. This is one of my studies earlier from during COVID-19 to after COVID-19. We can see that in this figure, when it is during the COVID-19 period, that is 2021, August to September, because of the lockdown. So basically, we may not have the physical activity engagement. So many people try to use a lot of smartphone. They engage into the gaming, engage into the smartphone use, okay? But after the COVID-19 lockdown is, over, we can see that the trend of physical activity, that is this line, okay, from the second point to the third point, its slope is parallel to the smartphone use and also gaming, and also the social media use. So what does it mean? It means that when people use more of the smartphone, engage in more social media and also the gaming, their physical activity may be increased. Okay, so this means that yes, using kind of the apps may help us. And when we reflect a little bit, we know that the smartphone has so many apps that encourage us to do activity, to do physical activity. So this may explain why there is a positive relationship between the physical activity with the smartphone use. Okay. Wait.
Yes, please continue.
Yes, wait a moment. I think that I have some kind of technology problem. Okay, now, yes, I can move it. Okay. So there are still some problems. Even we know that there is positive effects of the smartphone, but there are some problems that may happen if we use too much of internet and the smartphone. So the major issue is that people will think about if we use too much of technology, too much of internet, then we may have caused the issue is calling the problematic use. When we use a thing too much, that is not good. So they call it as problematic use of the internet. Or some people will simply say it is the internet addiction. I think this is the more common term that we have heard, the internet addiction. And they borrow the idea from the substance use addiction, something like that, the drug abuse, something like that. And then they think about if people can addict to the drugs, then people may also addict to the internet or smartphone use. Okay, so how can it become a potential route to use a smartphone and then develop the addiction? Some people propose that it could be the interaction of person, affect, cognition, execution model. That is, when people, we have some kind of personalities, we have some kind of characteristics. And when we feel lonely, we have some kind of emotional needs, then we would like to find a way to help to feel better. So when we use the internet, we may feel better because the internet gives us too many things. They give us the social networking, they give us the entertainment, okay, they give us some kind of interaction with other people. So if the person used the internet as a way to cope with the emotional need, then the people may feel encouragement and then has a positive loop established. That is when they feel lonely, they feel emotional needs, then they use the internet and then can get satisfied. And after they're satisfied, they will want to use more of the internet, and this becomes a loop. And when the person has a kind of weaker mind, that is, if the person's resistance to use internet is not that good, has kind of tendency to use the internet, then the person will use more and more of the internet. Even they later on feel that using internet is not healthy. So this is a so-called iPass model. Apart from the iPass model, some people will propose that narcissism could be another reason to develop the internet addiction or the problematic use of the internet. That is, when people feel they have a kind of, confidence, and then they want to show themselves. So they want to let other people know about they are so good. So they will go to post their positive points, their good sides to the people on the internet. And after they posting this kind of positive stories, they may obtain some kind of positive feedback. And after the positive feedback, it will increase their narcissism. They'll feel more confident and more like themselves, and then become a loop again. So they will going to use the internet more and more and become problematic. And also people have proposed that compensatory internet use could be another reason to go to the internet addiction. That is, they have some kind of emotional need, and then when they have the emotional need, they use something to compensate their emotional need. So they may want to use more relaxation features of the internet. They want to have some kind of social interaction through the internet, or they think that the internet can help them to learn something and to fill up their bored time. So they feel that using internet seems to be a good way to compensate their emotional need. And then they will develop the pathological internet use, or we call the internet addiction. Apart from the personal inner side, another thing is fear of missing out. The fear of missing out means that because we human are the, in the society, so we need interaction with the people. And internet becomes also a small social networking for the people. They may want to interact with each other using the internet. So fear of missing out means that if I'm inside the internet group, okay, we have the Facebook, so maybe there's a Facebook club, and everybody's on there, and everybody posts some posts. And then you feel that I cannot be outside of that post. So you would like to post more on the Facebook. So it's a kind of feeling that I don't want to be ruled out. I don't want to be outside the group. Okay, so the fear of missing out may also trigger the person's motivation to use more internet, and especially on the social interaction. And also, use and gratification theory is another model that may explain the use of internet and then develop the internet addiction. That is, when we use the internet and then we found that, oh, it's so good. It can help us to improve our self-confidence. Okay, they can help us to entertain. We can get a lot of pleasure there, and it can give us some kind of empowerment. We can see some positive feedback from the posts on the social networking, something like that. So we use the internet and gratificate that we can get a lot from the internet. So it becomes another kind of positive feedback loop. And then later on, people will like to use more and more of the internet, and as they see that it's a positive side of using internet. Then we know that these are all different kinds of mechanisms that may explain why people addict to the internet. Now, how can we classify a person is addicted to the internet? Because we know everybody feel internet is good. So if I feel internet is good, does that mean I'm addicted to the internet? No, that's not the way. Actually, we will think about whether the person has some kind of features when they use the internet. Here is a model proposed by Griffiths in 2005. He borrowed the Brown's components model. The Brown's components model is based on the substance use. And then Griffiths thinks that the substance use shares similar feature in addiction to the internet. And so he thinks that the 6 components can also be used to identify, to classify whether the person has a kind of problem of internet addiction. So the 6 points are salience. That is, the person will think a lot about internet. Another is the withdrawal. That is, when the person cannot use the internet, will feel nervous. And the third point is the tolerance. That is, when the person uses the internet, it will become more and more. They will have a progress increase. And then the fourth is the mood modification. That is, when they feel sad, they feel some kind of emotional needs, the first idea to them is, oh, we need to go to use the internet, because use the internet can help us to change the mood. So the fourth point is the mood modification. And the fifth point is the relapse. That is, after they know the negative consequences of using internet, they may want to quit using internet, but they cannot do it. Okay, they always fail to quit using the internet. Then this is the relapse. And the last point is the conflict. That is, if they want to use the internet, they know it is not good, and they know that their family or their friends do not encourage them to use the internet, but they will lie. They will tell their friends that I'm not using it, but actually they are using it. So they may have some kind of conflict with their friends or family to use the internet. So Griffiths think that if we want to claim a person is addicted to the internet, basically the person needs to fulfill these 6 criteria. Okay, but this is not the only model help us to identify the internet addiction.
Dr. Lin, last 5 minutes.
Lastly, the American Psychiatric Association, we know that they have developed the
last 5 minutes
diagnostic handbook, that is DSM. In their 5th version, they have developed the diagnostic criteria for the internet gaming disorder. They have 9 criteria. So the first is preoccupation with the gaming. The second is experience of unpleasant symptoms when gaming is taken away. The third is the need to spend increasing amounts of time engaging games. The fourth is unsuccessful attempts to control participation in games. The fifth is loss of interest to other entertainments. The sixth is continued executive use of games. And the seventh is deceiving family members, therapists, or others regarding the amount of the gaming. The eighth is use of games as escape or relieve negative mood. The ninth is jeopardizing or losing a significant relationship or education or career opportunity because of their participating in games. So basically, the 9 criteria are somewhat quite similar to the 6 components proposed by Dr. Griffiths. Okay, so the general idea is that we may want to use a lot of games, a lot of internet, and we want to, to use the internet to help us deal with our problems. But if we have problems because of the internet, we cannot quit, and we may cause a lot of problems because of internet use. Similarly, the WHO, they have proposed the criteria for gaming disorder. Although gaming is not internet, but many scholars in this area consider these two are quite similar because internet is a platform for us to, engage in gaming. So when they talk about the gaming disorder, we think it's a kind of behavioral problems, and it's similar to the internet use. Okay, so the WHO proposed in the ICD-11 that 3 criteria for gaming disorder: impaired control over gaming habits. The second, increased priority given to gaming. And the third is continued gaming. Okay, so although we know there are different types of models and also the criteria proposed by the authorities to, help us know about the internet addiction or gaming addiction, but in reality, we are hard to always use the diagnostic criteria. So we need some other measures to help us to know about whether the person has a problem of internet addiction. So there are many instruments, a lot of measures by questionnaires have been developed, and they can help us to monitor the levels of behavioral addiction. And in the measures, they can be separated into majority into 2 big types. The first is generalized internet addiction. That is, we don't care about what activities are engaged on internet. We just think about internet. So it has something like nomophobia questionnaire. That is a person when the smartphone is not nearby. It's not.
Dr. Lin, last 1 minute.
Yes.
Last 1 minute for you.
Yes. Oh, last 1 minute. Okay, yeah. Sorry. Okay, so the nomophobia questionnaire means that we are afraid that the smartphone is not nearby. And the SABAS, Smartphone Application-Based Addiction Scale, is another one that can help us to assess the generalized internet addiction. In addition to the generalized internet addiction, there may have also some specific internet addiction measures, like for the gaming part, for the social media part, and for the YouTube, okay? So there are many measures, so because of the time limit, so I will just quickly to go through it. Like Young's internet addiction test is used for generalized internet addiction. And gaming disorder, GADIS, okay, these are used for the gaming addiction, okay? And these are some kind of papers that I have done to support that these measures, they are psychometrically robust across different countries, okay? And also the video clip addiction scale that can be used for many Chinese. The ICD-11 is a measure based on the ICD-11, and it assesses a variety of specific internet addictions, including like social networking, like the porn use, like the gaming, gambling. Okay, but we know that these are problematic use. So how the problematic use may link to our health? my previous studies show that the problematic use will cause the psychological distress among children. These are for the children. And also could cause the problems in sleep quality and social dysfunctioning among people with schizophrenia. And also for people with substance use disorder, when they have higher levels of problematic use of internet, they will likely to develop self-stigma. And the same situation happened to people with ADHD. When they have the problematic use of gaming, problematic use of social media, problematic use of smartphone, they will have higher levels of self-stigma and also the psychological distress. And meta-analysis done by
Dr.
me and my team.
Dr.
Yes,
Yeah.
sorry, just 30 minutes, 30 seconds.
Yeah.
Okay, we found that basically all the mental health problems are associated with the problematic use of internet. Okay, so there are a lot of issues that we can do for the problematic use of internet. Okay, I'm sorry that for the overrun for the presentation.
Thank you,
Thank you,
Doctor.
Thank you.
It's a wonderful presentation. We got to learn about so many of models about the internet addictions, and you rightly mentioned that's rising part in the current population. So there are the mental issues also, and now we do have one more cause that can be a part of this domain, and it needs to be addressed well with the so many of comprehensive measures. I would like to start the questions right now for Dr. Lin also. If any from the audience, any question? There is one question. Yeah, please hand over the mic there. Can you come forward? It will be easy for...
Hello, sir. My name is Muskan, and my question is for the doctor who is speaking about the internet addiction. So, I'm also a young one. Maybe I'm also addicted to internet. He has explained the theories really well. I understood which type of I am that I'm addicted. I realize I follow in the narcissism way. Sir, can you suggest me any solutions to overcome by that? How can I be using it in a meticulous way that I can also be updated about things and not being an addicted one to that?
So,
okay.
Tricky
I
questions.
think that we in this field we are trying to find a balance. Yes, we know that using internet is good, okay, but we don't want to overuse it. So basically now the literature is still, some people think that use too many, we may still have some health benefits, but meanwhile we may have the problems of some part of our health. So currently what we can say is that I would suggest that maybe we can have monitor how much we are craving to use the internet. So if we can stop not using it when we want to do, then I think that will be fine. Okay, but if we want to stop, we cannot stop, then we may need to find some, consultations, find some help from the health professionals. Yes, that would be my answer to you. But now the literature, we still are, trying to find a balance of the healthy use of internet and the problematic use of internet.
Thank you, sir. Thank you.
Thank you, Doctor. Anyone from the audience? Yes, please.
Sir, as you mentioned, that this internet addiction is basically, it can be overcome by the idea of balanced use of it, right? So can we say that if we are using internet as a tool and are not allowing to intervene into our lifestyle, into our personality, sir, can it be a right statement for or the suggestion to your answer, to complete your answer, sir?
Do you mean how we can know the amount of use internet?
Yes, sir. Not just the amount, but I'm basically more concerned about the factors that are leading to the increased use of internet. And as I feel as a person, that if we allow internet to be more than a tool, as something which is trying, which we take it into our lifestyle, into our culture, or maybe into our personality, if we allow internet to do that, that is really harmful. So is that correct? Is that extension to what you said?
Okay, I think that because now there are many apps, they are designed. There are many internet tools designed to promote our health. I think basically it is good for this. But if we cannot stop using this, okay, if we cannot stop using this, I think the apps help us to develop this kind of healthy lifestyles, just to let us know the importance of health lifestyles. But if we always use the smartphone or internet to help us to engage in this kind of health lifestyles, then that may be a problem. So I would go back to see if we taking out the smartphone, whether we can continue having the good lifestyle is the important thing.
Thank you, Dr. Lee. Thank you. So moving with the next speaker. Thank you, Dr. Lin.
Thank you.
Data-driven decision-making and technology in healthcare. I would like to invite Mr. Sudhakar Reddy, WASH Officer, UNICEF, for his presentation.
Thank you so much. And first of all, thanks for the organizing team for inviting me for this wonderful, very informative conference. And I'm really, really glad to be part of this today's deliberations. Since morning, like I've been hearing a lot of innovations in the health sector. My presentation is a very, very brief presentation, which is basically, it's not an innovation, but I'm really trying to bring a problem which we all of us can think through and come out with a kind of a solution in this digital era, which we talked about a lot of health innovation. So I'm not a typical public health person. I'm a water and sanitation person, but I do work with the health department in Bihar for the last couple of years. So our larger mandate is water supply, sanitation and hygiene services in the communities, but we do also work in the institutions, and healthcare, public health care facilities is one of the important mandates of UNICEF as far as ensuring water supply, sanitation and hygiene services are concerned, which will ultimately contribute to the the larger goal of the public health agenda by reducing the hospital acquired infections and putting that right infection prevention control measures in place in the public health facilities. So I'll be briefly talking about the importance of WASH and also its linkages to the health, and then the government priorities and the flagship programs around quality assurance in the public health care facilities vis-a-vis the challenges that we are facing, and how our real-time monitoring data management will really help ensuring these WASH compliances and quality assurance compliances in the public health care facilities. So my presentation is basically structured with kind of a context followed by WASH and its linkages to health, as well as the kind of WASH status across public health facilities globally and nationally, and what is the role of real-time data management in terms of WASH in healthcare facilities, as well as I said, the government mandate, the Kayakalp, using Kayakalp as a strategic opportunity. How can we really further strengthen the data management systems and the real-time data management in the healthcare facilities, and the kind of challenges that we are facing in terms of implementing the Kayakalp, and also the kind of proposed solution all through these years of our experience in Bihar and as a Kayakal program as a whole. So the context, as we all know very well, like, we have, 150,000 plus public health facilities in our country. And, public health facilities, especially the government health facilities, are, perceived in a different way when it comes to the sanitation, cleanliness and hygiene. And cleanliness and hygiene really, it plays an important role, which is basically vital for the infection prevention and control, and providing the dignified quality care in these healthcare facilities. And as I mentioned, water and sanitation really plays an important role to also reduce these infections, hospital-acquired infection, as well as and especially in the maternal and newborn care. To reducing the hospital-acquired infections and neonatal sepsis and antimicrobial resistance. But what is the current challenge that we face? Because though there are systems in place, then flagship programs in place, the kind of quality assurance monitoring systems are still manual, and the Excel sheet based, which is really limiting the real-time tracking of what is happening in an X facility in terms of the availability of safe drinking water, in terms of the cleanliness of the toilet, in terms of the availability of elbow-operated hand hygiene stations and the availability of soap, the biomedical waste management, the segregation of waste, etc., etc. So that is where is the gap now is, and what are the missed opportunities? As I mentioned, there are a couple of quality assurance programs by the Government of India, Kayakalp, and which is introduced sometime in the year of 2015 after the launching of the Swachh Bharat Mission Gramin and Urban program, with an objective to ensure cleanliness hygiene in healthcare facilities. And we also have National Quality Assurance Standard for the ensuring the quality assurance across the service delivery of the healthcare facilities. We also have a Laksha program, which basically talks about the labor room and maternity care improvement program. So these are the initiatives that we have, but the missing link is this: because of lack of real-time digital monitoring system. So this whole system is become a compliance mechanism on paper, but it's not really embedded the WASH monitoring into this system, and which is also the accountability, the transparency part, and how these systems are really helping continuously improving the quality of healthcare facilities. And now, so what are the WASH linkages to health? Why are we talking about WASH? WASH is really important in healthcare facilities? So there are different global evidences that talks about the importance of water supply, sanitation, hand hygiene, which has a direct impact on the reducing the hospital-acquired infections, maternal mortality, neonatal mortality, etc. There are positive impacts of having positive WASH services in healthcare facilities, which you can see the clinicians in facilities with poor hand hygiene were more, around 6 to 21% more, likely to have contaminated hands. And then there are also evidences that hand hygiene interventions significantly reduce these MRSA cases in high-income countries, and then clean birth practices linked to reduced neonatal deaths from sepsis and tetanus. And we also have hygiene interventions consistently proactive against healthcare-acquired infections. So these are a couple of global evidences, national evidences that we have, which shows the importance of safe water supply, sanitation, and hygiene facilities in healthcare setting. I don't know, it's not working. Can you please change the slide? Please change the slide. Go back. Yeah. And when we talk about the data, the availability of wash services in healthcare facilities, so UNICEF and WHO releases a joint monitoring report. If you see the data gaps in terms of water supply, sanitation, and hygiene. So the JMP 2022 says the availability of water supply. So if you see, out of this many countries, we have only 47 countries could report the data on the water supply, sanitation, and hygiene, of which only 76% healthcare facilities found to have water supply. Sanitation, there is no data available. Hand hygiene, only 54% facilities found to have hand hygiene facilities. Waste management is around 55%. And then in 2025, there is a slight change. Water is moved from 76 to 78. Hand hygiene is from 54 to 57. Waste is reduced from 55 to 54% in 2025. And this data includes India data. But when I further digged what is happening in India, unfortunately, there is no data available. The latest source that I found is the Rural Health Statistics 2022. If you see the report, the availability of water is only 91%, and this data is only for the primary healthcare facilities and below, PHC and below facilities, not all the facilities. And the important thing is, after this 2022 report, Government of India has renamed this report as Health Dynamics of India, and the WASH data is completely disappeared from the report. So now you are not in a position to see what is happening around water supply, sanitation in the public healthcare facilities. And there are still gaps. If you see sanitation, it was only 51%. Hygiene, there is no data. What is happening around hand hygiene, and we have seen in the previous slide that how important hand hygiene is in terms of reducing the hospital-acquired infections. Waste, it is 72%. The electricity coverage is only 90%. And then, since this is a very informative workshop, we talk about a lot of real-time data monitoring systems, innovation. So how does this really help in terms of real-time wash management? So what is the need of real-time data management? It really enables the timely action and also improves the accountability of the healthcare facility stakeholders, right from the beginning, the frontline workers to the public health facility stakeholders at different levels, so from PHCs and CHCs and district hospitals, etc. And it's also strengthened the decision making. When we have a real-time monitoring in place, we'll be able to see where are the gaps, and then the decision making will be really improved, and accordingly the resource allocation also will be improved to be able to address those gaps in these healthcare facilities. It also sustains the quality standards in the healthcare facilities and empowers the frontline staff who are working day in, day out in those healthcare facilities. As I mentioned, Kayakalp is an opportunity which I say is a missed opportunity for all these last 10 years, which would have been a really great opportunity to really improve the quality standards in the public healthcare facilities, which was launched sometime in 2015. The primary objective of the Kayakalp is to really incentivize facilities which are really demonstrating excellence in the wash and quality assurance programs. It has a 3-tier verification system, a self-assessment followed by a peer assessment and an external assessment across different 8 thematic areas, and more than 50% indicators are directly contributing to the water and sanitation and hygiene waste management. What is the current challenge? As I mentioned, it is still an Excel-based assessment at all 3 levels, and we're really not able to see what is really happening in an healthcare facility which has conducted self-assessment, peer assessment, and external assessment, where the facility is really lagging behind. How can we support the facility to be able to make this facility as Kayakalp compliance? So that is the real challenge that we have. And it is an opportunity for this digital transformation if we can have a real-time dashboard in place, a centralized data system, which will really track the wash scores and also identify gaps and trigger corrective actions. Sustain compliances beyond assessment cycle. It's not just when we do the peer assessment or an external assessment. How can these facilities sustain the quality standards around the year so that this infection load is reduced in this particular healthcare facility, and also strengthening the accountability and transparency. This is the journey of Kayakalp, which started in 2015. But one important point what I want to emphasize here is, if you see, in 2024, Government of India introduced an additional scoring pattern for WASH, and WASH now is mandated. So if any facility to be qualified as a Kayakalp certified facility, that particular facility first need to be qualified in the WASH parameters. So there are 47 direct checkpoints which are related to WASH, and then 70% of qualification in among those indicators is mandatory now to be able to qualify that facility for the Kayakalp assessment. So this is an opportunity, and these are the different thematic areas that we have sanitation and hygiene, support services, hygiene promotion, eco-friendly, beyond hospital boundary, hospital upkeep, waste management, etc., etc. And as I mentioned, as far as data is concerned, even today, this is a 10 years old program. We do not have the data that like how many facilities in a state are really Kayakalp compliant. So I have to dig down, and the source, if you see, it's a Lok Sabha question. And then I have to dig down the data from there, because we don't have any central server or a data management system to really want to see how many facilities are Kayakalp compliant as on date. So if you see, it is the status of the district hospitals. There is, of course, gradual increasement from 97 to 446 in 2022 to 23, but still, if you see, 50% of the facilities are not still compliant. And facilities, those are compliant, again, there are sustainability challenges. So this data shows when the external assessor goes to the facility and conduct the assessment and give more than 70% score, it is qualified as Kayakalp. Then what happens after that? Whether it is really sustained that kind of a compliance system over the years and also throughout the year. So that is where is the actual challenges. If you see all healthcare facilities, see the blue color graph, it is still flat. And if you see the total number of facilities versus facilities qualified for Kayakalp, it is still there is a long way to go. And I strongly believe that this kind of a digital data systems will really help enhancing this compliance system. So the current challenges, as I mentioned, it's an annual cycle, but unfortunately it's a kind of a tick mark activity that there is a self-assessment followed by peer assessment followed by external assessment, but facilities which are not really participating for the ages. And we really don't know what is happening in those facilities. And those facilities which are participating but not qualified, we're really not able to see where that particular facility is really lagging behind, so that this particular facility could not qualify for that particular year. So that is the limitation that we have because of these Excel-based assessments. Limited thematic insights, as for example, if a facility is lagging behind in biomedical waste management compliances, do we really know how many facilities which are participated in Kayakalp are lagging behind in biomedical waste management compliances? If you know that, then we can have strategies to handle that particular facilities, increase the financial allocations, technical assistance, so those kind of challenges are there. And then unsustained compliances, as I mentioned, when there is an external assessment, then so all those things are, in order, and the assessment is done. Then once the assessment is done, the certification is done. Then what is happening after that? Whether it is really sustaining all the years. So that is again a gap. And then WASH compliance monitoring, again within this, what is the availability of water supply, toilet facility, how many toilets are there, gender segregated toilets, and then MHM friendly toilets, then the cleanliness of the toilet, the cleaning cycles, everything. So availability of soap. So those kind of tracking mechanism is still lacking.
Mr. Reddy, last.
This is my last slide. What is the proposed solution which we have been working with the Statal Society Bihar here, UNICEF, our WASH section and health section are closely working, and we are trying to come up with a digital solution for that, which still we have some time to really materialize it. But we think that digitization is the only way this will really help making this quality assurance program and these healthcare facilities compliant, including this all 3-tier verification systems. We need to develop a kind of a system, a dashboard where highest authority at the department level can see what is happening in the healthcare facilities in terms of quality assurance. And then we can see where are the gaps and how to really fill that feedback loops, and how do we really strengthen those facilities which are non-compliant to these standards. So this is how we thought that a really real-time digital data management system would really help ensuring the quality standards in the public health facilities vis-a-vis the WASH standards, which will ultimately contribute to the reducing the burden of infections around public health facilities. Thank you so much for giving this opportunity, and looking forward for any questions. Thank you so much.
Please give a big round of applause. Thank you. Thank you, Mr. Reddy.
Thank you.
So basically now we do have lots of tools to improve the quality in our health facilities. Started from the Kayakalp, then we do have now the updated NQS. There is also updated checklist for IPHS assessment. And all talks about one thing, that improve the quality so that we can improve the quality of care. Wonderful presentation, sir, wonderful presentation. And I absolutely agree with the tracking part, where these facilities are not being tracked. These facilities are quite not being tracked for a longer time, that if the inspection gets over, record, reports has been done, then what happens in terms of service? Same is happening in NQS. Once the NQS percentage, the scoring gets above 85, then they will be eligible for awards. And then what happens with the service delivery? Is it improving or not? That one has to check from HMIS data. So it's rightly agree that we need a system to track, monitor, and also to take actions in terms of governance. Before crowd goes there, I would like to understand a few things. We do have NQS, sir. Now there is 8 area of concerns. We do have miserable elements. When we talk about NABH, now NABH is not going for this kind of wash. They had a more comprehensive part. And we want to move towards the NABH, now the NQS. There is a Gunank app for NQS. So what needs to be done if we can club Kayakalp within the NQS? Because there are the 3 area of concern which already address the Kayakalp and WASH areas. But still, as a public health professional at the government side, they need to do the 3 times of NQS also for the Kayakalp. What is the solution, sir? How can we address less burden and clubbing all quality parameters into the single system?
So, my experience says, like, Kayakalp, say for example, Kayakalp is a very, very comprehensive tool, largely focusing on the basic cleanliness, hygiene parameters of a healthcare facility. And NQAS is a bit, higher version of the Kayakalp, which has a lot of infection prevention control related indicators. Now, when we talk about public health care facilities, say for example Bihar, there are different kinds of healthcare facilities. We have sub-centers, we have ARM PHCs, health and wellness centers, PHCs, variety of healthcare facilities. When you see the infrastructural gaps, the quality of infrastructure in the healthcare facilities, what I personally feel is the Kayakalp is the basic minimum standard for a healthcare facilities, for an interior rural public health facility. If that is ensured in that particular facility, then we can talk about NQAS and other, NABS standardization. For my concern is, if I go to a rural PHC, the basic concern is first itself. So we are still struggling to really, come over of those challenges. So if you ask me for the medical colleges, for the district hospitals, that is right. We can have one comprehensive tool which can talk about all these parameters. But I don't know whether it is really possible or feasible for a public health facility, public health center, RSCHC, in a rural Bihar, if you club everything together, and it looks very ambitious for a kind of a facility where basic, minimum infrastructure and facilities are not there. So that is what is the problem. I don't think if you club everything together, it's really going to help. Yeah, for data management and systems and for the feasibility of, reducing the burden of the assessors or the healthcare facilities, that is fine. But what is the practical, solution that we are coming out? And even we are creating more complications to those, PHCs. That's what I feel.
Thank you, sir. Thank you, sir. And to the sir says, that data is not available. Sir, data hai, hame nahi milta. They do have data.
That is there. So I really see. The challenge for us is we work very closely with the system. Day in, day out, we work, our consultants sit over there, we manage everything, but even then, we don't get the data, the Kaya Kalp data that we have been struggling for years.
Yes.
So we offer our technical assistance to the department. If you get the data, we can analyze the data. Even if it is an Excel sheet, if I get the data, I can really see which healthcare facility is really lagging behind in which thematic area. That data, I don't require a data that how many facilities are completed peer assessment or external assessment. That data doesn't really give you any kind of an insight.
Agree.
What is actually required is the indicator-wise data so that we can analyze, but unfortunately it is not available in the public domain, and government is not really open to provide those kind of data systems. That is a challenge. That is why I was keep talking about this real-time data management. So we do advocate with the department. We are working towards that.
I hope they are tracking real-time and doing the actions. Any questions from the audience? It's a very important topic, the current health system where quality matters the most. Okay, let's move to the next speaker. I would like to invite Mrs. Rekha Raj, Health Officer, UNICEF, for the presentation.
Good afternoon, everyone. And please put on the slides, please. And first of all, I would like to thank the organizer for providing us the opportunity. And in my slides, which is on data-driven decision making and AI in health, I will focus on how the data and the digital innovations which are taking place at the national level, and they are influencing and they are supporting the programmatic decision and also helping us to strengthen the MNCHA and immunization outcome at the national level, state level, districts and below. So setting the context of the presentation, the voice is echoing, I think. Yeah. So just put on the presentation. Yeah. So just setting the context for the presentation, as you are all aware, that SDG 2030 agendas, it calls for leaving no one behind. In health system, what does this mean? It means that using decisions that, which are based on evidence and that benefits maximum population and not only a few or average population. And also evidences have shown that India and also Bihar have made notable progress in the MNCH indicators, but still the inequality persists, and basically in the hard to reach community. In order to address this, there is a transition going on within the government and also among the partner to move from the paper-based to digitally enabled health system. And these are being done basically for the purpose to strengthen the reach, accuracy, and accountability. Now, if we talk about the UNICEF vision for digital health, it is very much aligned with the vision of the government. And we are also, UNICEF Digital Health Framework also emphasize equity, and it talk about a system which is very user-centric, which is scalable and is sustainable, and based on the data's decision can be made on a real-time basis. So we are talking about a system which can be easily integrated with the national or the state level systems. In my presentation, I will be talking about the ongoing digital interventions for data-driven decision making, and here I will focus on two of the important tools, digital tools, which are being piloted at the national level, and UNICEF is closely working with the Ministry of Health and Family Welfare in piloting these interventions. These two interventions include the U-Mentor application, which is an application for immunization analytics and real-time micro-planning. And second application is the RCH 2.0 portal, which is a name-based tracking and service delivery portal. And in the end, I will also talk about some state-specific initiative, which is on digital and AI chatbot, which has been developed for the frontline workers and to support them in community engagement. So starting with the U-Mentor application, it is an application for universal immunization program, and it is basically, will be used for monitoring and mentorship app. And it's aimed to become the national unified platform for routine immunization, planning, monitoring, and mentorship. Means everything in a single platform. This slide shows that what was the need of bringing the U-Mentor application within the government. It is because of the current challenges in the current monitoring system, which is that every states and every partners, they are using multiple formats for reporting and monitoring, and all these data, they are getting stored in multiple monitoring format. So at the end, it results in fragmented monitoring data. In order to overcome this, government has come with a U-Mentor application, which will be a single unified government-owned and managed platform for routine immunization monitoring, and it is very much aligned with the UN design. And for this, UNICEF have partnered with IIT Mumbai to develop and manage the application. This application is getting developed under the Gavi HSS3 project, and as a transition plan, it will be transitioned to the agencies at the end, which is identified by the Ministry of Health and Family Welfare. So what is different in this application? This application not only includes the monitoring formats, but there is an inbuilt integrated quarterly supervision plan for the government and the supervisors, including the partners. There is a real-time dashboard for monitoring the data so that government can make real-time decisions. Thematic scores based on the monitoring, thematic scores will be generated for each of the session site and cold chain point. And also the mentorship aids have been standardized so that it is uniform across India. This is just the interface of the U-Mentor application. Just like UWIN, once you enter your mobile number, then an OTP will be generated, and this page will open, and we can interact with the system as required. So if we talk about the U-Mentor pilot coverage and the key results, then it has been piloted currently in 8 states, 16 districts, including 2 districts of Bihar. And during the piloting, the application has been tested across various features which has been mentioned here, and all these findings which have come during the pilot phase, they are getting integrated, and the application is getting revised, and we are hopeful that we will get the revised application by December end. And following this, there will be training of the supervisors at the national, state, and below level, and also the quarterly supervision plans will be developed based on which the monitoring will be done. So this is just in a nutshell because the time is short. So I am just talking about in a nutshell what are the innovations which are being carried out at the national level. Second big innovation is the RCH 2.0 portal, which is going to be a single unified RM and CHA data set for the state and the national monitoring. And it will support planning, resource mobilization, and targeted interventions. Now, if we talk about the key features of RCH 2.0, then it is designed to benefit all levels of health workers, from the policymakers to the program managers to FLWs. And it is one of the largest longitudinal database. It is integrated with ABDM. It is ABDM compliance, means Ayushman Bharat Digital Mission. And there is a real-time dashboard. In a single click, you will have access to all the digital portals and MIS. It can seamlessly integrate with all the digital portals and MIS, and it follow a life cycle approach. It is very user-friendly, and also the digital MCP cards will be available based on which the capturing of data would be made very easy. Now, I am just talking about that once the RCH 2.0 is rolled out across the nation, then it will cater to a user base of 700 million plus users. The concurrent users will be more than 1.5 million per day. API integration, if we talk about the API integration, then more than 400 plus API will be integrated in the system, more than 400 plus security control, and it has a server base which can store more than 10 years of estimated years of data. So a very large database we are coming up with the ministry. Now, if we talk about the rollout status, then out of the 10 states where this RCH has been rolled out, Bihar has been selected as one of the 10 national early adopters of this portal. And after the successful pilot, it has been scaled up in all the districts of Bihar, and the portal is live from 1st December 2025. So RCH 2.0 portal is not just a reporting tool, but it is basically a future-ready digital backbone which will provide strong foundation for integration and data analytics. And once this RCH 2.0 portal is rolled out across India and Bihar, then it will obviously, with such huge database, it will provide space for predictive modeling and also scope for AI interventions and models. Third, I will talk about another innovation which is the Disha chatbot, which is a conventional WhatsApp-based chatbot which has been designed by UNICEF. And this chatbot basically provides role-specific digital learning support across the 4 primary healthcare areas. And you can clearly see the 4 primary healthcare areas have been mentioned below. In terms of the usability of this chatbot, it is very user-friendly. It is persona-driven, easy navigations, and games and quizzes have been incorporated in this chatbot to make it more engaging. And also In order to assess this chatbot is available on the UNICEF Health India website, or you can just add this number to initiate the chat. It is available in multi-language, as you can see, and to start the chat after adding this WhatsApp number, you have to write Disha, and it will start following the sequence. So the target user for this application is ASHA, ANM, and other supervisor, LHB, and MOs. And for the program manager, it is basically for the decision making. So Disha, it comes with advanced data analytic dashboards to monitor the users and the learning outcomes, because there are various modules within this Disha chatbot, and it is very essential to know that whether the frontline workers are actually learning from the bot or not. So this real-time dashboard provide an opportunity to monitor this, and in turn helping us to enabling us to make data-driven learning outcomes. In terms of the scale-up and the roadmap, it has now been implemented in 3 states and is scaling rapidly. So this is the last slide, and which I will just focus on the Bihar-specific use case on AI and the key learnings, because AI is just, we have initiated 2 of the projects. Some of these are still in the pilot phase. First is the HBYC reporting AI tool, which is basically a digital HBYC checklist for complete and structured data capture for ASHA. And second is the Health Vani, which is based on generative AI-based assistant, giving real-time guidance on RM and CH answers for the ASHAs. So a few of the AI components have been included in these tools. And as we are piloting these interventions, few of the learning which is coming out from this pilot is that, and the challenges which we are facing in implementing this AI tool is because of the low literacy of the frontline workers. Also, there is a mismatch between the dialects which the tool is providing. And in the tool, there is also an option of auto prompts. So sometimes the instructions are not very clear. So we need to come up with a more user-centric design. So I would like to end here, my presentation here. And in the end, I would just like to state that AI has the capacity to strengthen the health outcomes when designed for usability, equity, and responsible use. Thank you.
Thank you. Thank you. So wonderful presentation that travels us from the different aspects. The latest part is the WhatsApp chatbot, and it uses a simple algorithm and provides more profound conversational aspects of the chatbot. And thank you for that. Any questions from the field, from the audience? I can see there are many field officers who are the part of the audience. If they would like to ask any questions. That's it. Okay, so moving to the next presentation. I would like, but कोई question ठीक है. So next questions की तरफ बढ़ते हैं. I would like to request Dr. Mausmi Gupta to talk about use of AI to detect and diagnose disease progression.
Good afternoon. I'm standing in between lunch and here actually. Yes, I will not take much time. I'll be very brief because from yesterday we are listening AI, data, and what can be done through data and what are the data needed. So I don't think there are some more thing is required over here, because from yesterday I was thinking what are the inputs from my side I can give.
because whichever we have listened from all the experts, and I feel we have almost covered all the areas, and there is nothing more I can now add into it. But yes, I prepared a very brief presentation over here, and that inclusive of my work, what I have done with my team through AI, and few of the work only I had given. Yes, whenever we talk about AI as Tanmayji was telling yesterday in his presentation, that AI requires data, and that rated data requires lots of scalability. It should have a potential to give you some kind of output. So that preparation of data itself is a huge task. First, collection of data. As sir was mentioning, data is there, but no one is there. Taker is not there. As well as data is there, but taker is telling it is not publicized. It is not in public domain. Yes, we cannot put all the data in public domain, but a demo of those data can be put in public domain for the student, for the research institute, so that the student can do some pilot. Yes, pilot is required to do a kind of sampling and all. So whenever there is a AI as a terminology it comes machine learning, and my field is image processing, and AI is there, so it is related with statistical decision theory and pattern recognition. As I am from computer science background, and I hope all of you are, yes, there are varied background is there over there, I can see, but majority is the health professionals are there. So AI, whenever we talk about AI, it is totally data dependent and data structured, all the ethical and clearance and all, and data should be very correct. There should not be minimal number of null values. That is the requirement is there, and whenever there is a AI, machine learning is required. And whenever there is a machine learning, data should be very large amount of data. We cannot train the system with small amount of data. We require large amount of data, chunk of data we require, and then only we can train the system. And image processing, yes, it is my area. That is why I have included here image processing. What we do in image processing is, for the computer, we train the computer that image is nothing but it is a three-dimensional matrix, and we would like to find out if there is a abnormal or if there is a discontinuity there is in the given matrix, and we try to figure out those points wherever there is a discontinuity is there in the given matrix. And that we do in the statistical decision theory, and this discontinuity we find out through pattern recognition. Pattern recognition is not like it is the line or a square. It is a kind of sequence of, if I am talking about 0-1 bit, it is a sequence of 0 and 1 combination, wherever how we can train the system with these zeros and ones pattern. That inclusive of, this is the whole of my work, and I have done few work with microscopy data as well as colposcopy images, as well as radiology images, as well as geospatial imaging. If you go to the next slide. Yes, this is a very, just a glimpse of work done we have done. And this is, we took WSI scanner images, and it took the whole slide in at once go. And the medical professionals are the pathologists with us, and they validate our outcome, and we have little bit of automated grading. It is, yes, if a pathologist is sitting over there, they definitely can argue with me. You cannot detect the grading, our system cannot detect the grading. Yes, it can detect some kind of abnormality, that is when it is coming to dysplasia, and after dysplasia when it is coming to the malignant. That kind of change of behavioral or change of pattern can be detected, and that we have detected. Go to the next slide. This is, I had given, it is there. Okay, okay. This is I had given for your information that the work is published, because if the work is not published, we consider that our work is not yet complete. So that is why we can say, no, I'm not saying it is complete or the field is already closed. But yes, whichever our finding, the little bit finding, it is published and read by few of the researchers. Next slide. Yes, and one more work we have done with cervical cancer, that I was in Sikkim, and in Sikkim it is for hilly region, people, there are primary health cares are there, and people cannot go far out if they are do not have that much economic, socio-economic status, or for their terrain also, due to kind of travel through hilly region, they cannot go to the city hospital then and there. So we tried to, and we have seen there are mostly in the primary healthcare hospital. We have went to few of the primary healthcare center. They have colposcopy devices. If the whoever is the medical officer over there, if they take the image of through the colposcopy image, and it can be, if it can be sent to the city hospital, and then and there, if someone else is sitting and can give a kind of diagnosis for pain relief, or to a kind of then and there medication, if it can be done. And this work we have done with Sikkim Manipal Institute of Medical Sciences. Dr. Anna Thattal was a gynecologist over there, and we few outcome we have received. But here again, I am very much not yet satisfied with publication is there. But we are developing, but whenever there is, we are giving it to some user, that time that user is not coming to us, yes, we will use it. We are providing the software to the user, we are giving them the guidance, but the users are not coming, yes, we are using, and these are the errors are coming. That kind of thing I am still facing actually is whenever we develop some kind of software or some kind of say framework, the user, the end user is not very keen to use it that. But if I'm coming from TCS, or they are buying it with few lakhs, or the more than 10 lakhs or 60 lakhs, the same thing, they are very keen to use it. But whenever I am delivering it, we have, my student had developed, if you can use it, that time they are showing very ignorance that our student done, okay, we will use. that kind of thing. Why this mentality is coming, I do not know, but it is there. Maybe we are not at par. Yes, they are not telling us in our face that, ma'am, you haven't done the work. But I require that thing. No, ma'am, you haven't done the thing. If you can do this, then we will use it. That kind of, if the input, if we get, the student will also get benefited. And yes, one more work I put in this slide is ICMR had given us a kind of COVID-19 vaccine data. With that vaccine data, we some kind of conclusion we had made, and with that conclusion, I can tell there are two findings from our side. It is we had made is that during the period of COVID-19, the person who was affected, that person become isolated with their families and everyone, to closer ones as well. But as per as our finding, it is a very contradictory over there is there, because when that disease is not following any kind of pattern, it is a very haphazard whenever we have seen the pattern of COVID-19. And next. And this is actually one other finding is there that is published in Nature. They provided in their news item as well that we followed wherever there is a railway network is going, that pandemic is more in those areas. And yes, sorry. This is my present work, which I'm presently working on with the Mahavir Cancer Sansthan, with Dr. Ashok Ghosh and his team. And we have taken a few lung cancer, and hypothesis we built up is female population, non-smoking female population, and mostly they are residing in indoor. And they are affecting with lung cancer. I'll show you the number of these patients. Next slide. Yes, no, not this one. No. Sorry, go back. Yes. These are the number. If you see the total, we segregated only female population, that is also non-smoking female population, and the female affected, number of female affected in one hospital, that is in Mahavir Cancer Sansthan. That is from 2015, we can see as an average there are 200, say, females are affected with lung cancer. Then I cannot say we can determine the cause is the pollution or whether it is something else. We are trying to find it out. And this is the data we took from Mahavir Cancer Sansthan. We digitized it. And this is the scenario. And this is my present work is. So as a conclusion, if you can go to the last slide. The conclusion is, and this is the age also. Age-wise, we have segregated the females, and from 0 to 20 is also there. That if we can exclude, there are. I feel it is the number is very prominent number of females they are affecting with lung cancer. That is also in one hospital in Patna. So I felt if we can study this thing, and we prepared a questionnaire. Till now we are interviewing the patient's family and the patient as well. And this is the last slide, and thank you. Conclusion slide. Okay, I removed that here. Oh, it is there. Last slide. Go to the last slide. Sorry, I'm disturbing you. Yes, definitely we can conclude that data analysis is there, and in other state, in other country, they are doing much better than us. But definitely there is a reason behind it, and we have to overcome from these things. And digitization, we have already done. Whenever there is a chat GPT or any other digitization is coming in the market, we are, as a Indian population, we are using it. We are not saying it that we will not use it. When WhatsApp is there, if you see the other thing also, we are the very significant user of it. So why not making from our side only? So let us hope if with this kind of small gathering, if we can do something better. Thank you very much.
Thank you. Thank you. Wonderful presentation that teaches us about machine learning, how the AI is being built through the machine learning, and the image processing section that is now more refined over the period, and that is going to take shape. So currently when we used to study about MD, we choose most of the times radiology was the first branch that has to be taken, and now if you want to purchase MD medicine, MD radio, it's the costliest part. But now the AI soon, and just like computer science professionals is going to take place of radiologists, that I am sure in a near one. Any questions for quick, so we can move forward with the next? Yeah. So if there are any questions, we can have a small group of discussion during the lunch period. But before that, before breaking up for the lunch, there is one more session, more speaker. I would like to request Dr. Tanmay sir to call upon the guest speaker for key messages to the audience and to the persons.
Thank you, Dr. Harsh. Having such an esteemed panel of Dr. Moushumi, Sudhakarji, Rekhaji, and Dr. Harsh on the stage, it's also good time to reflect a little bit. In a hungry mode, I'm extremely sorry, but we are hearing from yesterday that from AI needs to learn from history and protect the future. And in this journey, if we just think a little bit, this is Bihar, where the whole world used to come to learn. There are several religions which got its birth from here. And then, during 2010-11, over a communication with the highest state authority and Gates Foundation, there started a journey of Bihar Technical Support Program, evolving into Bihar Techno-Managerial Support Program, now in optimizing Bihar State Health Program. For this, from yesterday, we have heard several times about the contribution from Gates Foundation. Let us hear a message from Gates Foundation Senior Program Officer for Global Development Bihar, Dr. Akash Malik, a public health leader, a doctor who has contributed significantly in the large-scale digital national platforms like CoWIN and UWIN, and also leading the health system strengthening and other aspects in Bihar. I also welcome Dr. Ashmita Gupta to be here to welcome Dr. Akash. Over to you, Dr. Akash.
So all the people who are listening to me, I'm not that great as Dr. Tanmay sounded. I'm just a perpetual learner of public health. And first of all, I would like to apologize. I was supposed to be there in person, but I'm currently in Assam, Golaghat district, for a meeting with the MD NHM here, as we are also starting our programs in Assam. So I thought that why not just come in and congratulate the entire ADRI team for putting off this conference or international conference on innovations in health technology, health information technology. And I think what a way to begin my address than hearing Dr. Maushmi talking about artificial intelligence and large language models and how they can impact and improve the health outcomes and also help our decision makers to use data for better programming. What I understood, what Dr. Maushmi was very, as a student of computer science, as I know, was very explaining very technically. What I understood is that AI is not a magic wand, right? And it is not going to take away any of our jobs. It's just there to make our jobs easier. And there's a joke among AI experts that AI is 95% correct and 5% wrong, but no one knows which 5%. Right. So for that decision making, we and our expertise, each one of us sitting in the room is required, whether we are from any field, whether we are from public health or clinicians. Our interventions, our support will be required because, as Dr. Maushmi mentioned, AI works on a GIGO principle, garbage in, garbage out. So the kind of data you put in, that's the kind of output it will give it to you. It does not have mind of its own as of now, and hallucinates a lot and the hallucination is just because of the erroneous data that goes into it. Having said that, I think Bihar is at a pinnacle of health system reforms, wherein it has digitized, I think, all the levels of service delivery, starting with the command and control center at the highest level at the Department of Health and the State Health Society, the Bhavya application, which is a facility management system, which has digitized at least the OPD services from the district hospital up to the health and wellness centers, the CHOs, that is through the Bhavya Lite, and now we have the ASHA application, which digitizes the ASHA work or the ASHA activities, ASHA level activities. And we already have the ASHA portal at the ANM. So very few states have digitized each and every level of service delivery when we speak about health. But as my esteemed speakers before me mentioned, the time here is to see how we can integrate these vertical solutions or digital solutions to ensure that the data which is generated across all these platforms can be utilized and can be used for database decision making. And that's where we at the Gates Foundation are working on to help the state to come up with specific case scenarios to demonstrate a digital continuum of care, starting from the VHSND level where the data entry for a high-risk pregnancy, for example, goes in to the PMSMA where the first ultrasound happens. And then if the high-risk pregnancy is identified through a good quality ultrasound, which is read by, if a radiologist is available, and if not, a well-performing and a well-trained AI/ML system, can then the high-risk pregnancy be timely referred to a facility called an FRU, where the intervention happens, saving both the mother and child. Similarly for anemia, right? Once the diagnosis happens, whether that can be, how we can ensure a digital care continuum. And as I'm taking a lot from Dr. Maushmi's presentation because I heard it very diligently, is the user interface. I think COVID demonstrated to us that if you give an acknowledgement to the user in terms of what services the user has got, who has given those services at what time, and if that certificate is valid across the globe, and that is what COVID did, that certificate was valid across the globe, I think the confidence in the system increases and more people want to then take that services. Now that we have digitized the service delivery aspect of the services being provided in public health, how we also give an acknowledgement to the beneficiary, which will also serve as a trigger or a reminder system for the next level of services or the next due date of services. I think that will increase the confidence of the beneficiaries in the system, and more beneficiaries will come up and take up a digital system. And as mentioned by Dr. Maushmi, gone are those days when we used to say that there is very poor digital literacy or there are network dark areas. I think maximum number of TikTok users were from Bihar at some point of time. So we are now in a stage where I don't know the number, so I don't want to try and convert it into a number, but majority of our population is using mobile phones, smartphones, having some of the latest softwares. They are recording videos, they are using WhatsApp for communication. Whether it's safe or not, that's a different question. But the digital literacy is at its peak in the last 10 years and will grow further. So how we use this opportunity to ensure that we also bring in the beneficiaries into the scheme of things rather than just a supply side focus in terms of health information and technology. I'll not keep you away from lunch more, and we'd like to end with with saying that the Gates Foundation is committed to build up use cases for AI across India. And Mr. Bill Gates is a big fan of AI, and he believes that AI will surely in future contribute in a big way, introducing the mortality for mothers and newborn in areas where the services might not reach in time. So happy to partner further. Adri has been a trusted partner for Bihar and for Gates Foundation for many years. So hats off to Dr. Ashmita, Dr. Moshmi, Dr. Tanmay, and the entire organizing team, Dr. Sanchita, for pulling this off. And I promise for the next version of this conference, I'll be there in person, and I will be there, not in one of the panels, but learning in the audience for sure. So thank you so much, and all the best. See you. I will take your leave. Thank you.
Thank you so much, Akash. Very nice of you to join. I know that you are in the middle of another engagement, so thank you so much. So I would also like to say this, that just a year back, we had organized a data conference, which was also an international conference, which talked about similar themes. This conference just seems to be a perfect follow-up with which is focused on health, and we hope that there is a series that we undertake and we keep doing it on various issues of data collection, data analysis, data quality, data storage, ethics. So there are multiple themes around digitization and data use, and it is across disciplines. So hopefully this conference will bring together like-minded minds, and based on our institutional strengths, we will keep doing such events more and more. So I would thank our panel for this excellent set of talks. And I think we are already, like Maushami already said, she's standing between lunch, but we already had so many talks after that. So let's start the presentations and then we move on to lunch. Thank you.
Hello everyone. So I think we are way past our lunchtime and our oxygenating cells are secreting at full capacity. So without any further ado, we would like to move forward to felicitation. I would request Dr. Harsh to felicitate Mr. Sudhakar Reddy. I would also like to ask Dr. Harsh to felicitate Mrs. Rekha Raj, Health Officer, UNICEF. I would also like to request Dr. Harsh to felicitate Dr. Mausami Gupta, Senior Research Lead at ADRI. Now I'd like to request Dr. Ashmita to come to the dais to felicitate Dr. Harsh. big round of applause, please. Before we move forward to lunch, I would like to thank the project partners, Bihar Health Society and Gates Foundation. I would also like to thank the sponsors of this event, SBI, Rodic, IIHMR Delhi, Axis Bank, and our healthcare partners who are Medanta and Sen Diagnostic. I'd like to extend my gratitude towards academic partner AIMS Patna and also the publication partner Springer. We have a plethora of knowledge partners, that is UNICEF, PCI India, Pune University, Digital Bharat Initiative, Piramal Foundation, IGIMS, IIPH Gandhinagar, TISS Mumbai, and Yodh Foundation. We have the stalls of IIHMR, SBI, and PCI Foundation at the back of the hall. In the lunchtime, you can visit those stalls as well. We can proceed for lunch now. Thank you. We are a bit tight on schedule, so I would request you all to complete your lunch by 2:30. Thank you very much.
We will be starting shortly. I request everyone of you to please be seated. We will start in 2 to 3 minutes.
Good afternoon, everyone, respected guests and participants. We hope your lunch break was refreshing. I am Danish Razdan.
And I'm Neha Gupta, and it is our pleasure to welcome you back on the afternoon deliberations of day 2.
To begin our post-lunch proceedings, we move into panel discussion 1, titled Policy Perspectives for Technological Innovations in Diagnosis, Treatment, and Surveillance. This session brings together distinguished leaders working in the intersection of clinical excellence, surveillance system, and public health governance. We are honored to invite Shri Mukesh Kumar, Economic Advisor, Ministry of Corporation, Government of India, to chair this session. He has served across major central ministries including Agriculture, Rural Development, Health and Family Welfare, and Tribal Affairs. His leadership experience spans public administration, policy strategy, and inter-ministerial coordination. So now we would like to invite our panelist for our first session is Dr. Veena Singh, Professor and Head of Burns and Plastic Surgery, AIIMS Patna. She is a gold medalist surgeon through MBBS, MS, and MCH. She holds multiple fellowships and leads national research initiatives in burns and epidemiology, chronic wounds, craniofacial surgery, hand function recovery. Our next panelist is Dr. Abhiniti Srivastava, transfusion medicine specialist at Medanta, Patna. She is established Bihar's first NABH accredited fully automated blood center, has supervised over 50 autologous bone marrow transplants, and hold advanced training from Tata Memorial Hospital and KME Mumbai in immunohematology and stem cell cryopreservation. Our final panelist for the session is Dr. Ragini Mishra, State Epidemiologist, State Health Society, Bihar. She is a CSIR JRF awardee with an ICMR postdoctoral fellowship and has led Bihar's disease surveillance system, authoring several books and publications while receiving multiple national and international honors. With all dignitaries on stage, we now request our chair, Shri Mukesh Kumar ji, yes, sir, to kindly lead the proceedings and take the discussion forward.
Good afternoon and welcome to the post-lunch session. And I believe that after having so much wonderful food, it would be difficult to keep you awake. But we have very wonderful speakers in the post-lunch session, and their topics are also very, very relevant. And they will definitely try their best to keep you awake and keep you interested in the topic that they are going to deliver upon. We have been given 30 minutes time, so 10 minutes for all of you. And after that, 25 minutes would be for question and answer session. Regarding generative artificial intelligence, I was listening yesterday also, I was there. So I found that some of us were very skeptical about generative artificial intelligence solving our health issues. But I am quite enthusiastic. If we see the history, evolution of human history, and vis-a-vis the health sciences, the manner it has evolved, I feel, I don't know whether you would be agreeing or not, we are at a very Goldilocks kind of situation, where we have technology with us to help us, we have enabling governance to help us resolving health issues, we have international coordination. So, and we are living in a world where most of the people are literate, educated, they understand, they have information, and of course, we are more aware than we used to be in the past. So I am quite optimistic. I'm very optimistic that, without the use of generative AI or artificial intelligence or the advanced technology we are talking about, it would be rather very difficult to reach up to 1.4 billion population, providing them health services, giving them equal access to health services. I believe that, technology would be of great help to us for that. So over to the first speaker.
May I go to the next slide, please? I have it. Okay. So good afternoon, all. And first of all, I would like to express my gratitude to Asmita ji and Sanchita ji for inviting me and giving this opportunity for me to present my experience of innovative technology in healthcare, diagnosis and treatment. But Mukesh ji has given me a huge responsibility to keep the audience awake, and I will try to fulfill it. So please accept my greetings from AIIMS Patna, and I'll be mainly covering these three areas: the diagnosis, the treatment, and the research part in the surgical, mainly, especially the plastic surgeon, because I'm a plastic surgeon. So while I was searching for this technological innovation, I came across this article related to the plastic surgery. And I just want to share that these are the areas where work has been done in the plastic surgery field. As we can see, is major work has been done in burns, in wound care, breast reconstruction, head and neck reconstruction, and microsurgical reconstruction. So I'll take you to few of these. How does this work? So like in acute burns, coming to the diagnosis, we have a gamut of AI, including into software and the machines which are able to diagnose the degree of the burns. We know that there is a superficial and deep burns also. So for us, it is 4 degrees. So we can actually make the diagnosis using this simple technique, and we can also predict the healing time, how much time it will take. For example, in the knowledge part, we know that for a 2nd degree wound to heal, it takes approximately 3 to 4 weeks. For a 3rd degree and 4th degree, a skin grafting is required. So this information, if we get about the depth and the size of the wound exactly, then our treatment can be aligned accordingly. So that is the advantage of artificial intelligence in the management of burns. Then we have in the treatment. So I will take you to the few things which we are using, like 3D printing, use of virtual reality and augmented virtual reality, use of robots, and finally the generative AI technologies. So this is our 3D printing lab at AIIMS Patna. We have a system in place for last quite a few years. There are computers and the software which process the patient's data collected through CT or MRI. And finally, we can get a 3D printed model from the printer, which is shown in the picture. So this has got a software and a converter and a scanner also. So for example, if you see this patient, there is a tumor on the right side of the lower jaw, and his CT scan also shows a tumor. So like using this software, we can actually recreate the entire skeletal structure. And as you can see on the top left, it is the diseased mandible, we call it lower jaw. And somewhere on the right lower side, you can see the part which needs to be excised and the part which needs to be reconstructed. Why I am telling these things, that how using the AI and the 3D printer, we are able to deal with such patients very effectively. So we get a printed model. This is a 3D printed model. From the calcium sulfate is the consumables. And you can see there are 2 colors. One green color is there, which is one part of the right lower jaw. And there a pink part, which is again the another part. So with this printed model in our hands, we directly go for the surgery where we take a bone from the patient leg and just reshape into the shape of the lower jaw, and we reconstruct it. So things have become very easy. Initially, what we had to do is that we had to actually do all the measurements and the calculations in the theater itself, which involved increase in the operation duration, and also less of meticulousness was there. So because of this 3D printing, now we have the exact data and the exact measurement. How much is the mandible needs to be excised, how much it needs to be reconstructed, and what angle, what direction, what alignment. So it becomes like a perfect thing. You can see the post-op picture of this patient. And this is just an X-ray of the mandible. I think everyone can appreciate the normal mandible on the left side and the reconstructed on the right side. Similarly in females, and you can see the symmetry. All these patients have been managed by using the 3D printers and the softwares. Similarly, this girl, this small child was treated when she was 10 years old. Now she's an adult. You cannot make out the difference between her right and the left lower jaw. It seems absolutely symmetrical, absolutely normal. So such type of outcome we are able to give to the patient using the technology. Now the robots in plastic surgery. I'm sorry, some of the fonts have got changed. So now there is robots. Robots is there in absolutely all the fields of surgical branches, including the plastic surgery. So in plastic surgery for breast reconstruction, robots were used first time, and it has been seen that through a very small incision, actually the entire reconstruction can take place if we are using a robotic arm. So these are just a few data which I got through it. Then we have some small 2 millimeter, 3 millimeter vessel suturing. We call it anastomosis. Sometimes if there is a cut in the hand or if there is a microvascular reconstruction, we require these things. So using robotic surgery, it is very much possible because it excludes the fatigue, the technical expertise which a microvascular surgeon requires. So less of time, more of quality, more of precise. So these are the advantages of using robots. You can see a vessel, how it is repaired manually, and how a robot can also do it. So I had a training in the robotic plastic surgery, and we could use it for microvascular. I'm not talking about the larger structures, only the vessels, the arteries and the veins, which are 2, 3, 4 millimeter at a max. Now the last thing will be in the research, because whatever we get the evidence, that evidence can only be established when some randomized controlled trials are there. Some studies, some systematic, prospective studies are there. So what does AI does in academic research? So we know ChatGPT can do all these things. It can, even in the medical research, it can help you writing the article, starting from review of literature up to the final draft of the article. So all the steps which are involved in a manuscript publication cycle, it can do everything. We, our team at AIIMS Patna, we did some review study regarding the use of AI as research assistant. And we got to know that there are few AI tools which are available free of cost. ChatGPT everyone knows, but it is not very research specific. We have one Research Rabbit. We have Consensus. So all these are available free of cost. I am not going into details of it. Otherwise, we got to know the specific advantages and disadvantages of every research assistant AI. So this was just to show you that we are using AI in writing our publications also. The only problem is the concerns regarding the data security, the loss of the authorial voice. And then there are ethical implications. So how this can be solved? That is the topic of today's discussion. So a human oversight has to be there, a proper training, algorithmic audits needs to be prepared and followed, and the financial considerations, of course, should be there. So the future is that there should be a collaborative synergy between the AI developers, researchers, and journal editors, especially in the areas of AI as research assistant. Because without research, whatever we are using in our surgical fields does not have an evidence base. So that is the beauty of technology and all the generative AIs which are using it. So this is my part of presentation. Thank you so much for a patient listening.
Thank you so much, Dr. Veena. The health sector demands accuracy and efficacy, and their generative AI is helping us. But I'm not sure that we have come to a stage where we can completely rely to it. But definitely, with the passage of time, we would be achieving some of our objective. I would request audience to keep their questions with them so that at the end of the session we could ask some questions to Dr. Veena. Yes. So Dr. Abhiniti Srivastav, you would be making presentation, right?
Yes, sir. Good afternoon to one and all present here. Yes, sir, we were told we can do a 5 to 7 minutes of a video or a presentation. So I also have a presentation if I could get it, please. So thank you so much for having me here, Dr. Sanchita, Adri, the entire team. I'm very honored to be sharing the stage with such esteemed dignitaries. I'll be speaking very briefly and very shortly on my view, my branch, and what we are doing with not just artificial intelligence, but the technology that is available. The topic that was, I think, the point here was to discuss policies, the perspectives, and the quick changing technological innovations and how they should be going hand into hand. So I have a disclaimer here. I have used ChatGPT and artificial intelligence to sort of key down what I needed to speak about. So bear with me. If there are any questions, I'll be happy to take them in the end of the panel discussion. So the challenge, when we talk about the innovation imperative and the policy lag, the challenge is that rapid technological progress just then outspaces the regulatory frameworks. If we talk about a blood center, the blood center has these 3-4 regulatory authorities that we have to adhere to their guidelines. We have to know what they're talking about. But the quick change in technology is so quick that we are just not able to get those guidelines in the framework. Of course, it's being spoken about in publications. It has research written all over it. But when we as people practicing these guidelines, practicing medicine need our guidelines, which generally don't get out there. For example, in blood testing for all people who are from a non-medical background, when we issue blood or any blood product to the patients, we have to do some mandated tests. But the testing process is so vast that you can do a test which is just 95% specific and maybe 80% sensitive, whereas you have technology today which is 99.99% specific as well as sensitive. But the policies don't mandate the use of such technology. One such technology is NAT, which is nucleic acid testing. It has multiplied the diagnosis of the transfusion-transmitted infections. However, specifically to India, we still don't have any mandatory guidelines or policies which say that this is a mandatory test. Next, we can go on to pathogen reduction technology. So one is you talk about the viral and bacterial infections which will be in your blood. The other is that you know that they're there and you are able to reduce it through technology. Now, when we talk about this, again, of course, the mandatory aspect of a policy isn't there. However, they're also very expensive. So how do we deal with that lag? That yes, it is good for the patient, yes, it is good for your institution, but it is not an affordable technology. So the policy gap, yes, is traditional regulations have to keep evolving given the performance and outcomes to accelerate the adoption. So next is, again, for diagnostics, we thought what beyond NAT. So we talk about once NAT has been instituted, we still talk about the implementation of it. So we talk about people who are working, who need to be trained, who need to understand what good this is going to do in the field of a blood center. So next, of course, there are many studies, but we are going to stick to the time that has been given to us, the emerging threats. We remember the time when COVID had come and suddenly everybody was asking for plasma, give us therapeutic plasma. But the research aspect of it was quicker than the policy aspect of it. So nobody could mandate that a blood center has to have therapeutic plasma exchange going on for recovered COVID patients and then giving that product to the patients who need it. But the research had quickly caught up and there were different trials, different guidelines coming through researchers, but not the mandatory policy makers. So WHO and international standards for blood transfusions, yes, they do have recommendations for surveillance of new infections. Again, they are still not policy responses for these emerging emerging infections. Sorry. So next is the pathogen reduction technology which I was talking about. Again, the risk-benefit analysis has to be done, because sometimes when we talk about pathogen reduction technology, we also are putting at risk the component. For example, if we are doing it for platelets, then we are looking at a fall for the number of platelets which would be in a bag, because the pathogen reduction technology and the complicated steps of it do inculcate a small error margin, and that has to be catered for in the terms of benefits as well as the risks. So that, having said that, then global harmonization, the need for consistent regulatory acceptance. So Food and Drug Administration, FDA, the authority has to give some permits for us to be able to at least start testing this technology which is available readily in our country, and then we get to the standardization of these available technologies. It could be through AABB, it could be through Indian, AABB is American, and the Europe Council and Europe standards are also available. However, the three are very different. The three don't match. So somebody who's functioning here in India will have a different take, whereas a person who's maybe from the Britain or the USA will have a different take on these. So policy for digital innovation and surveillance. The focus is to improve traceability, inventory management, and hemovigilance. So hemovigilance, for those who don't know, is a common platform where the blood products have to be reported if there is a transfusion reaction or an adverse donor reaction to it. So we talk about these reactions at a common platform so that the guidelines can help make some things maybe safer. So this is a particular platform which is available in India. A similar platform actually has been in the Britain for a very long time. That's called SHOT, which is Serious Hazards of Transfusion Reports. So these are mandated standardized formats and platforms which help us get to these policy making decisions and the guidelines which us practitioners of medicine need. So just a small aspect of artificial intelligence is here, that we have mandated standardized electronic data capture in the blood centers by the use of a simple barcode. It's called a ISBT 128 barcode, and that now, since has become mandatory, we know that when a label which has been put on a blood product, if it's not in that particular format, we say that no, this blood may have come from a spurious resource, let's check it. So this in Bihar has been one of the biggest things that we as a blood center which has been practicing modern transfusion medicine has been able to catch, that this is spurious blood, this has not come from a blood bank, please take it back or at least get your money back from wherever you've got it. So this aspect I thought is a very important one in our field here. So when we do talk about policies, we talk about a framework for future proofing. So in that we have to have three major pillars. The first one is a regulatory modernization. So you have to shift the perspective to have performance-based regulations which can quickly match up to the policies and the guidelines which need to be made. The second pillar would be investments and the access. So public-private partnerships generally have these models where high-cost technology can be made accessible across, the economic settings. So as I can speak for Medanta, is a public-private partnership, and we get a lot of cases which are referred to from the government side. And for them, I think this is an ideal situation where earlier they would have had to go out of Bihar to get this kind of health facility accessible to them, which we try and get them here in Bihar. The third pillar is international harmonization. So again, doing something in isolation may not be the best idea, because ultimately the goal is to provide safe blood or safe bone marrow transplants, as in our case. So I think these three pillars together may help us make policies quickly and have a framework which is enough for the future. So last, there are a number of case studies which I went through, but this particular case of Zika virus was a study which finally we understood is a good example. So when you have a rapid policy and you decide that, you know, donors need to be screened for a emerging pathogen, there is a lot which you can do in terms of safety of the blood which is going out. So this particular case study is from the UK, and there they had pre-approved adaptable policy blueprints available. So they had a blueprint available for a just-in-case situation. It wasn't something they had predicted, but just they had these 5 diseases. They thought that if at a time these emerging diseases come to start from one center of Britain, we will have these blueprints ready. So they were able to get the mandatory testing for Zika for that particular period and area within 6 days, which is a huge number when you talk about mandating something for an entire country. So recommendations which have now started floating are having a rapid response blood safety committee. It could have a national aspect to it and an international aspect to it, which has predefined authority to make emergency changes to the donor selection and donor deferral, donor testing policies, and it has to have a very specific segment of no bureaucratic delays. So these are frameworks and policy making decisions which are taken beforehand, and then at the time of implementation just need to be quickly informed and implemented. So example is CDC and AABB guidelines also. So they also have started doing this for a number of diseases. So I'm going to stop here. The summary is that in modern transfusion medicine, since it's such a highly technological field, it requires a very proactive, performance-driven policy environment. And the key policy actions to such a advanced field would be to fund the transition to full nucleic acid testing and pathogen reduction techniques, harmonize the international as well as national institutes and standards for innovation, and mandate robust integrated digital surveillance, which is in the form of hemovigilance. So we must champion policies that view innovation not as a regulatory burden, but as the essential path to zero transfusion transmitted risks and optimal patient blood management. So these are my references. Thank you.
Thank you so much, Doctor. Yeah, of course. Regarding your concern about policy framework, that perhaps we have apprehensions that health technology is moving so fast that we would be leaving behind in terms of policy framework, regulatory framework, or your concern is also about harmonization of regulatory policies across the world.
Precisely, sir. So we cannot leave a single leg behind. It has to go on together. Just the time short, if it could be a shorter duration of period to get to these policy makings. Because having said that, we know of centers which are not mandatory. They're not doing the basics of the testings also. So once you mandate something, then maybe it can,
So I have not worked precisely in the Ministry of Health, but I was private secretary to Union Minister of Health and Family Welfare, and from that little experience, I would like to assure you that Ministry of Health is among those ministries which is very, very proactive, which has already been proved during COVID time. And regarding regulatory framework and harmonization, I believe that India is also part of global network, Health AI global network. So we are definitely moving ahead, but maybe we will have some more questions from audience. So we move towards the next speaker, please.
Can we move to the next slide? Can we move to the next slide?
slide change? Which one? This? Where's the name? Okay. Yesterday also from Adri's side, presentation was made on IDSP, IHIP. I just tried to summarize kind of things because since the morning we are talking about policy making, use of AI in research and actual implementation in various sectors. So just before I brief, this is the IDSP IHIP program is one of the information technology mediated surveillance program, and since its inception, I've been in great pleasure to work since so long for the program. And of the 5 major infectious diseases, you might be knowing that National TB Elimination Program is also running, then Vector-Borne Disease Program, National Leprosy Program, HIV/AIDS Program. They all have mandate. They are vertical disease control program, and out of all the disease control program, IDSP has the mandate of covering largest number of infectious or outbreak prone diseases, more than 35 plus infectious diseases and health conditions are being monitored. Except and beyond this, we also have mandate for surveillance of any unusual health event or any new emerging or re-emerging diseases, and COVID has been great blessings for us, because this was the time only, because just before the COVID arena, till that time, people used to think within the health system also, IDSP is all about PLS, EWS, and its end. And some outbreaks, then we get highlighted. Otherwise, all the time, this is a routine work that was never highlighted. And the COVID episode happened in the state that showed what an emergency department, how an emergency department would work. And we did very responsible duty during those hours. And people came to know that what is the benefit of a good public health surveillance system and how it's going to evolve in the future. Next. Okay. Like I've already summarized that basically we do surveillance for so many diseases. Initially it was weekly reporting, and now it's a real-time, everyday reporting that we are ensuring. And we have specially 3-tiered surveillance system in the state. P form, that is being reported by the physicians across the state. L form is being reported by the laboratories, and S syndromic form is being filled by the ANMs. So 3-tiered surveillance system is being executed in the state. And also EWS nil reporting is also mandatory for all the districts. Even though if there are no outbreaks or unusual events, they have to enter nil to be so that we are able to monitor the kind of things. Basically, this is a 3-tiered framework available for disease surveillance. One is the central surveillance unit at the apex, then the state, and followed by the DSU, which is the focal point for the activities at the district level. Like this is what a flow of information shows. Actually, it's real time only. You can see various program offices, because many of the programs are also interlinked with us, and the information flow right from sub-center to all the labs, private, public, all are part of this surveillance network. And right now, more than 10,000 reporting units are reporting in the portal on daily basis. And we have also added the private reporting unit, so has to have data completeness, and to get the data validated, we are working in that direction as well. This is how the data actually comes, right from ASHA to health workers, MOs, DSOs, and from the lowest unit is the village unit, followed by sub-center, then PHC, CSC, UPSCs, and DSUs, and each one of them are entering in the portal. And the greatest surprise that as an IDSP official I had was for P&L. Even in the old portal we were performing very fine,
But in S form, we were struggling. That had to be entered by ANMs. And in a state like Bihar, where IT literacy is not that much high, the way ANMs have actually delivered under the program, and they have entered the data. They are entering the data in the S form, and they are more dedicated than the medical officers who are reporting in P form. So this has been the greatest lesson that we saw. If we consistently follow up any program activities, that's going to work, and the system is responsive. And the main thing is you need to follow it up on consistent basis. If you send daily feedback to the districts, it will show its result. And this is what we did. We set very small target initially, and later on we have expanded. Okay, this is the work structure. We are still working at half strength in the entire state, and the actual sanctioned positions, 50% of them are vacant under the program. And this is just to show how we transition since 2021. We transitioned from paper-based reporting to real-time reporting and IHAP portal. So this was already discussed. This is just to elaborate. Yesterday we had shown it, and it's in the morning also we listened to our NPO, and he also acknowledged the efforts that we have put together as a team, and our performance has really improved. Anything that Bihar does, because many people from center I have met, and they have told, if you get the things done in Bihar, you can work anywhere in the world. So this was also one of the examples that we were not under any pressure, because nothing was expected from us. Rather, we decided to work and give our best, and it reflected in our performance. Okay, this is the progress that you can see from 2019, last 5 years or so I have put. And we are here today for PLS forms. We are reporting greater than 90% reporting we have ensured from all the health facilities. That is more than 10,000 at present. Or this is also Bihar has been holding top 5, under top 5 since last 6 months or so. We are quite doing good in this surveillance system, and you can see this is a central ranking system. Center has put their portal, means this is already ranking is done at their level. They have the software, and this is how the states are ranked, and this is where we are there. Okay, this is not of that much value, but we actually give feedbacks to the districts on weekly basis on how they are performing for different forms, so that the data uniqueness is maintained and data consistency is improved. This is for other forms. And for our state, we also do, send back our feedback to the districts. Every day, there is a competition between top 5 and bottom 5. This is the status. Many of the top most performing districts are also here, and bottom performing districts are also here. This means we have to maintain the consistency. This is one of our challenges, because different districts have different conditionalities. Transitioning of VPD. This is another chapter that has been added to IDSP, because initially VPD surveillance was being looked after by WHO team. Now the Government of India has decided to pass it on to IDSP, and for 8 districts we have already completed training and transition, and we have started reporting on a separate portal. And for this also I'm thankful to Adri team. Dr. Sanchita has been developing an app, so that mapping of private sector has already been done, and informal sector like rural health practitioners. Government side, we have the data and mapping. So we hope in VPD surveillance also, all these data units, reporting units will be used together to ensure that the VPD surveillance activities are carried by us in a finer manner. And other activities includes measles and rubella, DPT, and AFP surveillance. These are the major activities under the VPD surveillance program. That's by 2027 we are hopeful that we will be in commanding position to run this program across the state also. only means one is the data quality. Right now, what is happening, the system, the health facilities are themselves entering the data, and every day their portal is made in such a way that if any disease crosses the threshold level, the alert is sent to the concerned districts, to concerned block or concerned medical offices. So my district team is also here. The main thing is that they have to monitor the dashboard on daily basis and provide the feedback to the others. Because once we make the feedback report at the state level, what we have seen, many deaths are reported in SFORM every day. And the districts are not cross-checking those data, what is being entered by which sub-center. So the verification gets delayed and false panic is created sometimes. So it's quite challenging to ensure, because you cannot force A&M to be perfectly all right all the time. But these are the gaps that we are facing, and limited engagement of private sector, that now data mapping for the state has been done. We are hopeful that this will also get progress in less time. And others like network of field monitor support. Yes, this like VPD, they had field monitors from WHO side. Now that we are proposed our budget to the center, that the field monitors who had worked previously for VPD, they will continue to work with us. And this is also not that important. We required, basically, you know, COVID was an excellent example. In the morning also WHO had given its presentation on COVID, how we can improve disaster surveillance. So there was a review for that. I had made this slide, and basically we need to reassess ourselves, because again influenza season is coming and we need to be prepared. How much well are we prepared? Like mock drills and all, the government of India is continuously giving us this exercise that we have to conduct mock drills. Again, in December, some activities are going to come where we have to do mock drills for the influenza season. And another challenge is laboratory strengthening. Like I said, no PSC has the RDTs for infectious disease or communicable disease. Very limited tests like typhoid or malaria or TB is being done, and breast communicable disease that are being captured under IDSP, even the rapid test kits are not available. This is the gap, and under the IDSP program, we are given funds by ministry for district lab strengthening and for medical colleges, not for PHCs. And from the state perspective, what I have seen under free diagnostics, they think routine pathological, routine radiological, or routine biochemistry tests, this is all about diagnostics. Other diseases like infectious diseases are not captured. So this is also one of the gaps that we need to address, and we have been addressing. Maybe in future the PSCs are strengthened enough to at least screen the cases and send the lab to the send the samples to the positive samples to the lab for district lab for confirmation. This should be the ideal scenario. And medical college level, we are focusing on L-form because it's very difficult to get reporting from medical colleges. So P-form reporting is not being done. Actually, from there, we are ensuring that L-form we do not miss. Government of India can follow up with all, because private we can only request, we cannot force them. So the willingness is also very important, and even at the Government of India, we have requested to follow up at their level, all the private stakeholders to come together, and yeah. This is all about. Thank you very much.
Thank you so much, Dr. Ragini Mishra. You have very well reflected upon the scenario of health system in Bihar, and congratulations for the human work done by your organization despite facing human resource issues, and of course financial resources may also be at times problematic. Now the floor is open for Q&A session. So first question from you, sir.
Thank you. Thanks to the panel and chair for ensuring enough blood supply to brain to ensure we are awake. Starting from your assurance of the proactiveness of health department to the journey from coverage to quality of IDSP. I worry my question may little bit distract the discussion only to AI, and a very specific question, naive, simple, but real question, stupid but real. I just request any of you just to give a message, because in the audience there are many junior researchers and also people like Dr. Harsh, me, who really want to learn from past and want to protect the future. How to ensure that artificial intelligence is a support, not outsourcing intelligence? Because research is all about conjectures and refutations. There is a requirement of reproducibility, there is a requirement of leaving a track so that you can check the quality. I lead a team of more than 120 researchers. Every time when there is a literature review, the worry is it is based on real mesh term-based literature search, coming up with right evidence table, and then getting into a proper systematic review form, or it is the free version of ChatGPT giving me a kind of a thing in few seconds. There are hallucinations. There are issues related to, we know right now 47% hallucinations are seen even in the paid version of Perplexity. If we are talking about the unpaid version of ChatGPT, it is more than 80% at times. So the question is how we ensure that we use your point, Dr. Veena, that there is a requirement of interface, but how will I ensure? And you all coming from different perspectives where you have your clinical work. Now your research assistant who is probably researching on something on a fetal wireless monitor, which is actually happening in AIMS partner right now, that person can next day join my team where bread and butter in research. How will I ensure that the intelligence is not outsourced? Thank you.
So I would say your question is something like forensic analysis. And my take on it is that whatever we have gone into the AI as a research assistant while we were doing our study is that we should have an algorithm for audit, even the AI audit. Like we have the system to check, even like for example a simple surgery, we know that this surgery has come to this outcome by passing through these steps because we have an algorithm. So I think an algorithm of an AI audit is one thing which will be required. Though I do not have the complete answer to your question, I think maybe the other panelist or Mukeshji may take, but this is the only way as far as my little knowledge of AI and technology is concerned.
I don't have medical answer to it, but as a layman and I'm following generative AI, I can surely say that it's not an outsourcing of intelligence. You know, any app, even if we say, we are not talking about GPT here, not at all. But certainly any AI tool which is developed or which evolves, it is through the real time or real practices that have gone into it. Like, you know, it is about, you know, having knowledge of medicines of thousands of doctors or medical practices, bringing them together for bridging the gap in information. So I don't think that, you know, it's outrightly outsourcing of intelligence. It is basically it can be used as it is a helping tool for us basically. I don't know. Means yesterday also I was witnessing some questions like this, some apprehensions like this. Somebody was saying that it would be very costly, it would create inequality. But to my mind, I believe that technology is the best equalizer. So far, whatever we have perceived is this only. And reaching out to 1.4 billion people through physical doctors in an equal manner, it's going to be next to an impossible task. There comes the role of generative AI or technology, I believe. This is my small answer.
Sir, in terms of outsourcing intelligence, the fact that there is a human touch to this, I think that is why you cannot outsource this kind of intelligence. There is a very frequent dialogue between me and my husband about how there is a keen eye and how you are observing things which AI will miss. It may or may not, but if you're looking out for those things and you know that, as ma'am very correctly said, that maybe a form in the form of an audit, there are things and steps that you as a human would be taking and just taking that support from AI. So maybe that's what, can sort of prevent it from happening.
I completely agree to everything that you said. The question was how we ensure that. Because just like, suppose today I have to conduct a literature review for supporting Dr. Veena to have some information before getting ready for this conference. How will she ensure that I am actually using right method of literature review or just using a free version of ChatGPT to come up with something? Because she is not going to check it unless that algorithm-based audit is there. So ultimately my request is how we can head towards having an AI policy.
I have an answer to this. It is just, so ICMR has these guidelines which dictate the use of artificial intelligence in healthcare and biomedical research. So it's a 75 or 76 page document, and it has in detail, it takes into consideration the practical aspects, the important question of privacy, patient data privacy. So all that is covered in this document. Now the question is, how far is it implemented and how far do people know about it? So as Dr. Veena said, it is important to review and audit the algorithms which are used, and there should be some guidelines which dictate which are the apps or the AI tools which can be used in healthcare, because everything cannot be used in healthcare. So there has to be a line drawn somewhere.
Sir, like for small example, our trainees, they write their thesis using AI, है ना? So when it comes to us for checking, we, by a look and by just a superficial read, we know that this sort of good grammar, excellent grammar, decorative language cannot be any human. So that is my human eye, as he was telling. So just by look of it, we can understand that it is not there. But your question is about the policy. So I think we should quest for this. Yeah.
Okay, just to update that, just a few weeks back, there was a One Health conclave at the national level. Simultaneously, even at the ministry level, different ministries have started working in convergence. And they are coming up with AI guidelines might be coming up next, because they are consulting, they are engaging the IITs and ICMR and other research institutions as well to come up with any suitable model that would be applicable across the country. So in due course of time, we are hopeful. They are working on disease modeling using AI tools. And these things have started happening, and we from state level are being called in these workshops. So we are just hoping in days to come we might get any guidelines specifically in the health sector to get it universalized. Yeah.
Just adding to that part, sir. Basically here we are talking about two parts. The AI use in conducting public health research, and the second part, that the AI use in writing of public health research. So basically there are the changing times, and now the generation of Alpha or Gen Alpha or Gen Z, they are being taught now, as the first session that told about internet addiction. Now we are teaching them, I have a son, I am teaching him how to use a social media or the internet responsibly. Same way, the sir is talking about generative language models like ChatGPT, Gemini, Consensus, Research Rabbit, SciSpace. There are n number of tools. Simultaneously, we are also having the responsibility how to use these generative AI tools. Means most of the times we are using large language model, that is NLP, ChatGPT or Gemini. But how to use this, how to make a structured prompt and what is correct method, that is another examples. Yesterday, if you have heard about Microsoft, Satya Nadella had a big conference, big meet about this AI, and the co-pilot is becoming as a colleague. And everywhere now, all the public health researchers or the clinicians, they are going to use the large language models or ChatGPT or Gemini, whether it is free of cost or not. The thing is now, the responsible AI use needs to be used in everywhere. In One Health Conclave, before that the ICMR had made about AI use in public health research, conducting public health research. Still, the privacy and data security issue, we are not that much level of care that we can protect ourselves also. And that's why the scam is more common nowadays in India. It had happened in China, Cambodia, everywhere, but now it's turned for ourselves. So, being use of internet responsibly and teaching our generation to use AI more structurally, that's what we need to do. And some of us, those who are in the public health background or from the PSM faculty, they have started creating webinars that how to use AI responsibly in public health research. And SAGE elsewhere, they had published the guidelines that now AI assisted writing and AI generated writing. There are two different dimensions they had created, and almost n number of pages they had published, and they are evaluating just like that. Thank you.
So any question from young researchers? Yes, there. You want to have any question? No. So my submission is only that we need not be so much conservative in adopting generative AI or new technology. There are certain legacy issues we talk about. Because if we continue to be conservative in terms of using new technology, modern technology, or generative AI, we may say, we would be left far behind the world, because we are already seeing there's huge investment going on in Western countries on generative AIs, and we all know that Amazon is also coming for clinical services. So it's something like, I recall that when computer was being introduced in the country, people were making so much hue and cry that computer will take away our jobs and we would be all left jobless. And but that was not the correct way. So let us be open to the new technology. Maybe we will face some challenges. We are at a very nascent stage. We need to wholeheartedly accept the new technology, and that is going to be the only solution for providing health services to all. Thank you so much to all the esteemed panelists. You have really enlightened us. Thanks a lot.
Thank you, sir. We extend our sincere thanks to the chair and all the panelists for this insightful and deeply relevant discussion. The key message is clear. Technology must strengthen diagnostic system and disease surveillance through strong governance and clinical leadership. Also a message to us young researchers that AI should be used mindfully and responsibility in public health research. Thank you, sir. I would now like to request Shri Mukesh Kumar sir to kindly felicitate Dr. Veena Singh ma'am. I now request sir to please felicitate Dr. Abhiniti Srivastava ma'am. Sir, I request you to kindly felicitate Dr. Ragini Mishra ma'am. Now, I would like to invite Dr. Sanchita Mahapatra ma'am to kindly felicitate Dr. Shri Mukesh Kumar sir. Now, we would like to proceed further with our paper presentation session. This session will be co-chaired by Dr. Preeta ma'am, Professor and Dean Research, IHMR Delhi, and Dr. Harsh Shah sir, IIPH Gandhinagar, and Dr. Tanmay Mahapatra sir from Piramal Foundation, and also Dr. Aritra Das sir from Piramal Foundation. May I please request our co-chairs to please grace the stage. Yes, ma'am. It's okay, ma'am. Ma'am, please take the photo. Dr. Harsh Shah sir is here. Okay. I would now like to hand over the mic to our dear chairs to further lead the session. Ma'am, please take over.
Thank you, and good afternoon to everyone, and good afternoon, my fellow panelists. So we have 5 papers in diverse areas, marrying problems as well as technology. I'm sure they will bring in a blend of scholarship as well as rigor. Will be very interesting to lead. Our role here is to facilitate efficiently and effectively those discussions. So we'll set a time frame also. Let's have 10 to 12 minutes for each presentation and maybe 5 to 6 minutes for the discussion. Please have your questions ready, and we can call the first presenter.
Dr. Mukherjee, please come on the stage and presentation. upload the presentation. We will have 10 to 12 minutes.
A very good afternoon, everyone. This is Dr. Ruchira Mukherjee from Foundation for Innovations in Health. First and foremost, I start with a huge thank you to ADRI for the beautiful conference and to each and everyone present here for the most illuminating discussions that I have been hearing since the morning. And based on those discussions, when I came in today, Dr. Oyon Basu was speaking, and he said a thing which resonated with me very much. So he said that the way the human race is progressing, climate change will always be there. So all that matters is, and all that we can do is we can be prepared. And how to be prepared? We have to be prepared with data. And as Dr. Moushumi Gupta said, we are in dire need for performing pilot studies. And now when we are talking about the data, I would also like to quote Dr. Tanmay Mahapatra, what he said while he was discussing his works, that there are so many confounders, there are so many relevant variables in any kind of research. We humans, we are always going to be limited by how much we know. So we can't say that we know all the relevant variables, so we can't say this is it, this is what is going to happen. So with that, I start my presentation today, a pilot study into insights from climate change in India and how it affects the hemoglobin levels or anemia. Next slide, please. Okay, so we have been speaking about the topic. So here's just a small revision. I'm sure everyone knows what are the effects of climate change. It causes increases in vector-borne diseases by affecting their habitats and their proliferation. It can cause food insecurity through, it can cause scarcity of clean water availability. There are also many reports on how extremes of temperatures can cause heat strokes and things like that. There is also the factor that air pollution can create many variety of respiratory disorders. And for all these effects of climate change, there are particularly a few vulnerable populations like the elderly, like the children, and marginalized women and the marginalized community, whom we call the last mile population, generally belonging to the low socioeconomic stratus of the community. So they are the vulnerable populations. Next slide, please. Okay, now coming to the most sincere aspect, rather not sincere, crucial aspect of climate change, which is basically the nutritional impact. Why I'm speaking about this today? Because whatever we do, right from when our life begins, we require nutrition, like right from when we are in the zygotic stage. Without nutrition, there is nothing. We take in good nutrition, we are in good health. We don't take in good nutrition, we are in poor health. And whenever we are talking about nutrition, particularly in context of India, we can see that there is the dual burden of being overweight, being underweight. So there is a dual burden of malnutrition in India. And not only that, if we look at the global statistics, India also happens to be a country where there is deficiency of vitamin A and iron more than compared to the global standards. Now, when we are talking about iron deficiency, the iron deficiency in anemia is huge. It affects more than 50% of the women population in India. And particularly if we talk about West Bengal, the number stands to be 74%. 74% of women in West Bengal are afflicted with anemia. So here, in this study, we just wanted to see that how climate change might be affecting the same, how climate change might be affecting the hemoglobin levels. Next slide, please. Yeah. So here is the background that while many research and many mathematical models have investigated how the vector-borne diseases are increasing in response to an extreme weather event or based on climate change, there is a scarcity of literature which says that these are the things, these are the effects of climate change on health parameters like hemoglobin, on health parameters like, say, for example, the reproductive tract pH among the women, or even mental health. So that is the domain that we are working on. This is a pilot study. We have just begun conducting this study, and I am here to represent the preliminary results. Next slide, please. Okay, so this is my study methodology. We have conducted the study across 3 locations in India. That is, one is Borha, which is in Birbhum district of West Bengal. The other is Silvassa, which is in Daman and Diu, Dadra and Nagar Haveli. And the other in Sundarbans, the largest delta on the planet. So for the study, we have selected this location so that we can cover a wide range of the geographic and climatic parameters that exist in the subcontinent of India. We have measured hemoglobin using HemoQ301. We have applied for and received the ethical clearance for the study from Institutional Ethical Committee of Presidency University. And while collecting the data, we have been sure to obtain consents from all the participants and align and adhere ourselves to the ethical guidelines established by Declaration of Helsinki. Research locations we have already discussed. The total number of participants in this pilot study is 2001. Next slide, please. Okay. So when we are talking about the participation criteria, there was surveillance alignment and gender specificity, particularly so that the study could align with the Anemia Mukt Bharat and the other existing government schemes. The study population of 2001, they belonged to the reproductive age group of 15 to 49 years. And when we are talking about the exclusion criteria, pregnant women were excluded from the study, as were male participants. Only apparently healthy female participants without any congenital disorders were considered for the study. Next slide, please. Okay. So now next, let's come to the climate data. So the humidity, wind measurements, temperature, and precipitation data was collected from NASA GMAO MERA2 database, and time analysis was done based on this data repository. Next slide, please. Okay. When we are coming to the statistical approach, like I said, that it is a very preliminary study. In future, we plan to develop the AI models regarding the same, but for now, what we have done is we have considered the time lag parameters. So for example, if today my hemoglobin is being collected, I have considered the climate parameters from 90 days ago, from 30 days ago, from 1 week ago, and then just the day prior to the hemoglobin measurement, so that we can have an idea of how time lag or how the climate parameters of today is going to affect me, say for example, a week later or a month later or even 3 months later. Next. So the entire data set was dichotomized based on the percentile values. We did not find normal distribution. So percentile values was used to dichotomize the data set, and we also used the cutoff of 12 gram per DL for hemoglobin measurements adhering to the WHO standards. So based on this, we conducted the odds ratio, we conducted the chi-square validations of the same, and the key findings were that 79% of the participants across these locations, they had anemia. There was geographic specificity because the climate parameters varied across the 3 different locations. There is the predictive potential based on the odds ratio and the associations that we have gotten, particularly for relative humidity and rainfall, both of which are associated with increased odds of causing anemia. I can't say causing because this is not a causal inference, but at least they are associated with, and therein lies the importance of the study and how and why we should conduct the future studies based on the same. Next slide, please. these are the hemoglobin distribution results, the raw hemoglobin data, as well as you can see the majority, 79.5% of the participants, that is 1,590 participants out of the 2001 were anemic in nature, and the climate parameters varied significantly across the locations based on Kruskal-Wallis non-parametric ANOVA. Next slide, please. Okay. So if we come to the individual associations of climate parameters with anemia, we can see that minimum temperature and wind speed is associated with decreased odds of anemia, whereas relative humidity, rainfall is associated with higher odds of anemia. So for example, if the rainfall is more than 50th percentile for the entire year, then it can cause anemia. Specifically, after the effects are mostly observed after 1 week or the 7 days. When it comes to the maximum day temperature, it did not have any significant effects. Next slide, please. So the most prominent parameters associated with anemia were the relative humidity and rainfall, and this highlights the importance of moisture-related climate parameters, and this is a premise that needs to be more investigated. Next slide. There are also delayed effects, like I said, how the parameters today are going to affect me 1 week, 1 month, 3 months later. So that is what we have obtained from the data. There are delayed effects of climate parameters. So if climate today is not up to my liking, maybe a week later that is going to have some kind of effect on my health. So not everything is mathematically modeled as of yet. As I'm speaking, that modeling is going on, and this is just a preliminary pilot report. There are the geographic variations that we need to take into account, given that the Indian subcontinent is huge, and this also highlights the importance of why one mathematical model may not suffice for the entire Indian subcontinent, and we need to conduct more studies region specifically.
Wrap up in a minute, please.
Yeah. So there are some public health applications for this. If we know how climate is going to affect me after a particular duration of time, then I can mobilize the resources, I can have a timely response, and I can identify the population who is at risk. Next slide, please. And so this is my conclusion. So delayed climate parameters have an effect on hemoglobin levels. We have seen the associations. We are not saying it's a causal factor, but this needs to be investigated more. I sincerely acknowledge ADRI. I sincerely acknowledge BIRAC, Grand Challenge India, Bamar Lorry, and Asia Initiatives to make the study possible. Thank you.
Thank you, Dr. Ruchira, for sharing the findings with us. We open the floor to the audience first, after which we'll come to the panelists. Any questions? Please go ahead.
Thank you, ma'am. Really, this is a nice presentation. I think this is a new one also related to climate change with hemoglobin. Yeah. And I have a question like, is there any dietary pattern relation with the 3 geographical relation?
Yes, there is. Thank you, sir, for the question. So this study mainly, this topic, sir, we have mainly evaluated in Sundarbans. So what we have found is basically many foods that were available, say for example, 20 years ago in Sundarbans are not available right now. So that obviously the hypothesis says that that also has an effect, but we haven't as of yet modeled it, but we are in the process of doing it, sir.
Any more questions?
Yes, sir. Hello, sir. My name is Muskan. So my question is that we have, in your paper, you have said that we haven't been able to explain the causality, that directly climate change is causing anemia is a big statement, and we haven't even proved that. I would say that the methodology is correct. Maybe we can do a cohort study out of this pilot we should have followed up the patient and see, including the dietary pattern also, we should see that the longitudinal study only be able to give the correct answer on whether this climate change is the only thing is causing the anemia, or other confounders that you have possibly found out from the study. Because maybe climate change is giving one of the factor for prevalence of anemia, but it could not be the only one. It could have number of factors like the social determinants we need to test. So the potential confounders, what are the potential confounders? That is my first set of question is, what are the potential confounders that you have thought that could have lead to this investigation, and whether you and the organization is planning to have a cohort study to actually represent causality of climate change with anemia.
Right.
Thank you. Thank you.
Thank you so much for the question. Actually, yes, we have considered it. So first we did a preliminary review search, and what we obtained was specific to when we obtained these results. So what we saw was that the literature, it is there in the literature survey itself, that whenever there is rainfall, there is increase of parasites, there is decreased availability of clean water, and that can lead to inflammation, chronic inflammation or systemic inflammation mediated anemia. So what happens is during systemic inflammation, if I'm not much mistaken, hepcidin mediated inflammatory pathways get activated, and they actively stop hemoglobin synthesis and RBC synthesis. And this leads to anemia. So while we are considering the genetic factors at how the climate change might affect someone at the genetic level as well, we are also considering the other aspects like we discussed, like the food and how the dietary patterns are changing. So yes, to answer your questions, we are considering it, but we are not as of yet to the level of conducting an RCT or a randomized control trial, which is very important to get causal inference, because there is no statistical tool which gives us a causal inference. And as I was just saying at the beginning of the work itself, at the beginning of my talk itself, referencing Dr. Mohapatra, that there are so many confounding variables. So the more that we can list, the more that we can discuss, the better a study design it may be, and we are in the process of doing that.
Thank you. Thank you.
Thank you. So obviously, Dr. Ruchira stated that there would be, many other factors. It's not, they were not trying to establish causality. There may be many intermediate factors. Any more questions from the audience? Then I think we'll come to the panel. Sir.
Yeah. Thank you for the presentation. So just in line with her question, other than what you have mentioned, first of all, RCT is not possible for such a, for this sort of study. But why didn't you aim for any sort of multi-level or hierarchical modeling? Because given that there are overall ecological factors that we are dealing with, and there will of course be some individual level elements that can determine anemia. Why there was no effort to do that? Because all these are simple bivariate regression models.
Yeah. So, sir, to answer that, I completely agree with you. As we are speaking, as I'm giving the presentation, the hierarchical models, the hierarchical clustering, K-means clustering, whatever is suited to the data. Other than that, the exploratory factor analysis is also in progress. So we are doing that, but this is a very preliminary result that we presented over here. And yes, any inputs I completely welcome, but we are doing these models, and we are also in the process of drawing up the regression models for the same data.
Yeah, and another question. So have you tried to calculate or compute any sort of public health thresholds? For example, what combination of relative humidity and temperature would require some form of public health intervention, for example, an awareness campaign or IFA distribution, iron folic acid distribution?
Not as of yet. So, sir, whenever we are talking about the climate parameters, what I observed while dealing with the data was that the climate parameters are also interlinked and correlated to each other. So whenever we are drawing up the model, the variance inflation factors, they are just making us crazy sometimes. Yes, we are trying to do that. And it's what I can say is that with everything going on, with working in preventive health, it has become a little time consuming.
Okay, yeah, because that would actually have been helpful from public health perspective.
Right.
And just I won't ask you any further question, but just I noticed a few anomalies because you mentioned you have used non-parametric methods, but ANOVA was mentioned there, which is not
Kruskal-Wallis
non-parametric.
ANOVA, sir. Kruskal-Wallis non-parametric ANOVA.
Kruskal-Wallis, but you mentioned that you have used non-parametric methods. And this 12 grams per deciliter cutoff, so for pregnant women, it's actually 11, it's not 12.
So in the exclusion criteria, we are not including pregnant women.
Yeah, and you haven't really described that why these three regions. I mean, what's the significance of that and how is that determining? Okay. And this and one just comment on this because you have used HemoQ HB301, but there is only about 60% correlation between HemoQ and venous blood or using autoanalyzer. So it's may not be a true burden of anemia, and NFHS actually suffers from the same limitation. Yeah. Just I stop here.
For the interest of time, I'll not ask any question, just a few very brief inputs. Number one, everything what Muskan said, what Dr. Arithro said, these are good inputs to further this, and definitely climate exposure, which is a group level exposure generally, while handling that, the multi-level hierarchical modeling will be important, as you mentioned. And please avoid the words like effect, as you were mentioning cause, avoiding the word effect. And
Sure, noted, sir.
Just continuing on those aspects, just few things. There would be the confounding factors because they are confounders, and that's why we are cautious to keep what are the expected outcomes. And based on that, we measure the independency and we categorize them in the regression model. So the regression model doesn't have the answer of everything. We need to look at the simplest meaning of everything. Just keeping on those aspects, my friend who is working in ISP, they had made an ecological kind of analysis that during the IPL, if the IPL continues over the 10 years, there will be the more than BMI of 29 of every Indian population. So these kind of analysis happens, but we need to make sure as a public health professionals that what to understand and how to interpret. That's the first thing, and carry forward to those ideas. The Silvassa does have many of the sickle cell anemia, and they do have, I've worked there for almost 2 years, and they do have almost 50% population having sickle cell anemia. So that is not exclusion criteria that you have mentioned. So those areas needs to be looked at. There are many, but I'll limit myself here. And
in the interest of time, I'm also not asking many questions. Many of my questions were answered, but I'm interested to know, you spoke about scarcity of the subjective literature. Did you just feel that there would be anemia, or is there some mention in literature that climate change can influence hemoglobin either directly or through intermediate factors? That is one. And the justification for the study sites, the lack of justification for study sites was very stark.
Yeah.
I would also be interested to know what you would do next. That you can answer later. But please tell me if there is some mention in review of literature somewhere in the world. Yeah.
So, ma'am, as I was mentioning, like whenever there is rainfall, there is increase in inflammation-mediated anemia, systemic inflammation, which is mainly happening through hepcidin pathway. So, whenever there is hepcidin-mediated inflammation, there is decrease in hemoglobin synthesis, as well as downstream RBC synthesis is also getting problematic. It's not happening. So from there, the hypothesis was then we can come up with something. We can come up with a model which says this, which can mathematically express the relationship or association between.
Research team felt.
Yes. So that was the hypothesis that we were working on.
It's an out and out exploratory study.
Yes.
Huh?
Yes.
Okay. That's all. Thank you. Thank you very
Thank
much.
you.
All
Thank
the
you,
best
everyone.
to
Thank you.
So next, I would like to call upon next presenter, Prasanna Dungal and Madhula Nirola. They are online. So the topic is machine learning and explainable AI in public health research, a comprehensive review. Have they joined? Hello? So, can you hear us? Can you hear us? If not, then we can move to the next presenter. We can take him later on. No, we cannot hear. This is Chintan Desai. This is in the team.
Chintan, as you have written, can you just confirm whether you can hear us? We cannot hear you, that is being taken care of. But whether you can hear us, can you write down?
No, we cannot. We are not able to hear you. Okay.
Okay. Please give us a second, Madhav. We will solve this.
इसका ऑडियो तो इसका बंद कर दीजिए, ये ऑडियो बंद कर दीजिए.
Madhav, let us try once more. Can you please speak?
Am I audible?
Yes, now you are audible.
Is my screen visible?
Yes, your screen is visible. It will be good to speak a bit louder. There is some issue with the audio. It will be good to speak a bit louder.
Hello. Good evening, everyone. I will be presenting a paper topic on machine learning and explainable artificial intelligence.
Please speak a little louder.
These are the outline that I am covering today. Hello. Am I audible, sir? Am I audible?
We can hear you. Please continue. You will have 10 minutes to complete this presentation.
Am I audible, sir?
Yes.
Coming to the introduction, as we have seen that machine learning and artificial intelligence are used in various kind of public health related data, and it was previously accelerated from the COVID-19 pandemic, and challenges such as black box and which raises the transparency concerns. So the XAI here bridges the interpretability gap, and the main objective of this research is to evaluate machine learning algorithm applications in public health and to analyze the XAI methodologies to identify the challenges and limitations and coming to the research methodology, we did a literature source search from PubMed, IEEE Explore, Springer, and we used the inclusion criteria such as papers published from 2023 to 25, and used the terms such as machine learning, XAI in public health. This is the machine learning and explainable AI workflow in public health, identification, how it's to the clinical interpretations. First, it comes to identify the public health problems and to get the data, data collections, and after collecting the data, we divide the data for train and test splits. And after splitting, we train for for the models such as random forest, XGBoost, CNN, and then it's validated. Later, we use the XAI's applications SAP and LIME. Then the interpretation and the bias detections. Then it's done for the clinical implementation. Machine learning applications in public health are such in disease surveillance and the outbreak predictions are real-time monitoring with diverse data such as EHRS, social media, in-symbol methods such as random forest and XGBoost. AHU values also exceeding to 0.990 in outbreak prediction tasks and anomaly detection for emerging infectious disease threats. Diagnostic and prognostic applications such as deep learning architectures were used for most of the image-related data analysis, which we can see in COVID-19 diagnosis, such as X-ray and CT scans. Also, the hybrid and the ensemble approaches, such as ARIMA, outperforms from the traditional methods. Coming to the epidemiological and modeling for the policy guidance, it supports vaccination campaign planning and the resource allocations. It also enables rapid evidence-based policy decision making during COVID-19, which we already saw. And random forest showed very strong adaptability across diverse geographic data sets. These are some of the machine learning algorithms which are the performance based on the different applications such as in COVID-19 mortality. We saw that random forest has performed 94.2% accuracy. In disease outbreak, XGBoost has performed 92.8%, and for medical imaging, CNN time series analysis data, LSTM, and for risk prediction, decision tree, for classification, logistic regressions. Why XAI matters? XAI is required because healthcare requires transparency for clinical decisions, and black box models it lacks for the accountability. So for building a trust among the clinicians and patients, we required XAI to identify the key features and its benefit is like human interpretability explanations, feature importance. We can identify the key features from the like analysis. And primary like XAI techniques such as like SAP, line, and attention mechanisms. This is the like basic architecture of the XAI model, where it consists a data layer where input data, and then the machine learning layer where the data is fed to the machine learning models, and then after the machine learning
Madam,
model,
last 2 minutes.
I request audience to please.
Madam, last 2 minutes for you.
This is, and XAI techniques we have also compared, such as like we saw SAP line are like most widely used in various kind of like papers and for identifying the key features. Some of the challenges include such as like data quality and biases, privacy and security, lack of interpretability, generalizations, standardization, and ethical concerns. Coming to the conclusion, machine learning and XAI demonstrate transformative potential in public health research. Ensemble learning methods such as deep learning achieve like high performance in disease predictions and diagnosis. XAI and such as like we already saw that SAP and LIME are successfully enhanced for the model transparency and clinical trust. Future success, also we need to consider that key challenges such as like data quality should be good, and privacy protections, also the algorithm biases should be considered, and the generalizability. Future successes requires like interdisciplinary collaboration with the user-centered design approach.
Thank you. I would request the panelists to ask a question.
Well, Prasanna, thank you. That's a great presentation, although I was not very sure where from did you obtain the data. The table that you showed where you have compared different types of models, what was the source of that data? Because you needed to have granular data for that.
So it was like based on the papers that we have reviewed.
Secondary data.
Papers.
Secondary data, but you could access it from different literature.
Yes, sir.
Okay, thank you. So just one question. According to you, what would be that minimal standard or minimal framework? Say, for example, some sort of HDF.
Not able to hear you properly. Hello?
Can you hear me now?
Yes, sir. Yes, sir. It's like echo sound.
Okay, there
I
is.
can hear.
Yeah, is it better now?
No, sir. It's echo.
Okay, anyways. Can you hear me now? No, I don't think he can't. He can't hear me. Huh.
Can you hear us? Can you hear us now?
Oh, okay. Yeah. Then maybe we can just skip the question because he won't be able to answer.
So Madhav, thanks for your presentation. There is some technical glitch because of which either one side cannot hear the other. But thanks for the presentation, and we are now going to the next presenter.
Said Nabil and Dr. Prernika Kachru. You're welcome. Please share your presentation.
Renika, can you hear us?
Dr. Prernika, I can hear. Are you speaking? Please try to speak. Are you speaking now?
Yes, ma'am, I'm speaking right now.
Yeah, we can hear you. Please go ahead with the presentation.
Okay, great. So, good evening, everyone. I am Prernika Kachru, and my colleague Nabil and I, we conducted a study on the barriers and enablers to mHealth adoption in Bihar. As we are already aware, mobile health is not just a convenience, but a bridge to equity and access to healthcare. Now, we need to know why this matters. So, mHealth has an unprecedented potential to expand healthcare delivery, reduce diagnostic delays, and enable patient care in remote areas. And despite high penetration of smartphone and internet, the adoption of digital health services is still low. Now, digital health literacy comes as a critical factor that shapes who benefits from this technology, and it is fair to say that it is now a social determinant of technology. Social determinant of health. Now, our study was focused in Bihar across 19 districts, mapping the digital health ecosystem in resource-constrained settings. We assessed the access of phones and internet, the digital literacy levels, and quantified the awareness and usage of mHealth tools. We then analyzed the barriers and enablers of adoption of the tools, examining the disparities by gender and education. With this, we generated insights to design scalable strategies and to scalable strategies that will ensure equitable digital health expansion. We conducted a cross-sectional study using mixed method in a sample of 463 adults. We used purposive sampling to include women and non-smartphone users to reflect the digital exclusion in rural and urban, semi-urban areas. Interviews were conducted with structured questionnaire for demographic, skills, and access. We also calculated a Digi score for digital health literacy of the respondents, and each yes was scored a 1 and a no was scored 0. Then a total score was analyzed. Descriptive statistics, chi-square test, t-tests, ANOVA, etc. were used to identify these disparities, and correlation analysis were done to assess the linkage between barriers and enablers for informing policy. Out of our total respondents, 57% were male and 43% were female, and one respondent was transgender. The respondents were from all age groups, ranging from 18 years to over 60 years, with most coming from 18 to 29 age group. 22% of our respondents did not have a formal schooling, while 20% of them were at least graduates. Moving to what we gathered from the study, we first compared the device ownership with the digital capabilities of the respondents and found that 95% of them owned a phone, out of which 80% had smartphones and 15% had feature phones. 71% of these respondents had access to internet on a daily basis. 80% of the respondents could read an SMS in Hindi, while 79% could play videos on their phone. Statistical analysis then showed a significant and moderately strong relationship between education level and household phone ownership, meaning that education is a driver of digital inclusion. We then compared the knowledge of digital tools with the actual adoption. So out of the total respondents, 53% knew about Aabha IDs, 31% knew about telemedicines, and 29% about digital health lockers. However, only 1/3 of the respondents reported using any of these services. A deeper look then told us into the type of digital services that these respondents used. Okay, it showed that 19% used Aabha IDs, 13% had phone consultations, and 11% had video consultations, while only 8% was using any health apps. We did a logistic regression to check the association between education levels and awareness of these tools. The results suggested that compared to no schooling, higher levels of education decrease the odds of being unaware of digital health tools. We then noted how these respondents were skilled and trusted the digital services. So 75% were confident that they could read a message in Hindi. Only 19% trusted medical advice through phones and videos. But 57% said that they would store medical records online. We then drilled deeper into the skills area by using the DigiScore. Our respondents showed a moderate literacy, that is, on an average they possessed 2 out of 3 skills that we assessed. Some respondents scored a 0, while some scored 3 as well. Next, we assessed the DigiScore with gender and education. A t-test revealed that men on an average scored 2.12, while women had an average score of 1. This suggests that digital literacy was higher in males. Then we conducted an ANOVA for education, which showed significant differences between adjacent level of education, with the largest gaps occurring between no schooling group and higher education categories, thus confirming that higher literacy was with higher levels of schooling. Next, we wanted to understand the barriers the respondents faced to adopt digital health services. When we asked them, 62% cited a lack of awareness, while other reasons were preference for in-person doctor, language problems, lack of internet, no phones, etc. Then we wanted to understand what would lead the respondents to use these digital health services. 51% said that support from a volunteer or an ASHA worker would help them. And other enablers were social learning events like group demonstrations, apps in local languages, physical touch points, assurance that their medical records will be safe, and of course low-cost internet. Then lastly, we conducted a correlation analysis that highlighted several important linkages between perceived barriers and the potential motivators for adopting digital health. The respondents who said that they did not know about it, they were more strongly associated with the motivator, local help from ASHA or volunteer. This suggested that an awareness campaign, while important, will be insufficient on its own. A personalized, community-based guidance is likely to play a decisive role in the uptake. Similarly, the barrier preference of in-person doctor was positively correlated with local telemedicine center, indicating that individuals who were hesitant about remote digital tools will be more receptive to hybrid care models that retain a sense of physical proximity and reassurance. This finding underscores the value of local digital touchpoints such as telemedicine kiosks as a bridge between traditional and digital health. Now we conclude by saying that access does not equal adoption. The availability simply does not ensure that there will be health equity. It is a blend of technology, digital skills, trust in the system, and support from the community that would ensure an equitable adoption. The focus here should be to integrate digital skills in community health programs, build hybrid models for hesitant users, and develop culturally resonant apps with privacy. Thank you so much. If you have any questions.
Thank you, Dr. Prevnika. Let's hear from the audience first. Any questions from the audience?
I guess everybody, we can't hear you. You're muted probably.
Any questions?
Prenika, can you hear us?
Yes, I can hear you. I can hear you, sir.
So, Prenika, I saw that it's a purposive sample. So, given the low digital literacy, as I mean, of course, in one of the substrata, and there is this possibility of high social desirability bias, especially those who are those who are on the positive side of the digital divide, they are more likely to report that they are using certain elements, whether it's the awareness about ABHA or about accessing digital health services. How confident are you that your findings is actually have some sort of representativeness at a mass level, at a scale?
Purposely selected that we made sure that our sample would include women as well as those who do not have a phone. So it's possible that somebody might have heard about it in a remote area, because there's several awareness campaigns and we know how much digital adoption was promoted in Bihar in the last 4 to 5 years. So we tried that we include everybody, and nobody was left behind. We included women. We made sure, of course, purposive sampling was done accordingly. And of course, we included those in the 60 plus age group. So everybody was there. And of course, when we did a demographic analysis, the descriptive statistics we conducted, and we saw that, okay, there's a significant population. And then our results also showed that, okay, this is going fine.
But your results, how does your result show that your data is actually representative?
So, like I said, in Bihar there has been a lot of focus on digital adoption.
Yes,
we
since 2019.
There's a high penetration. I'm sorry, sir?
Yes. Since 2019, there has been a concerted effort to improve digital literacy in Bihar. That I am aware of.
Exactly, sir. So when we were asking the respondents and a general perception, since we have worked in Bihar, so we were aware that people have some sort of idea, but still a section of the population might be left behind. And that is the reason we went deeper into these areas and asked the people who we found that they did not have the same access as someone in an urban area. For example, the Sadar blocks. People would be much more aware there, but in a very far away area like Aurai of Muzaffarpur, people might not have the same level of access to smartphones, and thus we included everybody in the sample.
Okay. And my second question is, of the potential solutions that you have suggested, which one do you think would be most cost effective to promote digital health adoption at our scale?
So the most cost effective would be giving support from the local community. We already have ASHA workers, and another would be including digital sort of training into community health programs. Since we are already in touch with the community, and we are conducting several interventions every single day, so giving a little bit more to the people would definitely help, and it will be cost efficient also.
Okay, thank you.
Thank you, Dr. Prevnika. In fact, my questions also have been answered. All the best to you. So we move to the next presentation. Dr. Chintan Desai. Again online, please join and share your presentation. So, we are running, a little behind time. So, kindly wrap up your presentation in maybe less than 10 minutes, 9 to 10 minutes.
You speak my name? Hello?
Please share your presentation.
Okay.
We can hear you.
Can you see my screen?
We can.
So, good afternoon. My name is Dr. Chintan Desai from Tufts University, and today I will be present our study title Association between obstructive sleep apnea risk and oral discomfort in Korean adults. This work was prepared for HealthCon 2025, focusing on innovation in health formation technology in low and middle income countries. So, as a background, obstructive sleep apnea or OSA is a highly prevalent sleep disorder characterized by repeated upper airway collapse during sleep. OSA is linked to major systemic disease such as hypertension, diabetes, conjunctive impairment, and cardiovascular complications. At the same time, oral symptoms include dental pain, dry mouth, bruxism, and temporomandibular disorder are increasingly recognized in the individual at high risk of OSA, obstructive sleep apnea. Understanding how sleep-related breathing disorder influence oral discomfort can improve early detection and integrated patient care, especially in resource-limited settings. Then this study had two main aims, like to determine whether increasing OSA risk measured with the stop bang tool is associated with dental pain and chewing discomfort in Korean adults age 40 and above. And second one is to assess whether this association remain consistent across major comorbidity subgroups such as diabetes, cholesterol, and chronic kidney disease. This help us help me understand whether OSA risk can serve as an independent marker of oral health problems. And data source and study design, as I used data from Korean National Health and Nutrition Examination Surveys from 2019 to 20, a large national representative data set. This study's design was cross-sectional, meaning we I assess exposure and outcome at the same time. After applying exclusion criteria for missing responses and age less than 40, my final analytic sample includes 6,984 adults, and I conclude chi-square. I conducted chi-square test, ANOVA, and multivariable logistic regression across three adjustment to models. And this flow diagram shows how I arrived at our final sample out of 15,469 total responded. We excluded participant under age 40 and those with missing oral health or stop bank information. Finally, 6,984 adults reminded for analysis, and these figures highlight the rigorous inclusion process, ensuring validate comparisons. And the last OSA risk assessment is a stop bank tool. How is assessed? I use stop bank questionnaire is a validated and widely used screening tool for OSA risk. Like stop bank include 8 components like snoring, tiredness, observed apnea, high blood pressure, BMI, age, neck, circumference, and gender. Then participants were categorized as a low, intermediate, or high risk.
and then importantly, Asian specific BMI and neck circumference cutoff were applied to reflect regional body composition patterns. And then oral discomfort measures like I assessed two oral health outcomes. Dental pain participants were asked whether they had pain while eating or drinking during the past
You have
year.
5 minutes.
And chewing difficulty. This was based on difficulty chewing due to teeth, gum problems, or dentures, and response of moderate severe were counted as positive. And these are standardized items in Korean National Health Database, allowing reliable population level comparisons. And this table 1 is summarized demographic and clinical characteristic across OSA risk groups. Like participants in a high risk group were more likely to be male, about 92%, and they also had significantly higher BMI, waist circumference, and neck circumference. And then comorbidities such as diabetes, chronic kidney disease, and hypercholesterolemia were more common in the higher OSA risk groups. Lifestyle factors such as smoking and heavy alcohol use also increased with OSA risk. All differences were statistically significant, indicating clear health and behavioral patterns associated with OSA risk. And here I see that the prevalence of dental pain increased with OSA risk from 23.7% in the low risk group to 27.4% in the high risk group. After adjusting for demographic, socioeconomic, lifestyle, and medical factors, individuals in the high OSA risk group had 1.4 times higher odds of experiencing dental pain with a statistically significant p-value of 0.0156. This means the association is unlikely due to chance and suggests a meaningful connection between sleep disorders, breathing risk, and dental nausea.
Dr. Chintan, 2 minutes to wrap up.
Sorry?
2 minutes to wrap up, please.
Chewing discomfort, there is few slide, and I am in 7 minutes, so there is few slide. Chewing discomfort, the pattern was different, although intermediate and high OSA group had slightly higher p-values. The adjusted odd ratio was 1.31, but the p-value was greater than 0.5, meaning it was not statistically significant. And this table examines is the OSA risk and dental pain variance across comorbidity subgroup. I found that condition like hypercholesterolemia and chronic kidney disease, the elevated odds of dental pain in higher OSA risk group were mostly consistent. And the interpretation finding, there are several possible explanations for the link between OSA risk and dental pain. OSA-related intermittent hypoxia may increase pain sensitivity, mouth breathing, and associated dry mouth can worsen dental decay leading to pain. And bruxism, which is more common is OSA, can cause tooth wear and TMD-related discomfort. And the strength and limitations. Strength include the use of large nationality representative data set, validated OSA screening measures, and robust statistical adjustment. However, I also note a key limitation. OSA was not confirmed with polysomnography, which is a measuring tool. Dental pain and chewing difficulty were self-reported, which may introduce bias. Important oral clinical variables such as number of remaining teeth or denture used were not included. And in low and middle income countries, access to sleep study is limited. Use StopBank as simple and low-cost screening tool alongside routine dental assessment may
Dr.
enhance
Chintan, kindly wrap up.
Detection of OSA. And these conclude high risk of OSA is significantly associated with higher odds of dental pain even after controlling for multi-factors No significant association was found between OSA risk and chewing discomfort. These findings support the need for closer collaboration between dental and sleep medicine professionals, especially for early screening. And thank you to the conference organizer, and thank you all of for your attention. I'm happy to take any question.
Thank you, Dr. Chintan. Again, in the interest of time, we can have one question.
Yeah.
Any question from the audience?
Thank you, Dr. Chintan. That was a nice presentation, but I think you have to refine it a little bit because there are certain things where, just like you mentioned, that it is a cross-sectional study, but was the data secondary data that you mentioned?
Yes, secondary data.
So when you are doing a secondary data analysis, generally we don't call it a cross-sectional study. We can call it a different kind of analysis, but not really cross-sectional study. So that kind of some refinement will help you to get it further. Thank you.
We really appreciate the efforts you have put in, and I hope you'll take it forward, in your discipline. Thank you very much, Dr. Chintan. We now have the last presentation of the day. We have an online presentation by Adarsh Pradhan and Mirzanur Rahman. Welcome, and please share your presentation. You have 10 minutes. Kindly wrap up in 10 minutes. Can't hear.
I'm audible.
Yeah, you're
Yes.
audible. But your presentation is not visible.
Okay, I hope my screen is visible, ma'am. Okay, my name is Adarsh Pradhan. So I'll be presenting this my work today. It is about detection of dyslexia, like from the point of view of using machine learning, applying machine learning for the detection of dyslexia, and using neuroimaging. So now, while using machine learning and applying that using neuroimaging, how does it affect in low and middle income countries? So that would be my study. So dyslexia is a kind of a neurobiological disorder. Hello? Am I audible?
Yes.
So dyslexia is a kind of a neurobiological disorder which is affecting around 10% of the people worldwide. Here, having a dyslexic person doesn't mean that the person doesn't have normal intelligence. The person has a normal intelligence, just that he has problem reading or spelling words. So when it comes to low and middle income countries, even the problem is even it is higher, because why? Here the diagnosis kind of is a problem here, because the diagnostic facilities might not be available. The specialist may be minimal, may not be available, so that problem even becomes it's kind of a problem is even larger when we talk about it in terms of low middle income countries. So the general method is kind of to detect dyslexia, to diagnose dyslexia, is behavioral screening, where people kind of the clinician or the doctor kind of does the consultation. Some questionnaires are given, some questions are asked, and then the screen is kind of, it is subjective. And another problem is that it is kind of too late. By the time the child or the person, by the time it is diagnosed, he might have suffered kind of lot of setbacks in his in the like he might or she might have suffered already some kind of setbacks, because dyslexic person might have some problem in the society, while because he or she cannot be able to may not be able to read or clearly read or understand words, or may not be able to pronounce the words or sentences. So here what we are saying is that by using fMRI, there is the technology which is fMRI. What it does is that it captures the brain activation that happens due to the flow of blood in the brain. So the more the blood flows, the more oxygen flows, and the more neurons gets activated. So now here there are certain sections of the brain which relates to language formation, language creation, language understanding. So those sections, those areas of the brain can also be identified by using fMRI. And now neuroscience studies has also shown that dyslexic persons can have different types of activation patterns while doing the reading task, while not only reading task, while having a kind of a visual stimulation also, the brain activation might be different. So now the problem with fMRI is that the fMRI scans are expensive or costly. The infrastructure that is required is also costly. We need trained personnel, we need trained staff to handle the fMRI system and all. So if we talk about using machine learning for detecting dyslexia, this is a general pipeline where first the data has to be acquired. The data here, even if I'm talking about fMRI, the data could, even if the data is EEG signals, or even there are other methods, like one method is by using the handwriting of the child or the person. That would go as an input. So first the data has to be collected. The data might have to be we need to do some kind of pre-processing. Then after that, feature extraction is the third part, where we try to extract relevant features from the data. After that, the model, the feature, using the feature, the model is being trained, and then the testing is done by using certain metrics, accuracy, sensitivity, specificity. By using those metrics, the testing is done. And finally, what finally it matters is that finally, after we use machine learning to do the detection, the output that is generated, we should be able to interpret that. We should be able to understand what actually the AI model has actually done. So that again is an important feature that has to be done. So to explain this briefly, this is a simple pipeline of how machine learning would work. There are when we come to machine learning, or when we come in terms of computer science, there are two kinds of using AI. One is called as traditional machine learning. One is called as deep learning. So even in the case of dyslexia detection, studies has already conducted where they've used SVM, they've used ANN, and by using ANN on fMRI data, on using GTI data, they have acquired around 94.9% accuracy on using SMRI. This is also another kind of MRI where they have achieved accuracy of around 82% by using, in another study they have acquired around 83% accuracy. Similarly, by using deep learning, where they have used convolution neural network, they have acquired accuracies of in one study they have acquired 72%, in another they have acquired 95%. So overall, what we are trying to say is that dyslexia detection is possible by using machine learning. But again, now when we talk about using fMRI, again, since it is costly, so there are other methods, which is one such method is EEG, which which records the brain, the electrical signal that the brain sends, so that can be recorded, and then the various features like power spectra or time series patterns can also be detected by using AI model. It is since it is a bit cheaper than MRI. This could be
please wrap up in 5 minutes.
Okay, ma'am. So these are some of the features which are a bit cost effective than the fMRI. So since for using fMRI, the problem is that the infrastructure problem is there. Another problem that is there is that we do not have the the complete data set, because to train an AI model we need as much data as possible. So the large, so that much amount of large amount of data to train an AI model to make it as much accurate in the diagnosis, in the detection of dyslexia, that is not existing. Yes, there are some open source projects where they have contributed some images related to dyslexia. Some has also done for EEG, but that the large amount of data set is not yet possible. Again, another major problem is that when it comes to those data sets are mostly being collected through high-income countries, not from lower-income countries. So now the problem would be that whether the model would generalize to the to local population, that also is another problem. So if we want to collect data set from local population, again the problem is that would be expensive, and the collection would again be expensive. So that the data scarcity is there. Another challenge is that whether the implementation that has happened, whether how much, in what manner did it in what manner was the classification, was the prediction being done. So us from a CS background, computer science background, we would be able to understand how the algorithm works. But for anyone other than the CS background, for clinicians, for doctors, it would appear as a black box. So here, interpretability, the explainability, the understandable of a AI model is another challenge. As along with that, ethics, as we all know, ethics is always a challenge when we use AI. So what is the future? Here is one future is that we might combine a lot of other sources, not only EEG. If we combine the EEGs along with that handwritten inputs, along with that SMRI is a bit cheaper than fMRI. So this could be combined, and then the data set could be formed. If all data sets are not possible, at least by one or the other, the combination could be done. So here the thing is that when we use such models where the combination data set is there, algorithm which is there, which is called as region transformer, is very much useful, whose internal working principle itself is that it can take multiple modalities, multiple types of data sources it can take. So that is one of the features. Another thing is we can use transfer learning, where already trained model could be used. A trained model which has already been trained could be used by other researchers from low-income categories. They can use it and they can fine-tune it for their own purpose. So transfer learning is another possibility. Also, few-shot learning is another method where if an algorithm would be there for the algorithm to be trained, if it would not require that much of data set. So that also is another possibility. Obviously, for an AI to be explainable, that is a very much requirement. Now the problem is that since we want it to be explainable, since we want it to be easily available, the standardization of the data set is also another issue that has to be solved. These are some of the future scope that we found, and where we have to work on making dyslexia detection accessible for low and middle income countries. So this is what we would like to conclude with that. So,
thank you, Adarsh. Your presentation was very informative, but you did not share how. Obviously, you did a review, but the methodology of the review was not clear. It would have been better had you shared the methodology also. But now we have run out of time. In fact.
The voice is very slow, ma'am. I'm not able to understand, ma'am. The voice is very.
You had not shared the methodology of your review. What were the objectives? What were the databases? How did you search out the information? How did you extract the data? All this information was missing, although what you shared was quite informative. And I was saying we have run out of time, so there is hardly any time to hear from you. So if there is a pressing question, somebody can ask.
Ma'am, I'll take this, ma'am, as a useful information, and for the next time I'll make sure I'll do this, ma'am.
Thank you to all the presenters. Only one point from my side for almost all the presenters, although I'm seeing the in-person presenter is not listening to the panel. But basically, it's important to pay attention to an academic presentation also. What should be the amount of data there in the screen? What is the use of the positive area, negative area? What should be the font size? What kind of animation to be used, not used? These are good things to learn. Thank you. Thank you, Dr. Pritha.
Thank you. Thank you, sir.
Thank you, Dr.
I think we thank the audience, the presenters, as well as the audience, in addition to my fellow panelists. Thank you. We must have, I hope we learned something from all these presentations, and best wishes to all the presenters. Thank you.
And a message to audience. I know it was a 2 days long conference, and it's almost the fag end, but still there are 2 more sessions, and we have very elite panel waiting for all of you. So paying attention will be great.
Thank you. I'd like to thank the chair and all the presenters for the insightful presentation. I would like to request our chairs to facilitate Dr. Ruchira Mukherjee for her paper presentation. Now, I would like to thank all our online presenters, Mr. Prasanna Dungel, Mr. Madhav Nirola, Mr. Chintan Desai, Mr. Syed Nabil Siddiqui Hussain, and Mr. Dr. Prenika Kachru, Dr. Adarsh Pradhan, and Mr. Mirza Noor Rahman. Thank you all. Coming up next is our second panel discussion of the day. Use of technology in sustainable solutions for primary healthcare, social innovation, and hard-to-reach populations. This session brings us together global experts advancing digital equity, community innovation, and primary care strengthening. We are honored to invite Dr. Aritra Das, consultant epidemiologist at the Piramal Foundation, to chair this session. He has over 18 years of experience evaluating major public health programs with 49 peer-reviewed publications, spanning infectious diseases, preventive medicine, and program impact assessment. Our first panelist, who is joining us virtually, is Dr. Krishna D. Rao, professor at Johns Hopkins University. His research focuses on health system, human resource planning, and health financing reforms across LMICs. And he serves as assistant editor of the International Journal for Equity in Health. Up next is Dr. Wemming Tang, research associate professor and co-director for UNC Project China. He is leading expert in infectious diseases, implementation science, and digital health, and has built one of the Asia's most prominent global health programs with extensive international publications. He is also joining us virtually. Our next panelist is Dr. Sean Sylvia, who is joining us virtually. He is associate professor at the University of North Carolina at Chapel Hill. He is a health economist with work published in top global journals and leads the Digital Health Economic Lab with prior roles in Renmin University of China, Stanford University, and the World Bank. And finally, we welcome Professor Ye Zhang Professor at Nanjing Medical University. Her work focuses on infectious diseases, care cascades, and patient-centered health systems, with impactful publication in Nature Medicine, Lancet Regional Health, and BMJ Global Health. Backed by grants from National Natural Science Foundation of China, she is also joining us virtually. Requesting audiovisual team to bring all our respected panelists on the screen. With all the dignitaries present, we now request our chair, Dr. Aritra Das, to kindly lead the proceedings.
Good evening and good morning to some of the panelists. I hope everyone can hear me. Yeah, it's always it's always great to connect with you all. Hi, Wiming. Hi, Sean. It's been a year we met. Hi, Krishna. Hi, Dr. Zhang. This is the first time we're meeting. Yeah. Okay. So we are about to start this panel. When I received this invitation, the first thing that came to my mind, again, it's on a slightly lighter note, that if there has been a plethora of applications or digital health solutions in the last decade, even in our country, which is an LMIC. But had all of them, all these piloted apps, had all of them been put to scale, then actually we'd have run out of server space and we'd be looking for a new cloud server. And even simply to store that logo even, it's that number, that huge a number. It seems like it's the so-called Bollywood movie that there's this, it comes out with so much brouhaha and then everything fizzles out and then we look for the new blockbuster out there. Jokes aside, it's this sort of gap between what has been promised by digital health solutions and the gap with its implementation in actual practice. That actually worries us all. It's not whether we can build new solutions or can come up with new innovations. That's always possible. But are all those solutions able to help a nurse in a busy primary health center or some frontline health worker working in a remote village, or even say some peer educator as Wei-Ming or Dr. Zhang would be speaking about, some peer educator working with some vulnerable populations. That begs the question. And additionally, whether these solutions have been able to last long enough to be considered sustainable, and whether these tools are still funded and functional. a few years down the line. Because we have, again, based on my limited experience, and I am no digital health expert, but I have seen that after a while, the funding just keeps moving away to so-called, to something new, something for a newer or greener pasture. And we are actually very fortunate to have these 4 distinguished panelists, each of whom will bring a different piece of this puzzle. And I request each of the panelists to speak for about 7 to 8 minutes. And then we can try to pull out some common threads and face some questions from the audience. I hope that is fine with everyone. And with that, and with all the dead pilot apps watching us from some distant cloud, let's invite Dr. Rao to start us off.
Thank you, Ritra. Shall I share slide?
Yep, please.
So good evening, everybody. It's a pleasure to be here and to be among old friends like Aritra and Dr. Tanmay. I'm going to talk about digitization of health information systems in India, and in particular about how health workers use this digitized health information, and the sort of challenges that they face in doing so. And this comes from a project that I've been involved with in India, where we're working in 3 states at supporting primary healthcare programs of the government. And so we've seen how this whole push for digitization has how it interfaces with how health workers use data and so forth. So for a bit of background, over the last 10 years, India has made some very impressive progress, I would say, in digital health. We had, there's the Ayushman Bharat, the digital mission, which was started in 2021, which is a very ambitious program, with the ambition of creating a secure, integrated digital health ecosystem, where personal health records are digitized for everybody. There's a unique health ID called ABA ID for everybody. There'll be registries for all health professionals and so forth, right? And this has been one of the centerpieces of the government's digital efforts in the health sector. Now, what I want to focus on is the digitization of health information systems, and as part of this whole process of bringing digital health in a big way, the public sector health system has also started digitizing their health keeping records. So you have all of these population registries like the CBAC, which is a survey that's done for communities in primary healthcare catchment areas, or for people who are 30 years of age and above. And this is for checking, it's a checklist to see if someone is at risk of NCDs or not. So that has been digitized. There are these family folders that are largely focused on collecting information on maternal child health from households living in a facility catchment area. That has been digitized. And there's these various portals that have been created, national portals, like the maternal child health portal, the NCD portal, and so forth, where a lot of data that used to be collected or recorded in registers and so forth now are on a digital platform. And of course, the big benefit of this is that this data is then visible to various levels within the public sector health system, right from people at the block managers, district managers, state managers, and above. So there's a great visibility in information, and once it's entered at, say, by the frontline health workers and so forth, this data is then visible throughout. It's used to pay financial incentives to health workers and so forth. So the idea behind this was an important one. Is by making creating this digitization of information systems, there's much greater visibility on how how these health facilities and the health system broadly, and I'm talking about the primary healthcare system, is functioning. Well, that was sort of the aspiration and effort in that direction. But in our fieldwork, what we've been seeing are very important challenges to this to this effort, right? And one is, there are infrastructure challenges, and this is well known and would not be something uniquely an Indian problem. There's inconsistent internet access in places. There's limited mobile data, so entering data for health workers, etc., on their apps or accessing this data can be a bit of a challenge. But to my mind, the sort of the bigger problem was that even though a lot of these registries have been digitized, right, health workers frequently still manually record all of this data, and that places a dual burden on them. So, for example, this is from the state of Meghalaya, where we have a field site. You can see the number of registers that these primary healthcare centers have to maintain. So they maintain 31 registers for RM and CH, 7 for communicable diseases, 4 for non-communicable disease, and so forth, right? And what we saw was that of these, say, 31 for RM and CH, 16 are only are paper-based, so they are still recording on these registers in a paper-based way. But in the remaining ones, they record both on a paper-based as well as on into the portal. So it's not like they've given up recording using registers. So they're doing both things. So as more and more of these registries are being digitized, it's not reducing the reporting burden on health workers. It's in fact doubling it, because now they're doing both things. And it's a very curious thing why they're doing both. Partly, I think, is because they don't find a lot of these digital platforms very reliable and so forth. So they maintain their own paper registries, and then they enter it. And wherever I've gone in our field sites, the big thing that all these primary healthcare workers talk about, the amount of time they spend in data entry. There is no dedicated person in the primary healthcare team responsible for data entry. So these workers spend a lot of their time, just filling in these registries and collecting data and entering it. And the digitization process has in many cases, in these cases, also doubled sort of the work that they had to do. So that was one thing that I wanted to highlight. The second is that the digitization has also not allowed. One would expect that by the digitization of these registries would enable health workers to have a comprehensive view of the performance of their facility or of their block and so forth. But that also hasn't really happened. For one reason is that because of how verticalized a health program is, right? Each sort of disease tends to have its own portal. So to understand how, say, for example, a health facility is performing, or how the catchment area health is doing, you need to look at multiple portals. There's no single portal that will tell you that this is sort of the health status of the catchment population. The second is what we saw was that these digital apps that are used to both access these digital databases and also enter data are designed for higher level managers to observe and monitor the health system, right? They're not designed for frontline health workers to know what is going on. So it's really a monitoring tool, and that's been the design of these things, rather than a tool that enables or empowers lower level workers to understand how they are performing or how the health of their community that they are serving is. So that I think is an important missed opportunity in this effort to digitize all these health information systems. And finally, I've talked about this lack of integration, and this lack of integration among different portals, right? So you have a portal for maternal child health, you have a portal for NCDs. This lack of integration between these portals prevents not only a comprehensive view of the health of that catchment area or of how that facility is performing, because you have to look at multiple portals for different conditions, but in many times, the same households are surveyed by different programs. For instance, the CBAC survey is done on an annual basis of all households, but they only focus on adults above 30. The family folder is for maternal child health, and it's focused on mothers and children, but the same households. But these two databases are not integrated, right? So you instead of providing a comprehensive picture of what is going on in the household, you have to actually look at different ones to know what is happening within each particular stream. So these are some of the challenges that we've observed, and so just to conclude, I think there are tremendous benefits that can be realized by well thought through digitization of information systems. Some basic things I think need to be given attention for this potential to be realized. This duplication needs to be stopped. I think the number of registries that health workers enter information into, that needs to be reduced, but that's an old problem that doesn't seem to go away. And then these digital apps need to be configured in a way that they provide meaningful information to frontline health workers and not just as a monitoring tool for higher level managers. So with that, I'll stop. Thank you, Aritra.
Yeah. Thank you. Thank you, Dr. Rao. Any questions for him?
Good morning, Dr. Krishna. Tanmay here. Can you hear me?
Yes.
Yeah. So I had a question which is not really based on your presentation, but really little bit future facing. In our journey for over more than 1.5 decades in settings like Bihar, you have presented from another setting. We have seen lots such aids. I'm using the word because it may be considered a job aid, it may be considered a personal aid, it may be considered a total data system aid, but ultimately we have seen several aids coming for the frontline workers. And we all know that frontline workers are really the cornerstone of our public service delivery at the last mile for health. But none of them have been seen to come up with such a quality data that can inform research. We have seen them coming up with something like very close to be something like a process data or operational data, but later on for the operational research for government to take decision, policy decisions especially, this is altogether a big data. ultimately if coming from the country, from the frontline workers. It can ultimately inform a lot of programs and policies. Is there any learning from overall your experience, your huge experience of working in different places? Is there any idea how we can actually get these up to the quality where we can actually have some policy implication based on research learning from this data? Over.
Yeah, thank you, Tanmay. You know, I think it's an interesting question because there's a sort of myth that health workers don't use data and such like, right? Or managers in the public sector system don't using data. What we are seeing is that they're inundated by data. The system generates so much information, so much data. Most of it is not used. It's just reported upwards and it keeps getting collected in someone's, I don't know, database, someone's laptop or whatever. But so that's one thing. The second is a lot of this, I think a lot of the information is extremely valuable. For example, if you look at the NCD app, you can know through that app whether a particular person in a particular village was screened for hypertension or not. So it gives you that level of visibility into the system, right? And I was amazed that that sitting in the state capital, you could narrow down to one village in the state and know which person was screened for hypertension on what date. So that's a very powerful thing. But the problem that we are also seeing is that one is because this data is not used or it's not available by researchers, the quality of this information can never be truly evaluated. Unlike survey data that is made publicly available, like the NFHS or whatever, right, where researchers use it, so the problems or issues with the data can be judged. Knowing that with routine information system data is difficult because it's not used. The other issue that we've encountered a lot is that governments are not very keen to share this information. It's very difficult to access this data. And I find that rather unfortunate because I think, people in the research community can bring a lot of learnings to these managers who are managing these programs by applying some very basic analysis to this information. But there's a reluctance on the part of governments to share this information. So, yeah, thanks.
Please.
Good morning, Dr. Krishna. I'm Dr. Yashwant, currently with the PHFI. I have a question, sir. I was previously consultant with the AP State AIDS Control Society, and this was in 2020 that entire NACO moved from SIMS, the Strategic Information Management System, to SOCH, the Strengthening Overall Care. So it was told that for 1 year data needs to be entirely re-entered. So they had to download the data from SIMS and re-enter into SOCH. So for almost a year data was to be re-entered, and which means that, program activity has to be halted, and, all the people are focused on entering the data. Has there ever been an attempt to see how much does this, duplication of data, may it be physical and digital, or, entering from one platform to another, how much does it cost? So that, there is a specific number that you put in front of people that, this is how much it costs.
Yeah, I mean, I think you're giving another example of this duplication that we've also seen in our field sites. But was there a question or just a comment?
No, my question was that has there ever been an attempt to do a costing of how much these extra efforts cost the government or the program? Because when you are making them not do the operational activity and make them do data entry, that involves some cost, right? You are wasting your efforts and money.
No, so and it's a good. I haven't seen any costing studies of this, but I've seen studies that try and estimate how much time health workers spend on data entry and I think on collecting and entering data. So those studies are there, and it's a substantial part of their time that goes into it. And as I said, wherever, in our different field sites, wherever we have, talked about this with frontline health workers, they all complain about how much time they're spending just entering data. That doesn't allow them, takes away from their time from doing, the activities of providing health services to people. In some countries, they have dedicated data entry people at the primary care facility level. To my knowledge, in India, at least in the states we are working, that person doesn't exist. So it's the medical officer or the CHO or those people who, the A&M who, ASHAs who do the data entry themselves. So.
Thank you.
Yep. Thank you, Dr. Rao. He raised a very pertinent point that if this entire digitization effort is actually leading to more work for the frontline health worker and not necessarily resulting in better care. And with that thought, let us move to the next panelist, Professor Yi Zhang, who would be focusing on digital interventions that centers around community engagement, with a strong lens on how communities themselves shape uptake and impact. Yeah, Dr. Chan, please. You have to unmute yourself, Professor Zhang.
Is it my turn?
Yeah, you are audible now.
Okay, thank you. I will share my screen then. Just 1 moment. Thank you very much for the invitation. And my name is Yi Zhang from Nanjing Medical University in China, and really appreciate the opportunity to do the panel discussion here. And also like to just to clear up, sorry for the mixed up information I made earlier. There's so many amazing senior panelists on the session. I definitely not a professor yet. And today I will talk about the social innovation and digital health. So start with like there are so many like challenges to uptake the health service globally, and estimated 4.45 billion people lack coverage for essential health service globally, and there are specific like the gaps in China as well. For example, 10 people died in influenza each hour in China, but only 2% of them got vaccine. And also, like because China had huge burdens on the hepatitis B infection, but less than half adults in China ever tested for HPV. The story also continued for the key populations in China, like who are like with high burden of HIV and STI, but not tested them optimally as well. The barriers to uptake, including low awareness, low perceived risk, as well as the high price for the health service, low accessibility, stigma, etc. And we think the social innovation is a way maybe to address these barriers. And social innovation, the definition of it is like they are inclusive solutions to address the healthcare delivery gap that meet the needs of end users. It have like the 4 key features. So the first, it is a participatory process that promotes the social inclusion. It is also a new lens that to look at the creative solutions, new solutions for social problems. And it's also being a way to meet the human needs, by increasing empower the people, empower the people participants. And it's also regarded as a label for system change. So today I will share an example of social innovations in China called Pay It Forward. The definition of Pay It Forward is someone, the concept of the Pay It Forward actually, it's someone receives a gift to free or free service and then gives a gift to another person. And
sorry for the interruption. Yeah? Probably you did not
just show your slides and they just.
We
Oh,
also,
really?
I
Oh,
don't
sorry.
think the slides are moving. Yeah.
Yeah.
Can you see now? Yeah. Maybe I just,
Yeah.
if it's okay, I
Establishing
can
the
just,
sharing model, probably that's why, yeah.
okay. Or if you can see that, I can maybe just talk like this. Is that okay?
Maybe you can put it
so,
on presentation mode. Otherwise, it's not legible.
presentation mode. Maybe I share my screen again. Just yeah. Sorry for the. So let me know, is it working?
Yes, it's perfect.
Okay, thank you. And and in our study, like we use the pay it forward concept to promote the health service uptake. So if a person come to a clinic or community site, we will give them a free health service. It could be a testing or it could be a vaccine. And they will know like the vaccine and the testing already been paid by their peers in the community. And we also wrote a postal card for them to encourage them to take the test or take the vaccine. After they take it, we will also ask them if they want to donate some money or write a message to the following participants to let them to get the same free service like him. And so we did our first RCT, like to demonstrate the effectiveness of this pay it forward strategy. And in this study, like we focus on the men who have sex with men, and we randomly assigned them into 3 groups. First is pay it forward group, which I just described before. The second group is pay what you want, where men are offered a free test and could pay any desired amount. And the third arm is designed to capture the free reduction component of pay it forward, and the third group is the standard of care group. So the result showing like the pay it forward actually working and really effective to improving the chlamydia and gonorrhea uptake among this population. Comparing to the standard of care group, pay what you want group can increase to about 28% of the uptake rate, and the pay it forward group can increase about 38% of the uptake uptake rate. And about most of the participants choose to pay it forward, which means they donate some money to their peers, and the average donation is about 50 RMB per sample, which is about I think $8 per sample. And then we extend this like the pay it forward to other settings as well as other population, and it all show very promising result. Like for example, it increased the we integrated with community surveys. So the community, the local community initiate hepatitis testing surveys in their office, which also showing a quite good result. And we also increased the flu vaccination uptake among children and adults using the pay it forward strategy, as well as the HPV vaccination uptake among adolescent girls in China. And so, just to summarize, like the social innovation, what pay it forward and social innovation can do, it effectively improve the health service uptake. It also a low-cost way to expand health service, which is the cost effectiveness analysis show it's much cheaper than the standard of care, and total donation also help the offset some of the screening cost in the pay it forward group. And it's also good to reach the marginalized population as well, and particularly useful for like in one of the study we did, like it's particularly useful for to reach the men who use the drug. And the qualitative study also show it can improve the engagement and social support, and as well as the community belonging. But the social innovation can be really powerful too, but many initiatives actually remains more because all of these pay it forward projects I talked about, it depends on the face-to-face activities and the local resource. So and which we think digital health can greatly increase the impact of these efforts. For example, it can expand reach and reduce access barriers. On the left, in the bottom of left, the picture, there is a picture like the village doctor using the affordable and the mobile ultrasound to help the women living in the village in the rural area in Uganda to get the regular pregnancy check. And and the social innovation also the digital health also can help the social innovation get more engagement. It can make the social innovation more fun, like the more exciting, and the people can do the exercise, like they can use the digital platform to track their records. They can also share their exercising like the record with their friends. And digital health also can enable the real-time monitoring and adaptive implementation. For example, there is one study in Europe that they use the smart diabetes assistants, help the people to check their blood sugar as well as the exercise they might need in the real time. And it also can help to digitalize the social innovation process to fit the routine workflows, which is on the right, the figure on the right, like what we want. I think what we want to do in the future, like to make a digitalized the pay it forward. Currently, it needs the people to expand the concept to the people, but in the future, we think maybe we can make all of this in a mini app. And at last, also the social innovation can help digital health to integrate more community-driven designs in it to increase the community engagement as well as to provide a people-centered platform. And I think my presentation is over. Thank you.
Thank you. It's really impressive. Yeah. Any question from the audience? So I just go ahead with a question. I mean, first of all, it's so fascinating to learn that community norms and reciprocity can do as much as you have shown. I mean, almost as much as the technology itself. My interest would be to know that what actually suggested. Did you do any pilot before going ahead with this paid forward model? I mean, what gave you that idea or the courage to go ahead with, because it seems like such a huge risk at a scale?
I mean, like but did we did any pilot study before we went the art?
If you did a pilot study, what gave you that idea? I mean, what's the origin of this idea of this paid forward model? How did this idea came along?
Yeah, I think because Dr. Tang and I think Professor Joseph Tucker is like the initiator of this idea, but I know the story. Like when Paid Forward actually is established the concept in the business world. So it's already there. Like the people sometimes in the Starbucks and in the coffee shop, the waiter will ask the people, do you want to have a free coffee, which the previous customers actually already pay for the coffee for you, and do you want to get one? And then they will be asked, like, do you want to donate some money for the next customer, make them have a good day. And so this is the originally like the idea from the pay it forward. It never used to be in the health field, but it has been used in other fields before. And it's the concept of the pay it forward also have a long history. Like it's used the upstream reciprocal, like the theory as well as the nature of the human. Like we love to help people. We love to make the others happy. Yeah.
Yeah, thank you for sharing. I mean, Dr. Tang always is kind of a melting pot of ideas, so it's no wonder that he and Joe Tucker managed to do it. Yeah. So with that, let us move to the next presentation from Dr. Wiming Tang. And he has pioneered technology-enabled and social networking strategies to improve HIV testing in China, not only HIV actually, or the STIs. So let us hear from his experience. Yeah, Dr. Tang, please.
Yeah, I'll just share my slides. Can you share it on screen properly? Give me a second, okay? Can you see my slides now? Or just in
yes
playing mode? Okay. Good morning or good afternoon, everyone. Thank you for being here. It's really exciting to be here to see many old friends, also new friends. For example, Rachel and Sanchita and Tammy and I have been met 15 years ago in Los Angeles. So it's so exciting to meet everyone today, even virtually. So my topic for today is actually harnessing digital health to end the HIV epidemic or as the epidemic. I'm an HIV researcher. Still, I'm defining myself as an HIV researcher. So I'm doing lots of HIV relevant studies. This was adapted from my presentation as a keynote speaker for International AIDS Society. We summarized what the digital health have been used to promote HIV health care in different areas and what is the challenge currently, how we can move forward. As you may know, digital health becoming more and more popular in the last 1 decade. Everything is turning digital, and so for the interventions for HIV in many different settings, for example, HIV have been using dramatically to promoting messages for HIV education, including peer-led models, to improving education and awareness, and crowdsourcing strategies to develop interventions, and the behavior theories were used in different gamification apps to promote behavior change, etc. Also, more importantly, digital intervention have been used to develop surveys for HIV testing and also STI testing. Digital platform can increase access to HIV testing. For example, in China, most of the HIV self-testing is actually online right now. People just go online, ask for a self-testing kit, and the kit will be shipped to them for free. And they also used to promote HIV and other STI service online to increase accessibility. Also, geolocation services are used to push information to people in different areas. For example, in China, usually if you have a gay dating app, we can push the information to you to deliver the tailored service for you for free, and also it can facilitate knowledge exchange through the communication. Of course, PrEP is pre-exposure prophylaxis is important. Prevention strategies is digital methods also have been used to improving its uptake and adherence, including understanding disclosure and the community perceptions for the PrEP use. Also, we give the PrEP prescriptions online through telemedicine. I'll reach out to this later on. Also, social media have been used to educate PrEP users. Mobile applications offer PrEP descriptions. Big data AI is also becoming a vital tool for HIV and AIDS prevention. Digital platforms construct part of big data for digital health. For example, this kind of dating apps or daily communication apps that generate lots of big data. And this kind of big data can be tailored, used to develop AI models, big language models, or even chatbot to facilitate the service for HIV services. For example, machine learning and natural language processing approaches have been used to develop the chatbot to facilitate HIV subtesting for to deliver service to prep users, etc. This kind of service is becoming more and more tailored for people. For example, if you have an app, probably the system can automatically generate a message to you to remind you that you should use your PrEP today, or probably you need to use a condom before sex, or remind you to continue to use ART to take the medication at a certain time. So these are kind of price intervention that is already widely available. As I mentioned before, AI and chatbot have been used to support HIV, including personalized information for education, risk assessment and prevention counseling, virtual navigation and link to care, treatment adherence support, and data-driven insight for public health. Also, another important area is actually telemedicine. Telemedicine is becoming more and more popular during the COVID-19 period, when many people cannot go to the hospital or do not have access to the offline clinical service. It can provide remote consultation and follow-up, and for the prescribed medication and monitoring. For example, during the COVID-19, when people cannot walk to a hospital, many people seeking care from the telemedicine platforms to get the ART medication prescribed and shipped to them. They can also provide training and mentorship through the platforms and enhance medical management. So even AI or big data or digital health becoming more and more popular, now certain problems remaining. For example, digital divide is still challenges to many settings, especially in low and middle income country settings. Even young people may have big access to this kind of smartphone, but to many people in low and middle income countries, especially in rural settings, digital divide is still a big problem. They have lack of access to digital platforms, lack of consideration for the prevailing and the digital ecosystem, and the availability of the technology in different settings so divided. Also, even the big data is everywhere. People are collecting different kind of big data, but actually accessing to this big data and the utilization of this kind of big data is still a big problem. Another concern is the ethical concerns. Digital is becoming more and more popular, but how we can actually correctly using the digital platforms to ensure equal opportunities, equities, reducing stigmas is a bigger concern. Also, privacy is another big concern regarding how we can actually protect the information of the users. For example, for HIV, many people, or master majority of people do not want to disclose their HIV status. How we can actually protect their privacy and protect their personal data is a concern. And that's my brief review for how actually digital health have been used to end HIV, and also how we can actually meet different challenges and address the challenges in the future. Over.
Thank you so much, Wiming. I mean, this is really, really interesting and fascinating. So, any questions from anyone? Yeah, please. Can you please give him a mic?
Hello, can you hear me? Yeah.
Yeah.
I'm Dr. Asif Imran.
I'm an NHS doctor, come from London, so I've got a conflict of interest. My daughter is at the moment
sorry, I can.
Can you hear me?
We cannot hear online.
Can you hear me?
Speak a little louder, sir.
Yeah, so, yeah, I'll speak a bit louder in the mic. So, I'm Dr. Asif Imran. I'm a GP and work in the NHS in London. So, I've just come today, conflict of interest because my daughter is training in Adri at the moment. So, it's lovely to hear all of you. Just to tell you the background, NHS has been collecting data for years and years, over 50 years, and has got a wealth of data. But there is a big problem over there in concern with privacy of data. Who really owns the data? How is it used? And are people consented for the data that is being used? Or are the people rewarded for the data that is being provided? It's the biggest currency now. In the future, data will be the biggest currency. So that's the biggest question. Who owns the data? And it's for all the panelists. Thank you.
And
thank you for the question.
And
yeah,
also, in a similar vein, actually, thank you for posing that question, Dr. Asif. So I also had a question in almost similar vein, that given the long history of stigma with HIV, associated with HIV, when you spoke about AI chatbots or other big data models, first thing is who owns that data, but also given that your users are people living with HIV, how do you circumvent the issue, or how do you convince them that whatever they chat with the AI chatbot, that's not going to be misused? I know that this data, you must have some sort of secure mechanism, so it's behind a firewall, but how do you convince the users, the end users, because there's this long history of stigma associated with it? Thanks.
Yeah, actually, for the first question regarding privacy, data security, I think this is the strongest concern for most of the people, whether when I share something, information of myself, this will be available online by other people. How can what if people share my information online? What's the consequence of myself of sharing the data? This is a concern for the end users at the most of time. So basically, what we have been done in the past is using different strategies. Like for example, for digital interventions, typically we developing interventions by working with the end users. And the intervention will be remove any after the intervention was developed, we will remove any individual information. Of course, for online data, who owns the data? Who actually for big apps gate dating apps, for example, the company Grindr they have millions of users' information. This is the strongest concern would be actually how can they have proper ways to protect all this information. I think the current main issue is actually how we can actually have different regulations, different strategies to protect the data and privacy. This is not just relevant to HIV/AIDS prevention and control. This is actually true for every kind of digital data, I think. Yeah. Richard, for your second question regarding stigma, stigma is our concern, a big concern for HIV prevention and control. And I would like to say offline models is more stigmatized actually. When people move to online, it is because anonymous in most of the time people do not need to meet each other. The stigma part is actually reduced a lot. For example, in HIV self-testing programs, people do not need to walk into the clinic to meet a CBO personnel or a physician. They can just easily order testing kit online, delivered to them for free, report the results online. They do not need to even encounter any personnel. This is also for many different strategies for promoting ART adherence, promoting digital adherence for PrEP, etc. The people do not need to know who are actually meet with, what's their situations. The personal information will largely not shared. This make them to less likely to disclose the information to others. Also, like reduce the stigma concerns. I think. Yeah. Over.
Thank you very much. What are your thoughts on data security? At the moment, a lot of data security is still quite, there's a lot of phishing scams and various things. NHS has been kind of hacked a couple of times, and the whole system went down because we are all linked. Hundreds of computers are linked, so we all kind of face the brunt of that. So obviously, it's the government that has to secure the data, but individuals as doctors and things, we are data controller for that individual.
Yeah,
so
I think not just the government, whoever actually own the platforms for delivering information should have their own role in digital security, ensure that the information they collected, the information they delivered is actually protected in a proper way. I think the important thing is actually before we start to do the things, we need to have a procedure in that protection. And if any information was like leaking, what's the procedures to prevent further information leaking? How we can actually provide the end users information?
Thank you.
Mm-hmm.
Thank you. Thank you for taking us through this entire gamut of peer-led online prevention messaging and crowdsourced content to digital pathways for testing. Yep. Thanks. So now let us move to Dr. Sean Sylvia, who is a health economist, as you have learned, and he would like to discuss about the digital tools and incentives that can change provider behavior and primary care quality in resource-constrained settings. Yeah, thank you. Dr. Sylvia, please.
Sure, thank you. Can you hear me okay?
Yeah,
Thumbs up? Yeah,
we can hear you perfectly. Thanks.
Okay, great. Here, let me share my screen. Okay, can you all see that okay?
Yes.
Good. All right. So thanks so much for having me. I've been looking forward to this, and so it's I think in the few minutes that I have, I just wanted to kind of to go into just kind of a high level perspective on kind of adaptation of digital health tools, and I think in particular, the kind of opportunity that I think digital health poses for low and middle income country health systems, but also the amount of uncertainty, and then how to kind of mitigate that through, I think, community engagement's a key piece of how to do it. And so this is very, very high level, and we can talk more about specific projects. But I think digital health is kind of a side point here, is that, with these digital tools, there's a lot of opportunity to, build in a learning process, right, where you learn from stakeholders, learn from the community, and feed that back efficiently into the design and monitoring of the system. So that's kind of the perspective that I want to provide here. I'm an economist, and so I have to have a graph in the presentation somewhere, a stylized graph. So if this is giving you nightmares from Economics 101, I apologize. So this, can you all see my cursor on the screen here? Yeah? All right. So this is just a kind of a stylized framing of what we call technological leapfrogging. And what you see here are, so first notice these like three curves. So there's an S curve here for Gen 1, Gen 2, Gen 3. These are different technologies that come along, right? So you can think of these as technological jumps. So maybe like iPhone 1, iPhone 2, iPhone 3, right? And so they start off where the technology is improving, and then it kind of levels out, and then the next technology, and the next technology. If you trace out the tops of these, that's what we could think of as the technological frontier. And so this is productivity, and this is time. And so over time, as you have these new technologies come out, the frontier of what's possible technologically kind of rises with that, right? And so we could think of this, applying this to digital health and use of machine learning and AI in healthcare. And so one way to kind of characterize how systems will develop along this path is that they're going to be somewhere below that curve, kind of increasing. Not necessarily right on it, because no system is perfectly efficient. But what I've drawn here, though, is a graph to kind of make a few key points. Is to highlight what I think is the key high-level decision for low and middle country health systems, right? Or kind of second movers, as we call them. So there's kind of you've probably heard of a second mover advantage, right? But this is a characterization of that. And so what we're thinking about is health systems kind of have two choices. In essence, one is to follow the path of these high income countries like U.S. or UK, right, and how they kind of develop their health systems. But those health systems were designed and contain like what we call institutional debt of these legacy systems. So they didn't have the technology, right? For example, the U.S. I think we're still using fax machines in our health system due to institutional reasons, which it makes zero sense technologically. And so this is kind of a high income country path. And so there's this what we call like this debt, right, or this drag that's institutional or technological on high income country health systems. But then if you're starting later, right, so say this is now, and you're a health system that's thinking about, okay, well, how do we have resources to invest in designing and upgrading our healthcare system. What do we do? How do we design it? One option is to follow the high income country path, which is, there's a proven trajectory you can follow, there's a path you can follow. But as I said, these systems have a bunch of like legacy debt built in. I think if most countries tried to follow the U.S., for example, that would be a very poor choice, in my opinion, right? Just for a number of reasons that we have, that the U.S. healthcare system is a bit of a basket case, as we all know. And so the optimal thing may not be to follow that. And in fact, I think, India and China, right, would go bankrupt if they tried to follow the U.S. path, for example, right? Just because there's with the dual burden of disease and all of these other issues that are kind of have changed. And so that's path one. Path two is to what we call leapfrog to the frontier, right? Meaning, so take a look at the technologies that are available now, and think about how to design systems so that they appropriately leverage those technologies. And so this is it sounds appealing, right? But it also contains significant uncertainty, right? So because it's not really a well-traveled path, there's less evidence to suggest, right, how you may move forward. And so there's a good amount of uncertainty. And so as you can see here, this is like, follow the safe path, but then, or you can try to leapfrog, and there's this cone of uncertainty that emerges. So that's kind of like a mental framing for kind of how I think about this, high-level question. But the question is, like, how do you capture that leapfrog opportunity while managing the risk effectively? And my my sense is that it's much larger than technological uncertainty, right? So, all of these, so the digital health system is embedded in, a healthcare system, which is a social system as well, right? And so you have this socio-technical system that's intertwined in different ways and constitutes what we call a complex system. And so, this is just a stylization of, what I think is, so you have, data that you're ingesting into the system, and then you have decisions that are made based on that data, which informs behaviors, which informs health outcomes. And those outcomes then are also influencing the data that's generated in the next period and then used again for decisions. And so you have these feedback loops that just add to the complexity. And there are a lot of what we call like unknown unknowns, right? So you have risk, okay, there are these different possibilities. Sometimes you don't know what those possibilities are, which is a huge challenge, I think, with designing these kinds of systems. And so the idea here is that health systems are kind of information processing and decision making factors, if you think about them that way, because that's essentially what at one level what they're doing. And what is unique, I think, about AI and digital systems is that they transform the factory floor, right? Because they inform how decisions are made directly and what information is used to make those decisions. They're not just affecting how care is delivered like a traditional technology, but also what care, when, and to whom care is delivered, or the benefits accrue. And so what we need to figure out is how do we learn about the system before we go and finally deploy systems in different settings. So think about what is the optimal amount to kind of figure out about how all these components work together, not just the technical components, but then also how do people interact with things, how does it influence workflows? Like Dr. Rao highlighted a few of these issues, and so we want to then also figure out how to design it to continuously learn. And so this is just a kind of a framework that is a summary of some papers we've published in. One is PLOS Digital Health, and others MDJ Digital Medicine. But these are both papers on kind of how health systems can think about the process of building in generative AI technologies, especially into their systems. And they kind of boil down to these kind of four things. One is the importance of gauging stakeholders first, and then collaborating in the calibrate to the local context. And then another is audit bias continuously, or audit the system continuously. And then finally is monitor and adapt over time. So this is a living, evolving system, which is another challenge. And so I think these kind of four steps, right? So where you are thinking about engaging stakeholders first to map and understand, talk to CHWs, talk to patients, talk to the healthcare officials that are consuming the data, talk to physicians, talk to patients, talk to everyone that are touched by the system, and try to understand, map this thing out and understand where those touch points are. And if you do that, you kind of reduce the number of unknowns, I think, to help you get on a better starting point. But then the rest of this is thinking more about how to continuously audit and then improve the system over time. And so in a nutshell, this is just kind of an argument for moving to this, to baking in the community engagement and into the design of the systems from the start, but not kind of this traditional approach of oh, hey, we built this cool thing, let's deploy it and then let's see what everyone thinks, right? Which is how a lot of health systems are doing it. So instead, it's thinking about how to set these up so that you learn continuously over time. And so we've kind of been working on this and tangential issues and the lab we have at UNC. So this is the website if you want to take a look at some of the projects that we have going on. But there's, I think, opportunity as you build these digital tools, especially to even design the tools such that you can collect this data in a research capacity to improve the system over time. And so that's the final point. I'm done.
Thank you, Dr. Sylvia. Any questions from the audience? Okay, I'll start with mine. So you mentioned about co-designing. What, again, my practical experience, given my whatever I have been working with for since the last decade, it's really a struggle to co-design with the end user, especially when we are referring to the frontline health workers, like community health workers. We don't share the common vocabulary. We often struggle to get inside her mind that what actually solves her problem, because she's not articulate enough, or at least I am not, my perception doesn't really get there, what she's trying to articulate. So how do we solve for that?
Yeah, that is a great point, and the friction there is, we've as we've designed tools mainly for research and implementing trials, that's always a challenge, is trying to understand, right, and try to get on the same page with the community, because we often are not speaking the same vocabulary or using the same language. And I think the approach that we've taken is to kind of think about essentially a schema, right, in the technological frame. So thinking about a dictionary, right, of things of key components that we think are important in the system, and then working on kind of that translation, or to try to take what we hear when we talk to communities and do interviews, or look at data and think about how to structure those things efficiently so that they pipe into our shared dictionary that we've developed ahead of time. And sometimes it's not it's not super easy to do. I think there are technological approaches that can probably help where there's facilitate communication. I think those might be evolving over time to where I'm not an epidemiologist, but I could speak with Weiming right more easily if we had some sort of AI translating between us, maybe. And so things like that could probably help. But I think a lot of it is just spending a lot of time in the room and talking to folks, and making sure that you have a translator that it can kind of speak both languages and lives in both worlds. That's involved in the process. And so that's I think there's there will be interesting technological solutions in the future to that, but for now it's just good old shoe leather, boots on the ground kind of thing. So I think.
So if we need a solution, we need to speak to women.
Yeah. Can I ask a question quickly?
Yeah, please.
Thanks for your lovely presentation. I really liked the map you showed about leapfrogging. And it was really what has happened in India is that when they didn't have landlines, they started getting mobiles. And then they started using mobiles in various ways. And that absolutely, they went from where they were to a huge, a lot of people benefited it. Your absolute perception is correct that getting it from a high-income country, the same technology, it's not really viable for I'm from UK, so I think for India and Indian conditions, they need to adapt to a technology which will suit them. But the problem here is awareness and the communication. As you mentioned in your last answer, how you communicate these things, health professionals, how they sort of enlighten basically the general people that it is for their good. And once they understand, they start understanding their own health care much better in much easier terms, and then the whole health economy will move in a synchronized way. At the moment, there are some people who got everything, but there are so much health inequalities that, it's a big challenge for India and for people. So in those, yes, if there is a AI tool that comes in, which can teach all these people in their own language and they can understand things in a much simpler way, that will make a big difference.
Yeah. Well, I don't think this is a unique problem in India. I think it's a problem everywhere. I think it's even a problem in where, like in many healthcare contexts, right, where you're trying to understand, if you're a physician talking to a patient, right, you don't speak the same language, and you're trying to understand. Your job is to understand what the patient is telling you and what their preferences are. And so this is a problem that I think people have thought a lot about, and we should apply when we're thinking about the development of technology. Part of it is having the right infrastructure for doing it. So we work with a lot of great organizations in places that have really deep ties in the community and are able to they have spent decades learning about what the issues are and how the institutions work. And so that's there is a lot of existing institutional knowledge that can inform those conversations and the dictionary that you use, for sure. Another piece, kind of on a more micro level, right? One thing that we've been looking at that I'm quite excited about is developing digital tools that are efficiently, intelligently guiding interviews and are designed to kind of map, for example, patient preferences, right? And so understanding how patients may prefer one treatment or approach over another, right? But applying that more broadly is something that would be really interesting to try to explore more, because it's a general approach that I think some folks are thinking about, and employing some of these cool new tools that we have, and language models and other things, and attention systems and transfer learning and that kind of thing could be a great unlock, I think, for a lot of this work.
Thanks a lot.
Yes, sir. My question is, as we are designing digital health systems that is empowering patients, so how do we are going to prevent techno stress among the frontline providers? Like for every program, there is a new digital tool to collect the data. And as you mentioned, after some time, new set of technologies are coming.
So this is a great question. I think part of what I'm talking about is talking directly to or understanding how this enters workflows. For example, with community health workers, I think that if you design intelligently and understand what those frictions are ahead of time, there is an opportunity to improve their workflow, make their jobs easier, right? So we have developed this open source platform that based on an RCT we did over a few years in China, actually, and now it's been localized to have like English and we've made it open source. But it's essentially like the whole point of that is to make the jobs of community health workers who are doing home visits in rural areas easier, and so it like streamlines our workflow a lot, and we got a lot of feedback, and that was because we worked directly with these community health workers from the start and understood their workflow, and then went back and forth. And and this, we started this before the pandemic. And my last trip to China just before the pandemic was to Wuhan to work with them to develop the app in the initial stages. And so that was right. That was January 2020. So it was right at that time we started developing it. But it was I think there's technology can cut both ways, right? So it can increase workflow or friction, or it can improve it, right? And there is low-hanging fruit to improve it.
And I also believe this question resonates with what Dr. Rao presented. So would you like to chime in?
Dr. Rao? Yep.
Yeah. I think so. I mean, I feel, like I said, I think the potential of digital health is enormous, but it runs into health systems that are stuck in a different time. We have very fixed ways of functioning, and so forth. And often that encounter doesn't end in a better place for people, that is health workers and also and so I think on one side, I think it's very important to push for digitization, digital health, but it's also to understand how can you solve these practical problems or that you encounter when you introduce this kind of technology into a health system.
That's a great point, and not everything requires a technological solution, right? So it's sometimes easier just to write it down on paper.
Right.
Exactly. Yeah, I think it's a great point.
Yep. So there are no more questions. So I would like to thank all 4 panelists, and sincere apologies on the behalf of the organizing committee that we had to make you wait. 3 of the panelists, they are on the East Coast, so we must have made you wake up pretty early, whereas probably we are delaying the sleep time of Professor Zhang. But sincere thanks for such insightful discussion. Listening to the presentations together, I believe there are 3 big messages that I could decipher. So first, Dr. Rao reminded us that the digitization itself is not the destination. Rather, it's just a means to getting there. So while India has moved fast with ABDMs and by getting those Aadhaar IDs done, but still there are, at the front line, the reality is completely different. There are still duplicate paper plus digital record. And there are still siloed systems that don't give the facility managers a coherent picture of the performance. Yep. Then we had 2 very rich examples of what it looks like in practice for communities who are often left behind. Dr. Tang showed us how digital health can now touch the whole HIV cascade, starting from pre-exposure prophylaxis to up to the, say, telemedicine for mental health support. And also that the fascinating thing for me, and I believe this audience, is that crowdsourcing can be an important avenue, a critical avenue for an LMIC like ours to fund such initiatives. At the same time, Professor Zhang's work on Pay It Forward demonstrated that social innovation and generosity can be designed, and not only that, it can be trialed in our cities and then digitized to scale. Again, that's, what Dr. Sylvia mentioned about leapfrogging, although he mentioned it in the context of digital health adoption,
this kind of, if we manage to implement either the crowdsourcing or the paid forward model for in our context, I believe we can, India's public health scenario can actually leapfrog. And then Dr. Sylvia made it clear that AI and digital health are not just new tools, they completely change the decision-making process in health systems. His ECAM principles give us a very, very practical checklist for making sure that AI is sustainable and doesn't leave any communities behind by design. And which is, of course, one of the critical concerns that we have been hearing from different speakers since yesterday, that all these biases in AI, and it's not only a first world problem. Even in our country, AI, all these data that are getting fed into those designing those AI models, they often come from a certain so-called upper ACS populations. And how do we solve for that? That's a question that can be answered in the future. So putting all this together, the question for LMICs, or like India, is that perhaps less of what is the next big digital innovation, and more, how do we ensure that the tools that we already have are co-designed with communities, as highlighted by Dr. Sylvia, embedded in primary healthcare, and governed ethically. So if we can do that, the technologies that we have discussed today will not only remain just a tech tool, just merely a tech tool. Rather, they can become reliable, trustworthy companions for leapfrogging our health system. Thank you. With that thought, I thank the panelists again and end it here.
Thank you, Ritra. Bye-bye, everybody.
Thank you all. Thank you.
Thank you, everyone. Pleasure.
We now sincerely extend our thanks to the chair and all panelists for this forward-looking and thought-provoking discussion. This session beautifully underscored how technology can strengthen primary healthcare when designed for equity, innovation and accessibility, especially for vulnerable communities. We now request Dr. Sanchita Mahapatra to kindly felicitate Dr. Aritra Das. We extend our heartfelt thanks. We extend our heartfelt thanks to Dr. Krishna D. Rao, Dr. Weming Tang, Dr. Sean Sylvia, and Professor Zhang for joining us virtually. Thank you.
We now move to our panel discussion 3, the last panel discussion of today. This is titled as Latest Technological Development in Maternal and Child Health, a Global Perspective. I would like to invite Dr. Tanmay Mahapatra, sir, Director for Data and Learning at the Piramal Foundation and Steering Committee Chair for Research and MLE Piramal Foundation, to chair this session. Thank you so much, sir. Our first panelist for today is Dr. Suvalgana Chatterjee, who is joining us virtually. She is consultant obstetrician and urogynecologist, West Midlands, Deanery, UK. She specializes in pelvic disorders, complex urogynecology, leads advanced pelvic floor surgical services, and has been recognized with a Clinical Excellence Award for leadership in women's health. May we please have her on the screen. Next panelist for the session is Dr. Dev Kishore Gupta, who is again joining us virtually. He is the Director and Head of Medical Affairs for South Asia at Biomedics. He is a NABL and NABH accessor WHO patient safety specialist, and a postdoctoral fellow from the University of Central Florida, and has contributed significantly to strengthening quality systems in diagnostics across India. Sir, may we please have them on screen? Thank you. Sir, Tanmay sir, I now request you to please lead the session. Thank you, sir.
Thank you. Thank you all. First of all, I like to unconditionally apologize to both the panelists, Dr. Gupta and Dr. Chatterjee, for keeping you guys waiting for long. I know you could hear a very good discussion, and that was so engaging that we could actually delay you more. Now, although as the organizers decided to have Dr. Chatterjee first, which maybe Dr. Chatterjee is also thinking that she'll be good to go fast because she's waiting from last 3 hours as much as I remember. But given the fact that we are right now going to talk about from diagnosis to treatment, I would like to invite Dr. Gupta to start the discussion with your presentation. And to the audience and to our panelists, this is an institution building approach to start with a plan for having a conference where we can have a charter to come up with the next phase of work in Bihar and beyond. As the member secretary, Dr. Rashmita Gupta, mentioned that this is probably the start of a series, basically a follow-up of the previous conference. I'd request both the panelists to learn from the past to protect the future, which has almost become the tagline of this conference. Over to you, Dr. Devkishore Gupta.
Thank you. Thank you so much for the kind introduction, and thanks for this opportunity. And it's a privilege to be here. And I was listening to the previous panel discussion. A lot of insights. It's very, very enriching and really great sessions, and congratulations to the organizers for that. And thanks again for this opportunity. So I'll share my screen. Kindly let me know if this is visible. Is it visible?
Not yet. Actually, it has gone back to your screen again.
Is my screen visible? If
not yet.
Not yet?
No. Can you reshare once more?
I'll reshare, sure.
Yes.
Is it visible now?
Yes.
Full screen?
Perfect.
Well, thank you. So very briefly, I'll be talking on the advancements in AMR diagnostics, antimicrobial resistance, and which we know this is a big problem. We call it silent pandemic, and the technological innovations and the implementation barriers that we are facing, especially in LMICs, and how we can have some sustainable impact. Because innovation sounds exciting, but we must understand there are certain barriers, and we must understand those barriers very well, and how we can make it sustainable, right? So as we are talking about antimicrobial resistance, so I will just very quickly give you certain three important sepsis statistics, which are rather scary. 50 million cases per year, 11 million deaths per year, and those who survive, 50% of them also succumb to death within next 1 year. And 40% of them are kids who are less than 5 years old. I think these informations are quite scary, and often we do not have any antibiotic at all to deal with such cases, and the situation is only becoming worse. So this is the global burden of bacterial antimicrobial resistance. So this is how it evolved from 1990 through 2021 with a focus to 2050. If we do not intervene, the way it's going to affect us, and give very brief outline. So this is what it looked like in the year not do anything special, extra, some special intervention. So this is the situation in 2050 where the AMR, where the AMR related death attributable to AMR can be more than 30. So this is really scary. I think this should be really a competing factor to devote our time, energy, research, innovation, and finally application of those innovations into clinical practice, and so that we can save more patients. Because otherwise, sooner or later, we'll be challenged by a time where any infection can actually kill a person. So we know that, for every septic shock patients, every hour of delay leads to incremental mortality, 7.6% per hour. So if you are led by 3 hours, so this means around 21% or more than that, higher chance of mortality. So this is important slide, but at the same time, this also led to a lot of antibiotic usage over last many years, because we are happy to anticipate and assume that every patient lands up in the hospital as having some sepsis or septic shock. So CDC has observed that up to 50% of all antibiotics used in acute care hospitals are unnecessary or inappropriate. So this has happened rampantly in all countries, and India is definitely an exception. So now what's the solution? So definitely nobody's stopping me if you really thinking a patient landing in the critical care or emergency department with suspected sepsis or septic shock. But the new guideline is saying that if the patient is not in shock, then you have 3 months, 3 hours time. So in 3 hours time, why this 3 hours time is very crucial? So these 3 hours is a time for diagnosis. So if you have some rapid advanced diagnosis, so you can try this advanced diagnostics and try to decide if the patient is really into bacterial sepsis or if the patient really needs some broad spectrum or any antibiotic at all. So this 3 hours timeline can be really, really important, and this can actually save a lot of unnecessary, a lot of life-saving antibiotics from being given as rampantly. So I mean, this is again a very important slide, I must say. We talk about whenever we talk about antimicrobial resistance, we talk about antimicrobial stewardship. Now, how this diagnostic stewardship and antimicrobial stewardship are linked together? Because when a patient comes, in the hospital, so for the initial clinical evaluation, you decide the right test and decide on the right patient. Definitely, we do not encourage unnecessary testing, and of course, you have to do the test at the right time. So no fun doing the test or doing the right test after a couple of days or 3 days. So if these 3 criteria are met, then you are doing justice to diagnostic stewardship, then the results are available, then you decide, then based on the results, you interpret it well, you choose the right antimicrobial, and again at the right time, then basis that you treat the patient and you expect a positive outcome. So this is how diagnostic stewardship and antimicrobial stewardship are inherently linked to each other. Very quickly, I'll say that now by this time you have understood time is life, especially when we are dealing with sepsis or septic shock patients. Time is really life. Some background news. Hope I am audible clearly. I think there is some background noise.
We can hear you clearly.
Bring automation into the workflow. The idea is, again, when you talk about technological advances, when you talk about technological advances, especially automation. So this is again very important, and this is how we can really narrow down the period when diagnosis can be made. And again, for the medical doctors, you will understand, you will appreciate that generally we give some broad spectrum antibiotic. Then the culture report comes. It takes around 4 days, 5 days. So till that time, those antibiotics continue rather blindly. How we can reduce the time with the automation? So there are certain automations, there are certain tests by which you can really very quickly, for a septic or sepsis or septic shock patient, you can very quickly identify the pathogen and also identify the antimicrobial resistance gene. So again, these are certain examples wherein rather than waiting for 2 days, 3 days, within few hours you can actually come out with a diagnosis very quickly. These are technological advances which have already happened and which is available critical in our country. As I said, when you're taking a suspected sepsis test, empirical therapy is initiated. Empirical means blind. So based on the local knowledge of antibiotic resistance, you decide on the first blind antibiotic. So that's called empirical therapy. So basis that you treat the patient and wait for the results, right? But unfortunately, we have seen that 1 out of 5 empirical treatments do not cover the isolated bacteria. And 20 to 30% patients receive inappropriate therapy. So these all lead to a problem, and this negatively impacts the patient outcome. So one way of addressing this, that you treat all the patients with broad spectrum antibiotics, but that's a problem because this will lead to a lot of antimicrobial resistance, and definitely this is not going to help the patient either. On the other hand, you have to identify the positive organism very quickly. You have to identify the resistant gene, if at all it is present, very quickly, so that you can fine-tune and start the right antibiotic as early as possible. So this is empirical therapy. So when you know the pathogen identification, you know the resistant gene, so you know the susceptibility pattern, that it becomes targeted. So with the help of technological advancements, we are trying to reduce the timeline so that you can start the targeted treatment as early as possible. So this is how one example how we get to know the antimicrobial susceptibility testing directly from the positive blood culture. This is one example where you can get the results 16 hours earlier from the conventional system. Time to adopted antibiotics, so you are able to start the targeted antibiotic at least by 24 hours. So definitely you can understand all these patients are having sepsis or septic shock. So getting to know or starting the right antibiotic at least 24 hours prior can save a lot of lives. So next generation sequencing, I think this is going to be there in the future. As we are talking about future of diagnostics, I believe that next generation sequencing can be the future for us. So from the positive blood culture, yes, you can detect the organism. Can you detect the organism or the pathogen directly from the blood? Yes, we are having certain solutions, but this is yet to pass the US FDA validation, which is again very, very stringent. But we are there, but maybe in the near future from the blood, direct blood, we directly identify the pathogen and we can start the right antibiotic day 0 itself, rather than waiting for 4 days, 5 days. And again, I think that will be a sea change in the treatment for a patient, right? So these are certain examples. So this is one company which we have acquired. So I think here you will see machine learning. And so this is again, a lot of predictions happening. So based on the, identification and based on the resistance gene detection, if we can predict various other factors, and if at all, if this is possible to come up with some genomic antimicrobial susceptibility testing. So these are the future, and we are slowly but steadily moving there. But having said that, there is a word of caution. Whatever newer technologies we are bringing, that must be validated and standardized. I think that's a very important message I'd like to give to this crowd and to this audience, because everybody are experts in their field. So without having validation and standardization, this can be quite detrimental. We are talking about data. I think the previous session also we are talking about data. So we are also, in the process of helping the users generate a lot of data. But the challenge in our country, when we talk about, infection control, when we talk about antimicrobial stewardship, in our country, most of the data are retrospective. So they are not system generated, they are not automated, they are not real time. They are not some manual entries there, so it's not error proof. So end result is they are not often actionable. I think this is where we should move our future energy, and this is one example where we can actually generate real-time data when the machines talk to each other, and so there is no manual intervention required at all. So from different equipment, different instruments, dealing with human sample, you generate the data, you have a look into the data, and maker and checker, that bias is not there. So basically, this is quite neutral data, and this is some example where we are dealing with different governments, and also the government of India. We are process to discuss with them how different different machines can talk to each other, how different labs can talk to each other, and finally, how we can integrate different labs and at a country level or at a higher level from a reference center level, you can have a surveillance network developed for the country. So these kind of systems are there in different countries. We are also moving in that direction even in India. So wherein the data can be definitely patient contribution, everything will be completely protected. So that part will be taken care of. But you can have a very real-time actionable data so that you can take the actions whenever some outbreak situation happens. You don't have to wait. You don't have to look back. So things can be really, really revolutionary. Now coming to the implementation barriers. So what we see in our regular day-to-day interaction with a lot of users, different medical professionals, yes, there is still some awareness gap. So this is really harming. Collaboration between stakeholders, and this is a challenge because it's good to generate very important data, very important patient report. But if the collaboration doesn't happen from the lab to the prescriber, if the real-time communication happens to the prescriber, then basically you're defeating the purpose. We have seen infrastructure and system inequity in different parts of the country. Economics and reimbursement has been a challenge. We really need to generate more of local data. We are facing regulatory and validation bottlenecks. Supply chain challenges, often we have seen that automated technologically advanced instruments are depending on tenders. The reagent supply is pretty erratic. So the problem is you cannot bring them into the workflow. You cannot bring them into the regular practice. So that's harming. That's a serious bottleneck. Clinical behavior and culture. So again, that's very important. We talk about a lot of automated products, automated things. The problem is it really changing prescribing behavior? We are seeing this challenge that physicians are getting very advanced reports, but they're still waiting for the conventional report to come. So this is a battle that we have to fight together, and we have to really educate and reach out to the prescribers and how we can change their prescribing behavior. There's some element of behavioral issue as well. Patient level and societal factor is there, and of course the operational technical challenges in that as well. How we can have a sustainable impact? So definitely we need to have clinical, economical, and operation models to have a sustainable impact. In terms of operational models, so definitely we can have something like self-collection, and how we can make it less, how we can generate less carbon footprint by reducing the workflow and so many other things. And those things are there. We really need to generate a lot of health economic data. We need to establish that this is really helping the clinical outcome of the patient. So for a sustainable diagnostics, so there is a combination which is essentially technology plus training plus reimbursement plus integration, and it should be enforced by the policy, and there can be a role of industry partnership as well. I mean, overall, it's a value innovation. It's not exactly innovation, but it's a value innovation wherein we should be able to reduce the cost, but the buyer value should increase. So essentially, this slide is taken from the Blue Ocean book, and this value innovation can be a very good, propelling factor for long-term sustainability. As I was talking about the economic part, yes, so we need to generate this kind of data more and more. So this is something, wherein it's kind of proven that, modeling, with a modeling study, the impact and cost of culture-dependent molecular tests for antimicrobial resistance in resource limited setting. So what they have proved that molecular diagnostic implemented at just $100 per test or less would lead to healthcare system cost savings across all scenarios investigated in India and South Africa. So we really need this kind of data, and because if we have to make it sustainable, we have to prove it that this is cost effective for the patient as well, and also for the payers. So to conclude, sepsis is a major global healthcare issue. We know this, and sepsis and AMR are the two sides of the same coin. You cannot address the other without addressing one. Automation is not optional or selective. It has to be integrated into the workflow. Innovation is the way forward, but it has to be customized and standardized. So that's again very important. Access, adoption, adoption, impact, and sustainability can be a simple framework, but it's quite complex. And I'm sure in the subsequent discussion, we will discuss a lot on this. So I'll stop as of now, and over to you.
Thank you. Thank you, Dr. Gupta, for taking us through such a nice journey starting from the importance of the time to the AMR surveillance and then ending up to a scenario where we can have the cost effectiveness and the framework for sustainability. I'm pretty sure the audience is buzzing with questions, but just keeping them a bit on wait. I just don't want to make Dr. Chatterjee wait more before discussing about taking all these diagnostics into action. And Dr. Chatterjee brings in a very interesting combination of, just like Dr. Gupta, understanding from the both sides of the globe, and whether from global north or global south. So she, if I remember correctly, 32 years back started her journey in a rural medical college. So over to you, Dr. Chatterjee, from your practice in India and your practice in UK, how you are looking at technology for maternal and child health, especially for obstetricians and gynecologists. Over to you.
Thank you, Tanmay. Thank you indeed for giving me the opportunity to speak in front of this esteemed audience. And I was never bored. I was actually enjoying the whole journey since I joined. It was such an enriching discussion happening, definitely. Now, trust me, I promise I'm not going to talk about the technological development or the product of it, which is used in NHS England, because I know India very well versed about all these technological products which is coming in the market, and to the extent on the very next day they can develop or invent a much cheaper version of that and can explore the affordability and accessibility of it. So I'm not going to talk about that. I'm not going to present the slides. Instead, I have chosen a couple of topics or descriptors which are useful in describing. It's been in use in NHS for ages. However, we made some little amendments by using the advanced technological accessibility, and that has significantly improved the outcome in NHS. And I will also discuss how they are useful in a resource-constrained country. The first is the Central CTG Monitoring System. Now, the CTG stands for cardiotocography, which is a graph we record for the baby, for the unborn baby, the mothers who are laboring. We call it as a fetal monitoring tool. And this has been used in NHS for ages and ages. We quite fast, quite early detect any complications during the labor and diagnose a fetal distress, take action and deliver the baby quickly. Despite it's been used for such a long time, we still encounter babies having birth injuries, babies having brain damage, and of course, nonetheless, intrauterine death. We now have a central monitoring system where the graphs are reflected in a central monitor. It used to be on a paper, and a dedicated machine used to be there with each mother. However, we now have a central monitoring system where the graphs of the patients are reflected there. What is the advantage of using it? The nurse sitting in the center, nursing center, or the midwife sitting in the center can observe the CTG, can take actions if it is suspicious or pathological, can call the resident doctor. The resident doctor can see the graph from the room he is working from or the office he is working from, or maybe giving ward round to a different ward. And if required, they can call the consultant sitting at home to review the CTG and give the action or advise the action. This whole thing takes about maximum 5 minutes, and you can imagine how quickly the actions are taken. This has significantly improved the outcome in the NHS management. I'll come to the questions if there is anything from the audience, but I'll go through the topics I want to discuss first. The next descriptor is a portable ultrasound. It sounds funny that ultrasound is very well-established system in almost every country, and India has adopted quite a few advanced technology in imaging. We know sometimes reports coming.
Yeah, you audible. You can go ahead. Some background noise.
Okay, the ultrasound. This only requires a small probe which can be connected to the phone or a small handheld monitor. Now, this ultrasound probe has such a good resolution that the training level required for it is 0. The 0 level training is required. So a nurse can use it, a midwife can use it, a healthcare worker can use it, and nonetheless, a junior doctor who hasn't even touched the probe at all can use this machine. Why this is useful? The women come in labor and the doctors
Dr. Chatterjee, we are losing you in between.
midwives may not be able to detect the position presentation because it's very important that the mode of delivery depends on it. Okay. Yeah. So the presentation is important to frame the mode of delivery for a woman. So what used to happen before? A lady comes, there is confusion about the presentation, then find out somebody who can use the ultrasound machine, then open the room for where the ultrasound is there, and then somebody who comes, oh, actually I'm not friendly with the machine, then again find out somebody who can use the machine at par. Now we don't have to think about it. Anybody can use the probe and put it on the tummy and get the presentation sorted. It just not only see the presentation, it can detect the fetal heart rate, fetal heartbeat, placental position, and also the amniotic fluid. Obviously, for growth scans, we require a more advanced machine. So these are the usefulness of this portable ultrasound machine. The next one is the cell salvage. Cell salvage is a machine which is used during the operation. It collects the suctioned blood during the operation, purifies it, disinfects it, and transfers back to the woman. This is an amazing tool in maternity in NHS, as it has saved umpteen number of blood transfusions, especially when the high-risk patients for PPH, postpartum hemorrhage, are having operations. We managed to reduce significant number of blood transfusions in patients like complete placenta previa, ruptured uterus, or severe uterine atony. So this has caused a significant improvement in our service as well. Now, last but not the least, which I want to talk about, and many people have actually talked in terms of digitalization of healthcare, NHS is paperless now. We use electronic maternity record system. There are quite a few examples of this, like Majonet, K2, Athena, Serena, etc., etc. All the systems are in place across the country. How these systems are useful? First of all, these systems detect the risks from the beginning. There are some questionnaires. We start installing or implementing the record through the system at the beginning of starting from the first visit of the woman. That detects the risks through the questionnaires, through the tick boxes, and counts the risk factors, whether it is scoring high or low. And then we can assess the pregnancy management. We can plan it all together. All the investigations are recorded in the same system. The same system has access to the community midwives or the doctors, and the patient herself can also upload or install the app where they can be engaged in the same management in terms of reviewing the results, reviewing the outcome sheets, and also getting the oncoming appointment notifications as well. So the tracking of the patients and getting lost in the community is much less now, since we are using these electronic maternity record systems. I'm happy to answer any questions, and these are the systems which I have now reiterated can be used in resource-constrained countries. It's one-time investment, definitely, and requires least cost for the maintenance, and overall outcome is amazing.
Thank you. Thank you, Dr. Chatterjee, for taking us through all those 4 wonders which are solving a lot of problems, simple but life-saving, useful, and efficient. First of all, just before opening this to the audience, I have a few questions. First of all, to Dr. Gupta. How far are we from AMR surveillance as a country?
Yes, we have taken steps, definitely, to have progressed, especially in the private sector, yes, mostly because of the acceleration and all. There is a push. So hospitals are generating data, and those data are getting submitted. We have taken some steps from the public sector as well. So ICMR is quite keen to initiate some structured steps as to how we can generate more and more data. So we are there, but I mean, now it's a long journey has started, but we really need to generate data, and the data ideally should be real time rather than taking some 3 months time to generate the data, then it's collated, then submitted, then it loses the action. I think that's a challenge that we are facing. So it's very well understood by ICMR and also the accreditation agencies. So we have started, and hopefully we'll reach there soon. But overall, resistance, I mean, mostly we are dealing with gram-negative resistance in our country. So different hospitals are generating and submitting those data. One problem being, again, the maker and checker problem. So at times, both are same. So data validation is a problem. So I think slowly we need to find out a mechanism which is rather automated, electronic, and can be real time.
Thank you. I guess the audience pulse is that this journey is better not to be a marathon, rather than it will be good to be a 100-meter run, because a few years junior or your batchmate, Dr. Oyanavo, actually made us frightened today by saying that the next pandemic may not be far away. And who knows the issues with the microbial resistance, antimicrobial resistance that we are facing, especially in situations like tuberculosis and all others. So I think that AMR surveillance is something which is the need of the hour. We want to see all the future collaborations that we have discussed, maybe a pathfinder for all these. Now I want to turn to Dr. Chatterjee. You talked about CTG. I had a question about that. How resource intensive it is in terms of the expertise required, starting from having the instrument or whatsoever needed to be applied to the pregnant woman, till identifying the fetal distress and providing a decision support through the central monitoring system that you just mentioned.
Yeah. So obviously the CTG, the basic requirement is the training of the doctors to read the CTG, and that training is quite repeated training, because it is very common to get confused or forgetting the things which is learned if you are not facing the same type of complications repeatedly. which may not be the problem in India due to the population. However, it happens in UK. So we do keep repeating the training every year for any doctors, including the highest level of the tier, where we actually refresh our mind by getting it. It's mandatory kind of thing. Overall, on top of it, the machine itself, yes, the upfront cost is there for machine. The maintenance is minimum. It's not very high. It's a one-time buy, as far as I have information about it. The basic electricity requirement is there. Internet is not required for the CTG, but the central monitoring definitely requires the connectivity with hospital. If the consultant or anybody wants to review it from home, that requirement is there. And it requires a management protocol, definitely. Without forming a protocol, we cannot implement this service. And the funding?
Okay, so with permission from audience and you both, a little follow-up on that.
Your voice is broken, Tanmoy.
Can you hear me now?
Yes.
Hello? Yeah. So basically, a little follow-up question on that. Now, in a subjunctive mode, suppose your CTG is... okay, first of all, let me take you to a place where deliveries are not conducted or monitored by doctors, maybe by maybe by auxiliary nurse midwives, even not GNM nurses. In that kind of a situation, how do you see the prospect of having a wireless fetal monitoring device connected to your central monitoring system? Everything else, what you said, is similar.
Thank you very much for this question. This is a very useful question, and this is why the whole point that I brought it up here. Where the resources are less, and it's the initial funding we need to collect to get this sorted, and the CTG, if we have high-risk patients delivering in an area where we don't have access to the doctor straight away, hand to hand, there the monitoring system is much helpful, because this central monitoring can be connected to the nearest tertiary hospital or the secondary hospital where the doctors are available. Obviously, the doctor needs to have the training to read it. Even the nurses in that peripheral area can be trained in reading the CTGs. And making the decision available, depending on the availability of the CTG over there, is much faster. That's how we found this. Exactly the same thing happened in NHS, where we have loads very high, but we couldn't provide the number of doctors and the midwives either. The central monitoring has enabled to reach out the patient very quickly, where we had the records of delayed in taking actions, where the complication has actually happened much earlier but was not picked up. So this is, I think this will be very useful for, in such setup, which you have told now.
Thank you. Now it's open to the audience. Any question from the audience? Yeah. Can we have,
Hello, sir. My question is for Dr. Devkishore Gupta.
Yes.
I wanted to know, and I'm very curious about it, that do prescribing patterns differ by age and sex, and how does this influence AMR burden? And also, what are the targeted interventions which are needed for the high-risk age and sex groups?
Sorry, if you can just repeat your second question.
What are the targeted interventions that are needed for high-risk age and sex groups?
Okay, fine. So I think your first question, what I understood is your prescription. I think this is really a challenge. And thanks for this question, because AMR is very intricately linked to with prescription, as I said in my talk. So there is a short-term aspect that everybody wants the patient to improve, and so for that, broadest spectrum antibiotics are often given. And later on, when the results are available, I'm talking about diagnostic results, de-escalation or stoppage of antibiotic doesn't happen. So I think this is the harm, and nobody is rather restricting not to start, especially if the clinical situation is there. Somebody can definitely start based on the local situation, patient's clinical condition, but the de-escalation doesn't happen. So that's a problem for a country. So as long as the patient is in ICU, till the extent patient is discharged at home, patient is on antibiotics. So this is really putting a lot of pressure. And secondly, the overall education awareness session. So I take part in hundreds of such sessions throughout the year within the country, outside the country. But to my surprise, I will only say that in most of these antimicrobial stewardship sessions where we talk and preach, so if you look into the participants, they are actually the doctors, medical doctors who have sufficient baseline knowledge. So we are perhaps not doing enough and reaching out to the roadside doctors, MBBS doctors, who are seeing 100 patients in a day, but there is no effort to reach out there. So there has to be a concerted effort how we can train and educate those people rather than reaching out to some corporate hospitals or maybe some other accredited hospital where this is kind of KPI to have some training on AMR, AMS. So I think we really would, we need to work there. And coming to the targeted intervention, yes, definitely. See, we need to give something, some actionable report to the prescribers. So it's often easy to blame the physician or clinician that hey, you are giving broad spectrum antibiotics, but are we really giving them adequate, timely support? So this is what we really need to talk and educate the support system, that right diagnostics, right time communication, and this is often very, very useful. At times, I again talk in different areas and people often reach out. We talk about innovations and all. So generally I say yes, innovation is really good, but whatever diagnostics we are having at this moment, are we really utilizing them at the optimum level? Perhaps no. I'll talk about simple blood culture for a sepsis patient. So blood culture comes positive at midnight, but a technician comes to the lab at 9 a.m. in the morning, takes it out, then informs. So basically you're losing many, many hours and it loses value. So whatever diagnostics we are having, so we can further optimize that. So that can be a targeted intervention. Definitely we can go for some advanced automation, and wherein if we can communicate, if we change the prescription behavior accordingly, and which is affordable, accessible, we can really do great.
Thank you, sir.
Any further question from the audience? Yes, I can see two hands.
Good evening, sir. Sir, my question is regarding the over-the-counter medications. Particularly in our country, the antibiotics, many of the antibiotics come under the OTC category, and people are more often than not, they go to the pharmacy and just take the antibiotic without knowing if they really require that antibiotic. So how much it is contributing to the AMR? And my second question would be, how should we counter it?
Yeah. So as I heard, I think your first question is over-the-counter dispense, right?
Yes, sir.
Yeah. Thank you so much for these great questions. So, maybe a couple of years back, I used to raise this question in various forums. That's why you are not stopping. And theoretically, yes, you are absolutely correct. That when we dispense this kind of over-the-counter antibiotics, so even a plain antibiotic like coanoxiclav can have a lot of collateral damage and can actually induce resistance, including MRSA and all. So these are not simple antibiotics. Right? Generally, we believe something is costly, that means should be restricted. Not always. A simple antibiotics like rather relatively cheaper antibiotics like doxycycline and coanoxiclav can generate a lot of resistances. So yes, restricting antibiotics at the pharmacy level can be the best possible solution. I raised this at multiple forums at the public sector. But again, I was also pushed back at times. I understand there is a logic, because at times we see doctors are largely centralized rather tilted that, at least imagine a remote place where there is not even a quarter. So if you really do not allow the antibiotics to reach out to the patient, so perhaps that can cause more damage, or at least some damage. Some patients can really lose their life, and versus you completely restrict. So I think overall this is, we really improve the system. We really need to have the right education, and AMR awareness should be there in the formative years, during the formative years, and we should have really, sensitized doctors, even at the remote centers. Then I think we can certainly think of antibiotic restriction at the OTC level. But certain states have done it, like Kerala. So they have done it. So this is definitely the future, and we must progress in that area. And if we can really do it, we can. That's a great achievement, I believe. And this can reduce the antibiotic burden to a great extent. For sure.
I think more than that, we need to sensitize the pharmacists who are there, because they are the ones who are distributing the antibiotic like it's some kind of eclairs or something. So I think if we take into consideration the RHPs and RMPs and pharmacists, if they are trained well about the AMRs, and if they see a symptom that is a simple fever, rather than prescribing amoxicillin, they can simply prescribe PCM. So I think that would be a better option for that.
Yeah.
So, thank you, sir.
Absolutely. I can't agree more. But the issue is, again, you have to understand the healthcare model. So our model is rather different than, when the healthcare is completely supported by government. So you understand what I mean to say. So there is always some, push somewhere to prescribe more and to, give more and more antibiotics. So again, I think we need to improve as a system, as a whole. But there is definitely we cannot bypass education. And as you rightly said, educating pharmacists, talking more to them on AMR and all, I think that will really have a long way and huge impact in the future.
Thank you so much, sir. Thank you.
Thank you. I see more questions there, but unfortunately, time is the only thing that we cannot manage properly. We cannot manage many things. Time is one of the major aspects in that. So, excellent discussion, and the best discussion is known to have generated maximum questions. And I just want to conclude this particular panel by asking a question to all of us, but the answer is not required right now. It may be another imagery. Prescription audit, pharmacovigilance, these are not new words to us anymore. Nowadays, this has become quite common, and prescription and prescribing are digitized in many places, private sector also, in certain government sector also. Now, when we can think of a scenario when all this prescription audit ultimately generating a big data, which is helping AI to kind of predict the next antimicrobial resistance pattern which can come up. With this particular idea that that's how the big data can be used, and this is a point for both Dr. Gupta and Dr. Chatterjee, because it's not about only antimicrobial resistance, it's about the pharmacotherapy. So about the pharmacotherapy, about the prescription habit, can we use the data in a way so that we can ultimately end up in policy making based on inappropriate prescriptions? With that, I want to thank you, Dr. Gupta and Dr. Chatterjee, and I guess it's the start of many such discussions. Thank you. With that, we conclude this panel, and over to
Thank you, Dr.
Thank you.
Well, thank you. Thanks to the organizers.
And heartfelt thanks to the chair, Dr. Tanmay Mahapatra sir, and our panelists, Dr. Sivalgana Chatterjee and Dr. Dev Kishore Gupta, for this wonderful session. This session highlights how technology can transform maternal and child health when grounded in evidence, affordability, accessibility, context. Also, to fight AMR, there is a strong need of behavior change communication for our community in a country like ours. Now, I would request Tanmay sir to please co-chair this last session of the day, that is paper presentation. We have 3 in-house paper presentation. I would also invite Dr. Aritra Das sir to co-chair the session with Tanmay Mahapatra sir. Sir, may we please have you on the dais. Dr. Aritra Das sir, may we please have you on the dais. I kindly request you to join us on the dais. I would like to invite our first paper presenter, Aman Abhilash. He will be presenting his paper, Mapping Affordability, a System for Generic Medicine Access. Aman, please. You will get hardly 10 minutes to discuss your paper.
So, hello everyone, good evening. It's been a long day, so just bear with me for a few minutes. So, this is a prospective study that I have made upon reviewing the secondary data. It's a kind of a prospective policy document. So, its name is Mapping Affordability. Can I have a handheld mic, please? Mapping affordability, a smart system for Janaushadhi access. So in that, I would be bridging technology operations and equity in medicine access. It's a prospective solution for generic mapping, real-time inventory, and GIS to make medicines affordable and local. So the background is that 90% of the Indians annually face catastrophic health expenditure which exceeds 10% of their household income. Followed by that, the out-of-pocket expenditure constitutes 47.1% of the total health spending that we spend in an entire year. Suppose that the medicines that we buy represent 50% of the out-of-pocket expenditure, the single largest driver of the catastrophic health expenditure. And since India is in a very unique stage of the epidemiology, we are stuck between the second and the third phase. So we have the burden of communicable diseases. But with the rapid urbanization, the non-communicable disease burden will rise. And since non-communicable disease require an extensive medications, so the cost of medication will also rise. So for that solution, the NCD-related medication cost escalated from 31.6% to 47.3%. This is the 2004 data. Obviously, this would have gone much higher. So the consequences is that the household poverty line crossing has increased, and there is a medication delay and non-adherence to the treatment because of the high cost of the medicines. The rationale of my study is that India is known as the pharmacy of the world. 20% of the global generics and 40% of the US generic supply is done by India. But yet, market preference is for the branded medicine, not because of the quality deficit, but for the affordability, availability crisis. For the current scenario, if I give you an example, the branded medicine command price premium of 50 to 90%. For an example, if a branded antihistamine is around 31 rupees per strip, the same at Janaushadhi is 6 rupees, a 5-fold price difference. So if we look at the data, the market gap which is there, Janaushadhi exponential growth was around 122.9% annually, but still it represented only 0.9% of the domestic pharmaceutical market. So despite having the affordable medicines, they are not able to capture the market. There is a critical gap. There is a no integrated system which bridges the patient branded medicine prescription with real-time Jan Aushadhi availability and geographic access. These are my literature review. So, these are the major literature review that I have done. The medicines are the dominant driver of the catastrophic health expenditure in India. There has been evidence that Jan Aushadhi demonstrated and substantial affordability gains. India's digital health structure, ABDM, and National Digital Health Blueprint provides a ready standard-based backbone for the integration of Jan Aushadhi medicine. And the public health sector supply chain research highlights of chronic weakness such as fragmented procurement and weak inventory visibility. So there is no integrated system research linking branded prescription to real-time Jan Aushadhi availability. My aim would be to design a smart medicine affordability system integrated with drug matching, real-time inventory management, and geospatial analysis to enhance Jan Aushadhi access while reducing patient out-of-pocket expenditure and optimizing generic pharmaceutical supply chain. My objective would be to develop an API, thereafter map all the Jan Aushadhi outlets geospatially and calculate the accessibility metrics, design a user-centric interface, and implement a real-time inventory management. This is a retrospective secondary data analysis, and it's a descriptive analytical health system study. For quantitative data sets, I got from the PM-BJP Jan Aushadhi sales volume, outlet counts, and state-wise performance, the government open data portals on pharmaceutical markets and medicine pricing, policy and regulatory documents related to generics. The cleaning of data was done by the fiscal year, and the descriptive indicators such as growth rates and market share was taken out. So the structured literature review with thematic coding was done for generic medicines and affordability, inventory and supply chain, GIS and special accessibility. So the expected outcome after this would be is that we have to identify gaps at the systemic level and the individual level for the Jan Aushadhi Kendra. Like Jan Aushadhi Kendra ke jo owner hain, what are the issues they are facing? Why are they not keeping extensive list of medicines? Thereafter that, we have to map the entire Jan Aushadhi Kendra with an accuracy of 20 meters. That would be done manually, just as Adri is doing the private health sector mapping. Then there would be a centralized inventory database for Jan Aushadhi Kendra with having a real-time open or closed status. So we would be designing a dynamic database for branded medicine with Jan Aushadhi alternatives. We would be including only those branded medicine who have a Jan Aushadhi alternatives into that. Post-intervention, we would be designing a UI that integrates both the database with the government hospital pharmacies. Initially, if you visit a hospital, if you go to an OPD, the OPD consultation is free. But the medicines which they prescribe, some of the medicines are available in the government hospital pharmacies, some are not. So the pharmacist will have the access to these database. It would enter the name of the branded medicine into his system. Into that system, the Jan Aushadhi drug code would be displayed. Along with that, since the inventory is a centralized database, with that database, it would analyze that what is the closest proximity of Jan Aushadhi Kendra in which I will send this person to, and he will get his entire medicines. Because in the hospitals, patients go to the Jan Aushadhi store. They know about the Jan Aushadhi store, but they go there, they have a prescription of 5 medicines, but they get only 1 medicine. They don't know how to get other medicines mentioned in the prescription, so they buy the branded medicine. With this system, that would be initially be available to the government pharmacist. It would then be made an API which the common people can be used. After that, with inventory uptake data, we would be able to predict the production according to the demands variable. Like the variables could be a season. Variables could be like in the urban areas there would be more non-communicable disease, so the sale of sale of anti-diabetic drugs, anti-hypertension drugs would be high. In the rural areas, if there is a communicable disease outbreak, we have seen multiple multiple data related to it. So it can predict production according to the demand variable. So we will have a less, inventory that goes into waste. So it would lead to low out-of-pocket expenditure among the people. There would be increased knowledge and awareness of Jan Aushadhi Kendra because people would be using it. And with low catastrophic health expenditure, there would be more family savings, a higher treatment uptake and adherence to the treatment, and there would be a low burden of disease due to the low mortality because there would be a higher adherence to the treatment. This model can be replicated in the other LMICs because all the lower middle income countries are in the same epidemiological stages as in India. They have the same fiscal condition. And if they replicate this model in other LMICs, then they can India can decrease the trade deficit. So it's a prospective policy that requires government intervention on a large scale. I was working on it, but the data set was so large, it had around 50,000 rows for branded medicine. So I was not able to, join the data, but that's what it is. So these are my references. Thank you.
Interesting presentation. I believe there are quite a few assumptions that you haven't discussed. For example, and initially probably there is this, I have been using a different definition of catastrophic health expenditure as per WHO definition, and that's not 10%, that's actually 40% of the capacity to pay. And for that, it's not the whatever data that we have from NSSO for catastrophic health expenditure, medicines are not the chief contributor. Rather, because it's a catastrophic event, mostly it's the other costs pertaining to inpatient admission. But again, let's keep that aside because that's not your topic. Getting here, there are a few assumptions, as I was saying. The initial set of literature that you showed pertaining to Jan Aushadhi, none of them speak about the quality of the medicines dispensed via Jan Aushadhi platform. As you said, India is definitely the pharmacy of the world. But pharmacy of the world, the generic drugs that are sold internationally or even USA, those are actually manufactured or produced by the so-called big pharma in the Indian context, not the global big pharma, it's the Indian big pharma. And they do meet certain quality standards, whereas Jan Aushadhi, a very, very small contribution actually comes from this big pharma's generic arm. So that's one. So there's this quality concern. Next is, as you said, there's this huge list of brand names for drugs. What we haven't been able to implement successfully is that the physicians, whether it's in the public sector or in private sector, they would be writing the generic name rather than the brand name of medication. So your API may fail if it doesn't include, and there are so many variations in spelling. It's only the pharmacist. Even I cannot decipher what other doctors have prescribed. It's only the pharmacists, they are a better judge of whatever may be the medicines, given that because they know the doctor. So that can be one of the constraints for your API. And finally, it's one thing is quality, the other thing is the trust. Your assumption is that if the CHE reduces, the adherence to medications would increase. But what if Jan Aushadhi medications, they don't carry the same amount of trust as for the medicines produced by the so-called big pharma? Then again, the model may fail. Again, I'm not criticizing it, I'm just noting down some of those assumptions or the critical propensity that can make your application API fail. Next.
Fag end of the day, invited us, gave us memento. The lunch was good. Not going to criticize at all. Whatever has been told, for the next presentation being better. Content-wise,
he has spoken a lot. I would actually recommend when you have a literature review, it is always good to come up with either a framework or some pictorial, like how the articles were chosen, what was the methodology of those, or don't show literature review, talk about background literature, talk about rationally. Dropping from up, going from down, these animations don't work in scientific presentation. Appearance is okay. Color, etc. ये भी देख लेने का जरूरत है. Number of words in a particular slide, all those are important. Especially when at the end you are showing your expected outcome, it is good to provide some contextual references, which you have probably in your next slide, the end slide, where you have your bibliography, but it will be good to actually give those supporting citations, at least in the footnote, why you are believing from A, B is expected, to C is expected, to D is expected. Some of the assumptions may be questioned through those citations. Thank you.
Sir. Thank you so much, sir.
So with this, we are going to have the next presentation, next paper by Dr. Rachna Misra.
Thank you so much, sir. So, title of my paper is Assessment of Epidemic Readiness of A&M to Support the IDSP program in Bihar. This is a GIS-based cross-sectional study. Next slide. Now the question comes, why this study? So, A&M plays major role in IDSP program. So, to strengthen the epidemic preparedness, it is very important for us to understand the knowledge gaps, the operational readiness, as well as the spatial distribution challenges that they are facing. So, we did some literature review, and through our literature review, we came to know about there were many studies that was conducted, which shows that there is insufficient training, high workload, and lack of supportive supervision among the ANMs. But there are very few studies that shows how geographic accessibility, residence location, travel time, and population density affects the surveillance performance. So what exactly this study brings? This study integrates the statistical analysis with the GIS mapping to generate the spatially informed insight so that can guide us better, and ANMs can collect information about the cases with more efficiency. Next slide, please. So now comes to study objective. So study objective is to assess the ANM's preparedness, knowledge, and operational readiness related to reporting of communicable diseases under the IDSP program across the 3 districts. Later we are going to discuss which 3 districts we have selected. Secondly, to identify key gaps in knowledge, reporting procedure, outbreak identification, and referral decision making that may hinder the surveillance. And definitely we are going to use the GIS techniques to map ANM distribution, residence location, travel routes, and the population density that they are serving. Next slide, please. So for this, we selected 3 districts, Begusarai, Darbhanga, and Bhojpur. So now question comes, how we selected these 3 districts. First, we divided 38 districts on the basis of infectious disease surveillance quality index into 3 components: good performing,
average performing, and the poor performing. So out of these three categories, we randomly selected one district from each category. So from good performing district, we selected Begusarai. From average performing district, we selected Darbhanga. And from the poor performing district, we selected the Bhojpur. So for the IDSQI, we took the data from the weekly IDSP reporting performance from the July 2017 to 2018. Next slide, please. So from these three districts, we collected information from 240 ANMs from 240 sub-centers, 80 per district. Now question comes, why 240 sub-center? We collected sample size assuming the completeness will improve from 40 to 80% with 80% power and the 95% confidence interval. To collect the data, we constructed a structured digital tool which was administered in the local language and collected socio-demographic detail, IDSP-specific knowledge, awareness of the syndrome, reporting practice, and the outbreak response capacity. So ethical considerations were taken care of. Thank you. Next slide. So now comes the result. Now comes the result. If we look at the age and job distribution among the respondents, so the mean age was similar across all the three districts, good performing, average performing, and the poor performing. But when we look at the job duration, then we can see the mean number of months were more in Bhojpur as compared to the Begusarai and the Darbhanga. If we talk about the employment contract, then most of them were permanent staff, but it was more in Begusarai. And when we talk about the formal training, majority of them did not receive formal training on the IDSP in the last 1 year. So, next slide. So, if we talk about whether they were living in the same catchment area or not, so most of them were not living in the same catchment area and they were traveling by public transport. And their overall knowledge regarding the syndromes that were captured under IDSP was good in Begusarai, and it was 0 in Darbhanga, and it was very less in Bhojpur. So in total, only 31% ANM were having good overall knowledge regarding syndromes that were captured under the IDSP. If we talk about the conditions that need for referral, their overall knowledge was only, in total, only 24% of the ANM knew about overall knowledge regarding the conditions that need referral. Next. So overall operational readiness related to job responsibilities, only 22.41% of the ANM were overall ready to practicing what exactly need to be done in according to the IDSP program. Like they were submitting actually when the data was collected, it was on the paper mode. So they were submitted the S form on time. So these were the questions in the practice part. Next slide. So we also did the regression analysis. This regression analysis shows age has a direct relationship with the overall knowledge. We can see the positive association with age and knowledge. Like if older ANMs are having better knowledge as compared to the younger ANMs. Next. If we are, this is the association between the operational readiness and overall practice and the overall knowledge. So for this, we can see if we compare, reference is the poor. So in this we can say having a good knowledge or having an average knowledge makes A&M to make 3.81 times to be better performing, like overall practice is better as compared to the poor knowledge among the A&Ms. Did I make sense? I'll explain it again. So if we look at the overall knowledge and the overall practice, so we can see, so for this reference is poor. So when we are going to look at this, so average A&Ms having average knowledge is having 3.81 times better performing overall practice as compared to the A&Ms having poor knowledge. Next slide. So if we look at the distribution of the A&M across Bihar, Darbhanga and Bhojpur district, the larger the size, the number of A&M is more in that districts. The smaller the size, the number of A&M is less. So we can see in Begusarai, distribution is even. Even the darker shade represent the more population and lighter shade represent the less population. So if we can see in the Begusarai part, so in the darker population there are number of A&M is more. In Darbhanga district, we can see as compared to the Darbhanga and the Bhojpur districts. So in Darbhanga district it is not evenly distributed. In Bhojpur district we can see even the number of population is less, the number of A&Ms are more. Next slide. So the discussion point, although the 98% of A&M were aware of IDSP, there were substantial deficits were noted in comprehensive knowledge, including the reporting format, number of form and the syndrome. Sir, I could not share all the data. So through our data we also get to know that 98% of the A&M were aware of the IDSP. There was positive association between the age and the IDSP knowledge was found, and the regression analysis demonstrate A&M with IDSP having A&Ms with a higher IDSP knowledge were far more operationally ready, and the GIS mapping showed that Begusarai is well covered with the A&Ms, but Darbhanga and Bhojpur lacking the A&Ms in high population areas. Next. Limitations of the study are, study of design, cross-sectional study, and then the self-reported information on an outbreak response may be influenced by social desirability bias, and the GIS analysis was only observational, but methodology is robust. So, next. Next. So way forward from this is, as we saw that majority of the A&Ms were living out of their catchment areas, so we can encourage A&Ms to be near to their or be within their catchment areas, and we have to prioritize equitable deployment of the A&M according to the population they are serving, and we have to enhance the supportive supervision and structured feedback mechanism. Thank you, sir. Thank you, everyone.
So, is the presentation still open? It's okay. I remember. See, I don't have a pen, so I could take a note. So, in one of the slides, you showed that 82% of the A&Ms actually reside in their catchment areas, and the next pie chart showed that still 62% of them use public transport. Okay, anyways, so we can discuss that. Then in the conclusion slide, say one issue that I noticed is that the GIS mapping exercise that you have done, see, the ANMs are mapped to health subcenters. So it's not that there is inequitable distribution of the ANMs. Rather, it's how the health subcenters have been created. So you know in Bihar, there are approximately 8,800 based on last data, if we exclude the APHCs, health subcenters. And Bihar's population is, as per the current estimates, it's 140 million, 14 crores. So if the HSC, as you can see, the HSCs are not as per the population or IPHS standard. So of course there will be inequities in distribution of ANMs because ANMs have to be mapped as per the guidelines to an HSC. So it will be a wrong inference if we say that the ANMs are inequitably distributed, or even your way forward, say when you were saying that there should be, the ANMs should follow the population norms, or ANMs can be given some incentive to reside in the catchment area. So these would fail unless we create that many HSCs. I don't know about the HSC mapping because I don't have that detailed data, say, to compare between Begusarai, Darbhanga, and Bhojpur. But it has to be, say, what your GIS plotting shows, those would be the areas that have, say, more health subcenters compared to rest of the areas where you see more sort of scattered presence of ANMs. So that's one. Then in the next level, I see that you have created those operational readiness as well as the knowledge, say it's poor, average, good. These two are based on, say, the initial quality, IDSP quality index that you showed. That's kind of the garbage in, garbage out. And why I'm saying that, because those are based on what should be the ideal number of cases of particular syndromes or patients with particular syndromes that are getting reported. And that expected number is created on the basis of population. If there are sporadic outbreaks, as we know, geographically never, an outbreak is never ever homogeneously distributed. So say in, I don't know, the best performing one was Begusarai. So if Begusarai reports higher number, then in IDSP quality index, it would rank higher up. But it could also be because Begusarai is actually getting higher number of cases of the IDSP reported diseases. It's not that we cannot really say that Darbhanga is performing poorly. I mean, in anyways, throughout IDSP, there is suboptimal reporting. But if Begusarai is reporting higher number of cases, one thing, of course, one inference could be Begusarai's reporting system is better. It performs better in terms of IDSP quality. But the other possibility could be Begusarai is probably actually getting higher number of cases. So if we are categorizing the ANM's performance based on that, then we may have some biases. Again, it's very difficult to comment on because we don't have rich data on IDSP. Had we had that, of course, there would be, you wouldn't have done this analysis. And the other thing that this age, so when we are referring to age and experience, number of years, so these are correlated variables. One can expect that like the ANMs with higher experience are likely to be older. So whether, again, the association that you have shown with age, whether age is a better predictor or the number of years of experience, that we should figure out. I mean, that can be one of your limitations that you could have discussed.
Yeah, plenty of things needed to be taken offline given the time. One point I just want to build on what he said. It's important to define the quality parameter, because if I think the IDSP quality parameter that you have used, it is probably not dependent on exactly number of reporting. It's actually out of how many supposed to report, how many reporting. And if they are supposed to report, how many consistently reporting. So those are the quality parameters are probably differently developed. So those are needed to be explained. And regarding 3.81 times better, 3.81 times is okay. If you say better, there will be a confusion. And regarding 1.02 for average, when good is not showing statistically significant association, age is showing a positive association is little bit overclaim. Better is there was the average knowledge was seen more among aged, although the association was not strong, something like this, and then checking others whether it is age or year of experience and others. Okay, and those animations may be our personal, but this is what we have been taught. I must say, very good presentation and very good work. Yeah, you know, for some reason I know this, so ultimately I know, but that is needed to be mentioned. Yeah, thank you.
That's why I mentioned that it really be because aging sterile is higher number of patients, but the number field load is actually higher. All of these will be rather than just having it as a quality parameter, because nobody says what is the actual burden in patient.
Thank you, sir.
So just to ensure that we have papers finished, we are going to have the last presenter, Anmol Rai.
Thank you, sir. So, firstly, I want to especially thank Dr. Arpan sir and my team that they helped me for this paper. We, as a team, did this. My topic is assessing flood exposure and accessibility losses in Bihar's healthcare infrastructure through remote sensing and spatial analysis. Next slide, please. So, as we know, Bihar rivers are unstable due to Himalayan system, which causes sudden courses of changes in river, which further causes repeated monsoon flooding. And flood leads to waterlogging of health facilities, which further block access to roads, which in the end causes service disruptions and greater dependence on the informal care providers. From the literature review, we know that primary level public facilities are often built on low-lying land, making them repeatedly affected by floods. And what is special in this study, no previous study has combined satellite-based SAR flood maps with a complete statewide database of health facilities. Next slide, please. So, what is SAR? SAR is basically synthetic aperture radar. इसको सिंपल भाषा में ऐसे समझ सकते हैं, इट इज़ अ सुपर पावर कैमरा जिसमें क्लाउड हो, रात हो, दिन हो, उससे कोई फर्क नहीं पड़ता है. इट टेक्स क्लियर पिक्चर ऑफ द अर्थ. And we have linked flood hazard maps with facility locations, which helped us to make evidence-based site selection, which enables a shift from reactive disaster response to climate-resilient health planning using spatial intelligence. This paper addressed critical policy gaps in Bihar's health system, where exposure is structural, not episodic. Like बिहार में कुछ डिस्ट्रिक्ट्स ऐसे हैं जहाँ पे फ्लड आती ही है, ऐसा नहीं है कि एक साल आई दूसरे साल नहीं आई. इट इज स्ट्रक्चरल एवरी ईयर. नेक्स्ट स्लाइड प्लीज. हमने जो लिटरेचर रिव्यू किया उससे ये पता चला कि जो LMICs में प्राइमरी केयर फैसिलिटीज़ हैं दे आर डिसप्रपोर्शनेटली वल्नरेबल टू फ्लड्स क्योंकि वो लो एलिवेटेड लैंड्स पे हैं। बिहार में कोसी, बागमती एंड महानंदा बेसिन्स हैं जो कि नॉर्थ और नॉर्थ ईस्टर्न बिहार के जो डिस्ट्रिक्ट्स हैं उनको बहुत अफेक्ट करते हैं फ्लड से। और फ्लड की वजह से बहुत सारे सोशल फैक्टर्स भी हैं जैसे कि जेंडर, कास्ट और ज्योग्राफिक लोकेशन भी, ज्योग्राफिक आइसोलेशन भी फर्दर रेस्ट्रिक्ट करती है एक्सेस को। जैसे कि अगर एक प्रेग्नेंट वुमन है उसको अगर फ्लड नहीं है उस टाइम पे कितना टाइम लग रहा है एक फैसिलिटी को रीच करने में, और जब फ्लड है उस एरिया में तब कितना टाइम लग रहा है फैसिलिटी रीच करने में। उसके बाद इट इज़ वैलिडेटेड फॉर रियल टाइम हाई प्रिसीजन डिटेक्शन बट इट इज़ रेयरली यूज्ड इन हेल्थ सिस्टम प्लानिंग। नेक्स्ट स्लाइड प्लीज। तो ये हमने कैसे किया, हमने सेंटिनल-1 से इमेज कैप्चर किया जिसका हमने प्री प्रोसेसिंग किया बाय आवर एक्सपर्ट RGIS मेंबर। उसके बाद हमने जो हेल्थ केयर फैसिलिटी डेटा लिया वो जियो कोडेड थे। देयर वर 22,057 जियो कोडेड फैसिलिटीज़। और जो हमने सेंटिनल-1 डेटा से इमेज लिए थी फ्लड लेयर क्रिएशन किया था, इन दोनों को इंटीग्रेट किया, स्पेशली इंटीग्रेट किया, जिसके बाद हमने एक्सपोजर एनालिसिस एंड मैपिंग की, जिसके बाद आगे हम फर्दर कोई पॉलिसी रिकमेंडेशन कर पाएंगे। नेक्स्ट स्लाइड प्लीज। तो व्हाट वी फाउंड इन आवर स्टडी कि जो बिहार में नॉर्दर्न और नॉर्थ ईस्टर्न डिस्ट्रिक्ट्स हैं जो कि कोसी, बागमती और महानंदा बेसिन्स पे बेस्ड हैं, वहाँ पे लार्जेस्ट कंटिन्यूअस फ्लड मतलब आते ही रहते थे, हर साल आते हैं। और सेंट्रल डिस्ट्रिक्ट्स जो है सेंट्रली लोकेटेड, वहाँ पे मॉडरेट हैजार्ड था, लेकिन वहाँ पे फैसिलिटी की क्लस्टरिंग ज़्यादा होने की वजह से दे आर हायर एट रिस्क। वाइल सदर्न बिहार जो है वो लार्जली फ्लड इंसुलेटेड हैं क्योंकि वो हायर एलिवेशन पे बेस्ड हैं एज कम्पेयर टू नॉर्थर्न एंड नॉर्थ ईस्टर्न डिस्ट्रिक्ट्स ऑफ बिहार। वाइल पटना स्पेशल अटेंशन करता है क्योंकि वो ऑल्दो मॉडरेट हैजार्ड में आता है बट ड्यू टू हायर डेंसिटी ऑफ फैसिलिटी उसको माइल्ड हैजार्ड से मेजर एक्सपोजर की तरफ शिफ्ट करता है। नेक्स्ट स्लाइड प्लीज। दिस मैप शोज क्लियर डिपिक्शन जो स्लाइड में डिस्कस किया कि जो नॉर्थ और नॉर्थ ईस्टर्न डिस्ट्रिक्ट्स ऑफ बिहार हैं जो कि डार्कर शेड में हैं, दे आर मेजर फ्लड प्रोन एरियाज। वाइल जो नीचे के साउदर्न के लाइट कलर के जो मैप में दिख रहे हैं दे आर लो। नेक्स्ट स्लाइड प्लीज। अब जो हमने 22,057 फैसिलिटीज़ की मैपिंग की थी उसमें ओवर 4,200 हेल्थ सब सेंटर्स वर रिपीटेडली एक्सपोज टू फ्लड। PHC और CHC में भी यही पैटर्न था जिसकी वजह से रेफरल पाथवे डिसरप्ट होता था। मोर देन 2,500 प्राइवेट फार्मेसीज और लैब्स इससे एक्सपोज थे। और जो फ्लड का इम्पैक्ट था इट वॉज स्ट्रॉन्गेस्ट एज हेल्थ सब सेंटर। नेक्स्ट स्लाइड प्लीज। जो ये इमेज है, ये ग्राफ्स हैं। जो फर्स्ट है वो ये दिखाता है कि जो फैसिलिटीज़ हैं, ऑल्दो आई एम नॉट अ QGIS एक्सपर्ट बट एज पर माई अंडरस्टैंडिंग लो बैक स्कैटर मीन्स कि जो जितना ज़्यादा लो बैक स्कैटर होगा वो उतना फ्लड प्रोन होगा। तो इसमें हम देख सकते हैं सेकेंड ग्राफ शोज कि फ्लड एक्सपोजर वॉज हाईएस्ट इन हेल्थ सब सेंटर्स एंड फार्मेसीज। जो लाइटर शेड में है वो बता रहा है कि टोटल नंबर ऑफ हेल्थ केयर फैसिलिटीज कितने हैं, जो डार्कर शेड में बता रहा है वो बताता है कि फ्लड एक्सपोज्ड कितने हैं उनमें से। थर्ड वन इज डिपिक्टिंग कि जो डिस्ट्रिक्ट हॉस्पिटल्स और लैब्स हैं उनका वो ज़्यादा फ्लडेड रहते हैं जब फ्लड आता है वहाँ पे। वाइल द लास्ट सोर्स की जो फ्लड इंटेंसिटी है इट वॉज हाईएस्ट एट हेल्थ सब सेंटर्स। नेक्स्ट स्लाइड प्लीज। अब पॉलिसी रिकमेंडेशंस क्या हैं? Using SAR based screening before building new facilities and prioritize retrofitting। retrofitting मतलब कि उनको अपग्रेड करते रहना टाइम के साथ टेक्नोलॉजी से for health sub centers, PHCs and district hospitals in high risk areas। Implementing hospital safety index in all major and public private hospitals to access structural, non-structural and functional safety। making disaster risk reduction as a part of routine health governance, and finally, using geospatial intelligence in annual planning through routine SAR monitoring. Next slide, please. वे फॉरवर्ड इस फ्यूचर में हम इससे क्या कर सकते हैं? हमें फ्लड को ऑब्जर्व करना होगा, फ्लड प्रोन एरियाज और वहाँ पे जो फैसिलिटीज़ हैं अक्रॉस द मल्टीपल ईयर्स, जैसा कि हमने डिस्कस किया, मॉडल ट्रैवल टाइम इन डिफरेंट सीजन्स, कि बारिश में कितना टाइम लगता है, गर्मी में कितना टाइम लगता है, ठंडी में कितना टाइम लगता है, एंड फर्दर विच कैन बी रिकमेंडेड टू द पॉलिसी मेकर्स. द लिमिटेशन ऑफ आवर स्टडीज कि हमने बस पोस्ट मॉनसून एक सिंगल स्नैपशॉट लिया है, लेकिन वो उससे हमें क्लियर पिक्चर नहीं पता चलेगी. जब हमें किसी चीज़ की क्लियर पिक्चर जाननी है, उसको हमें रिपीटेडली ईयर टू ईयर और हर सीजन में उसको ट्रैक करना होगा. फिर वी विल बी इन अ बेटर प्लेस टू गेट द रियल पिक्चर. लास्ट स्लाइड प्लीज.
Thank you. So your presentation seemed everything about exposure. Exposure, by that I mean, okay, there is flood, which is a known natural calamity. But where is the effect of that? I mean, of course, as you have said in those initial qualitative remarks, that we expect the floods to cause displacement, and there are data pertinent to it. But does flood actually increase the caseload or delivery load? Say, for example, if we take this simple parameter, delivery load, which is available from HMIS, does it increase in the adjacent block, which is not flooded, in the adjacent district, which is not flooded? I could see any data pertaining to that. When we are, say, recommending some sort of policy decision, then, I mean, we really need to come up with hard data that because of flood, this is happening, and that's why the policymakers should intervene. Also, say in your, say this recommendation slide or in the last slide, there was this, there was no mention of, say, travel time or anything. Does it increase during flood time? Again, what would the policymakers do? Is the people, the population continues to remain in the flood basins. They are not moving away despite facing floods every year, almost every year or every alternate year. So the facility has to be there. The facility cannot be uprooted and put in some other areas where there is no flood. So you have to come up with some sort of practical or pragmatic policy decisions rather than simply suggesting that the policymakers should take note of it.
Sir, just one point I want to mention कि इससे we are not saying कि we have to move वहाँ से लोगों को हटाना है, but we have to make climate resilient infrastructure. जो कि कैसे भी adverse situation आए, they are ready to provide services. उससे किसी चीज़ में disruption ना हो.
I agree. I mean, that's what I'm saying. But see, the health facility may be made climate resilient. I'm not denying that. But the people who are living in that area, in that block, in that district, they will be getting displaced. Where will they get accommodated? Even if the facility stands, maybe facility can be made on a, say, it can be made, say, five-story tall, so that the bottom floors may be exploded. But the people will be getting displaced because of flood. So even if the facility is there and that is climate resilient, they still may not be able to access that service. And anyways, the data has to be there to support that people are actually not availing that service. And the other thing is, say in one of those bar charts I saw, right after health sub-centers, it's actually the laboratories that were most affected. I could understand what do you mean by laboratories, because laboratories are within public health facilities. They are not isolated institutes. I mean, some sort of hospitals mostly. I mean, these are, the rest are simply collection centers.
So actually, जो हमारे डेटा में है वो पब्लिक वो मिक्स है, पब्लिक और प्राइवेट का भी. तो जो नॉर्थ और नॉर्थ ईस्टर्न डिस्ट्रिक्ट्स में लैब्स हैं, they are mostly affected by the flood.
But
It's a mix
these
of
have to be the private labs only then, because public labs तो कभी भी अलग से नहीं होता है. I believe you also haven't seen, because they are always part of that hospital, right? तो और लास्ट है कि कटिहार को आपने बोला one of the most affected, but only Purnia and what is that other one? उन लोग ही हाँ उन लोगों का ही सबसे खराब में था. The color scheme for Katihar was lighter. Katihar was
was comparatively lighter. हमने इसको क्वांटाइल में डिस्ट्रीब्यूट
हाँ मैंने देखा, but it's just that like only those two are the worst of the not Katihar.
Actually, I want to build on what Dr. Aritra said. I think we are very interested in this data, in this particular research. And not only stopping at exposure, actually you have data about what services available in which facilities. Again, eventually I know what data you have actually geocoded. So the point is, as you know what services were available in those facilities, it will be very interesting to actually identify and predict based on the geospatial analysis and maybe spatiotemporal also, if you have data from seasonal aspects, that what kind of service will be affected in which particular area because of flood and other aspects. And then there may be a bearing on this on what kind of, and another aspect, the flood affected areas will have people displaced. Now where are the people getting displaced? Those facilities are going to have more burden for that period of time. And you already have what services available, not available, etc. These will be good to actually cluster and contrast. On the other hand, this discussion happened before with some of the team members, that I know from the IDSP viewpoint, you always have facilities, laboratory, and everything put together because you actually report, it's from the IDSP reporting. But it is very important that whenever IPD and OPD services are being called in this kind of analysis, from the graph, keeping laboratories and pharmacy separate. It is my personal opinion that it will be to opinion. And then talk about laboratories separately, pharmacy separately. Then you won't face that issue that whether it is inside or outside. And the last thing is, I guess, when you are having this geospatial and kind of analysis, giving some buffer, giving that kind of some graphs also look good in the presentation. I always spoke something about the aesthetics because that matters. Thank you. Excellent work.
Sir, I have a few things to say actually. So this study that Anmol presented, this is part of a larger study. We are actually trying to do risk assessment, climate risk assessment through spatial indicators only at this moment. But what Aritra sir and you suggested, these are actually great suggestions, sir. Sir, I completely respect that, and I think, sir, we have like more collaboration opportunity, and we can work together on this. This I believe completely, sir. And I think Sudhakar ji was also talking about Kayakalp program. For infrastructural thing, they are doing like field-based field-based study only. But if we integrate spatial planning and if you try to integrate machine learning also, maybe we will be able to reach to more and more facilities. Maybe we'll analyze more and more facilities where these things are needed: training, testing, validation. So these three things are integral part of machine learning. So I think, sir, this has a great collaboration opportunity, and there is a lot to learn from your expertise, especially Aritra sir and Tanmay sir. So that I wanted to tell actually.
I think these discussions are really required because, frankly speaking, as I mentioned today, we are going into the Bihar health system transformation program optimization. That's the name of the current program that we are in. So for optimization of a state health system transformation, these next level analysis and decision making are important. But one more collaboration I must mention, which is little distraction for this, but ultimately we ended up making it like a class. So वो virtually होता था, अभी ताज ठीक है. So I think the district team and the state team collaboration is also important. I'm seeing people engaged in the operations of this whole work and everything, and they're sitting further from this particular hub where we are discussing about the paper. But I would have actually liked Amit also joining here, Pavan also joining here, and everybody else joining here. I think that collaboration is something at least people like us love to look at that. Thank you.
Thank you so much to our presenters for presenting their very insightful papers. Now I would request Dr. Tanmay sir and Dr. Aritra Das sir to felicitate Aman Abhilash for his paper presentation. Now I request sir to please felicitate Rachna Mishra for her paper presentation. I request the chairs to please felicitate Ms. Anmol Rai for her paper presentation. Now I request Dr. Sanchita Mahapatra ma'am to please felicitate our dear chairs. With this, we have come to the end of our two-day conference. Thank you to all the distinguished guests, delegates, organizing members, sponsors, and our partners. I would like to call upon everyone for a group photograph. District team,